And under the guidance of Dr. Shubhang Aggarwal, who is the director and HOD of Orthopedics Department of NHS Hospital, we have got a lot of new things here in this hospital, and we were among the few in the country to start with robotic surgeries. And along with that, we had the pioneering effort in a lot of orthopedic surgeries innovations also, like the leadership position in sclerosis, the advanced traumatic reconstruction surgeries, pediatric orthopedics, knee replacement, hip replacement, all in robotics. So these are the major achievement of this department of NHS Hospital.
We can use the stylus to see where we are, but even we know that this cut is good. So a little bit of eyeballing is also fine. You know this is fine. You all agree? Yes?
Sir, how many mm size you are going to cut?
Sorry?
How much tibia you are going to cut now?
I'm going to cut around 8. Okay, so this is done. The PCL is nicely there. Focus, please. Focus. Table and touch up. If we see this cortical rib, can you all see this? This white line? That means there is an osteophyte behind there. Grab it, please. Yeah. It's very important to clear the posterior recess. You should be able to put your finger and feel the posterior cortex of the femur. So now basically the cuts are done. There are 9 kinds. This is the 9 spacer block. It has to go in relatively easily. So there is full extension. There is zoom out. And now when I am flexing, it is flexing well and it is reasonably snug. Even if it is a little tight at this stage, I don't mind, because whatever I do, I will be able to increase the flexion gap a bit. Right angle spike. So now we can prepare the tibia. We have used a size 5 femur, narrow. So I am going to put the limb like this. छोटू Two spike. Spike. So we can see the whole area clearly.
Yes, sir, it's clearly visible. Sir, which implant you are going to use? Smith and Nephew implant?
This is a Smith and Nephew implant.
Yes, sir. Sir, which pin would you like to insert first, lateral or medial? Or doesn't, which pin would you like to insert first in the tubal plate?
I'd like to put the lateral pin first.
Yeah.
Because the bone there is not sclerotic. So if we straighten the leg, it's quite parallel to the anterior cortex. Can you see?
So we want to see the ankle and foot. Yeah, it's visible now.
What do you want to see?
Sir, it's visible now. It's a proper alignment.
Okay.
Yes.
So we are happy with the alignment. Sure. We need to hold this a little bit. Sure. It's quite a big one. Sometimes I have shattered, not sometimes. If you are not careful, you can shatter the proximal tibia here.
So, sir, delegates want to know what precaution should be taken to prevent shattering of the proximal tibia.
So, if you find that the bone is too sclerotic, you saw it a little bit before putting this key punch. So, I also like to clear the posterior part of the tibia when I have got things here. Also, some time.
Hariom sir.
Yes, sir.
Sir, now if the knee was tight in extension, since we have taken out all the pins out, how would we have revised the distal femur cut?
What is he asking?
Sorry, you're not.
Small sounded.
Could you repeat that question?
So the question is that if the knee was tight in extension, because we have taken the distal femur cut -2, so and we have taken all the 4 cuts, how would we have revised the distal femur cut?
Dr. Nilen,
Yeah.
there is one question that
Yes.
if there is a tightness in extension,
Yes.
then how would you revise?
If it is tightness in extension and I have cut an adequate distal femoral cut, then I would do posterior release. If the distal femoral cut is not adequate, I would revise it. I would cut 2 millimeters more and then recut it. Spike. Focus, please.
Does that answer the question in the hall?
Sir, any query from the delegates? Any question from the hall? Sir, you are going to put the trial now?
Yeah, hopefully. 4.9. this is a little tight. But I'm still going to be okay. You can trial it like this, and you can also trial it like this. Punch, please.
Sir, which size of the tibial insert you have put?
So this is a 9 tibial insert. You can see that the knee is quite stable.
So, good tracking, good patellar tracking.
Good patellar tracking. The knee is still a little tight, but it is all right for me to implant the components currently. I also like to do the patella. So we look at the patella. There was a question as to how do we expose the patella? So this is around 20.
So, it was whether it is reverted, patella is reverted or it is taken on the lateral side.
I'm sorry?
The question was whether we revert the patella during the procedure, like this.
So we don't evert the patella during the procedure, but now we evert the patella. This one.
Yeah.
पटेला पे फोकस करो.
So, sir, you replace the patella in every case? Or depending upon the individuality?
I can't understand. I generally do the patella in all cases. And I want you all to be reminded of one thing.
Please speak loud.
There is no tourniquet.
Sir, what precautions you take to stop the bleeding?
What proportion?
You take for the control of bleeding. One thing, you have infiltrated the soft tissue with the noradrenaline.
So the control is that when we flex the knee, the bleeding does decrease a little bit.
So there is a question from the delegate. Dr. Nilen, there is a question from the delegate.
Yeah, tell me.
Good morning, sir. Nilen, sir, good morning, Rohan here.
Hi, Rohan, tell me.
Sir, when you feel the knee is tight now, would you carry on with the implantation and then do the post-medial release, or would you do it now only, when you feel it is tight, before implanting?
I think I would implant it because it is not too tight.
Okay.
If it was too tight, I would stop it.
So you would keep the releases for further, after implantation?
Yeah, because otherwise I'll have to redo them. I'll still probably put in the spacer block and see that I'm adequate before doing anything.
Okay, thank you.
I do the patella in a freehand manner. I normally have a wider blade than what is available here. This is done. Measure करोगे करेंगे थोड़ा ये बड़ी साइड table a touch down, please. ये थोड़ा इधर ले लेगा। So it's the two
Any other
steps to heaven.
Any query from the house? You can ask to the surgeon. Any faculty or any delegate?
This is the patellar osteotomy. अभी वो लोग तेरा पटेला करने का है ना, लगाने का है आप. So now we can just put the size like this. So this 32 looks good. ये निकाल दे इसको तो hammer करो इसको थोड़ा gently. Gently hammer. Okay. अभी ये करो, pose करो. Rest. Okay. Rest. 32 trial. Okay. Okay. No. So this is the patella. Okay. Now the beauty of the approach is that with no component, nothing, and still everything tracks well. You'll see that?
Yes, sir.
Someone was asking whether it is still tight. 9 का special block है. Component Lego pekra. So we can put this back in again. So this is nice and straight. And this is also flexing, although it's a little tight. Focus please. 18 number needle. So when this is tight, the questions are whether the MCL is tight or the PCL is tight.
Yes.
So if you find that you can't really externally rotate, then probably the MCL is tight, or otherwise the PCL is tight. 18 number needle please. So I'm just going to make a little pie crusting of the MCL. Implant लिया या नहीं लिया भाई? नेवी के साथ और सिरिंज के साथ. पल्स लगा देखिए भाई. So it's become a little easier. पहला course है क्या नहीं? तो पहला course mix करो. So now we are ready for cementing. आपको जैसा पल्स वाला करता है वैसा करो, क्योंकि मैं जनरली यूज नहीं करता हूँ. करो, ऐसा कर लेता हूँ. फिर कुछ जो करने का कर. Now we are preparing the bone. तेरा सीमेंट आ गया, भाई सीमेंट मिक्स कौन करता है? करो जरा. आठ का जाओ देना.
Dr. Nilen sir,
Yes.
just for the delegates, tell us the advantages of the sub-artist approach over the conventional medial parapatellar approach.
So the advantages first is that the patellar tracking becomes a non-issue. The second is that the recovery is much faster. The third is the femoral rotation is also probably not as critical as one would believe it to be. Fourthly, the pain that the patients get post-operatively is lesser. Fifthly, that the flexion that they achieve is higher because the patellar tracking is good. And seventhly, this is what I have been doing since last maybe 20 years, and my practice in the city of Bombay is growing.
Yes sir,
Some of the
appreciable.
competition.
Appreciable sir, appreciable. Sir, you are not using any tourniquet.
Sorry? No, there is no tourniquet.
So, what are the advantages of non-tourniquet?
Again, the pain is much lesser. To mix कर रहे हैं right hand is नहीं दिखा नहीं तेरा 4 ले 5 ले दे रहे. So now we expose the tibia again.
Dr. Nilen, how do you make the bleeding so low? It's not bleeding at all. I mean, anything pre-op that we do?
We pre-infiltrate with a little bit of saline, adrenaline and hylates.
Tranexamic acid or any blood pressure monitoring?
I normally use tranexamic acid. I don't know whether they have given it here.
Okay, what is the desirable blood pressure you want in the patient?
Blood pressure is 102.
Okay.
So, patient is being operated under regional spinal anesthesia?
No, sir, this patient is under general anesthesia. Otherwise, it's done under spinal anesthesia with a similar blood pressure.
Okay.
तो जरा ड्रिल मेरे को देना रास का तो रास दो देना.
Dr. Hariom, did you hear us?
Yes, sir, yes, sir. We appreciate that general anesthesia has been given to this patient because of the light surgery demonstration.
Yes, because their anxiety level can go up sometimes listening to all the questions and answers.
Good thought.
Hariom sir.
Yes, sir.
Sir, I have a question.
Bone quality is not very, very great. She's a 70-year-old lady. चला cement देखा भाई जरा. Somebody should be announcing the time every 30 seconds. एक मिनट.
Sir, can you ask the question?
दूसरा चम्मच है.
Give him mic.
Sir, my question is that most of the cuts sir has taken without using even the jigs, whether it was all 4 cuts, even the tibial cut. So my question is that in his hand, do he feel any further advantage of robotics into a knee replacement with these primary knees, if we are not using these jigs?
पानी डालो.
Well, that's Pandora's box that you have just.
Yeah. चल टिबिया दे दो.
I think the deliberations during the day
सर सीमेंट इधर रखो. टिबिया दे दो यार.
will
टिबिया लाओ इधर. टिबिया हाथ में दे दो. टिबिया हाथ में दे दे. अच्छा अच्छा. सीमेंट निकालो.
Dr. Nilen, sir,
हाँ जी.
most of the delegates, they feel that you have done the distal and femoral cut without jigs, with a good perfection of the eyeballing.
Yeah, I think if you keep on doing the same thing, trial insert. I don't put the final insert until the last thing.
So, first the tibia tray has been placed.
I normally put a bone block inside here. Operating in a different place also has its advantages and disadvantages. But you are getting the gist.
Sir, always the tibial implant is inserted first.
Always the tibial implant inserted first.
Any sir tip about the cementing?
I'm sorry.
Any tip about the cementing of this femoral and the tibial side?
I think with the rear steam it is better. So now this is also done. Cement थोड़ा हाथ में दे. So cement law.
Dr. Shubhang, brightness has increased again. Yeah, it's good now.
Move away the light.
It's better now.
So in fact, I don't use the cautery also. And you can see that the cautery has been utilized to remove the cement. But when I actually operate, I don't use the cautery.
Blood loss is also quite less.
Sorry?
Blood loss is also quite less.
The blood loss is quite less, yes.
So do you use drain after that?
I don't put drains, no.
Okay, no tourniquet, no drain.
Actually, I normally don't use a pulse lavage also. I have around 4 syringes of 50 cc and they alternately give me saline and I just lavage it with 50 cc of saline.
Okay, good.
But Jalandhar and Shubhang's hospital is a high-tech city.
More high-tech than Mumbai?
More high-tech than Bombay. Thank you, sir.
Sir, any DVT prophylaxis you are giving to your patients?
Yeah, I give DVT prophylaxis to all. Huh? I normally use rivaroxaban for 2 weeks and then ecosprin for another 4. But I am thinking of giving ecosprin only to all for 6 weeks.
So you have actually seen the extreme of surgery. There no tourniquet, no cautery, some cuts with hand, eyeballing, subastus approach. So the idea of the program today by Indian Arthroplasty Association is to give an overview of possibilities in arthroplasty, in total knee replacement, the evolving technologies, robotics, at the very basics, and some special techniques in manual, unconventional way of doing the conventional TKR is what you just saw. Now we are getting ready in the other OT, where we will be showing you a robotic totally replacement.
Okay, so are we done here? Thank you.
Dr. Nilen sir, last question.
Haji.
Sir, do you infiltrate anything in the soft tissue to prevent post-operative pain?
Yeah, I inject into the posterior capsule only. I would use steroid, antibiotic and local anesthesia. All my patients get an adductor canal block. I don't know whether they use it here or not.
What is that adductor canal block?
Adductor canal block is putting in a catheter in the adductor region to block the saphenous nerve. So initially I used to use femoral nerve blocks, but that would cause weakness of the quadriceps. And in fact, I have given femoral nerve blocks with a nerve stimulator to maybe 500 patients before I shifted to an adductor canal block. Now, adductor canal block can be given pre-operatively, post-operatively by using an ultrasound and finding where the femoral vessels are and putting a catheter very close to that. But currently, we are even giving direct adductor canal blocks. So here, since I have raised the quadriceps, Since I have raised the quadriceps,
In
this
his
will be
practice,
another
what are the
membrane.
contraindications
Can you
for
see it?
subbasters when he will not do a subbasters?
Okay, you have already stopped probably.
No,
Is anybody there?
we can see it, sir.
Dr. Nilen, sir,
This is the adductor membrane. I can inject here. The vessels are on the medial side. If I inject here, I'll be blocking the saphenous nerve. And we routinely do that.
yeah. Dr. Nilen, sir,
Yes,
there's one question.
yes.
Is there any condition in which you will not go for the subvastus approach?
I don't think I have not used the subvastus approach in the last maybe 15,000 knees. I always do the subvastus approach and it can always be done.
Yeah. So what about the, sir, operative time? Whether it's lesser than the conventional approach or almost the same?
I don't think I am the person to answer that because all my cases are like this only. And I don't think it takes more time. Here we have taken more time in explaining things and all, otherwise it would have been done.
So what's your antibiotic protocol?
Antibiotic protocol is, I don't know what they do it here, but I give the first day only 3 doses, 1 pre-operative and 2 doses post-op. They have given a pre-operative dose. Yeah, I don't use oral antibiotics afterwards. Somehow the cement is not setting only here.
Because we want to continue with the questions, that's the reason. So, Nilen, what is the position of the knee that you hold while the cement is setting?
I put it in full extension.
Do you put any pressure on the knee to hyperextend or just normal extension?
I mean, I'm not very, I don't really hyperextend, but I want to be sure that it is fully extending.
So anything under the foot to you like?
So I'm giving it, axial pressure.
Okay.
I'm giving it axial pressure. And whilst you ask that, let me just add, okay, according to me, the best balanced knee is, as you said, a touch of hyperextension, 1 to 2 millimeters of opening on the medial side, 2 to 3 millimeters of opening on the lateral side, patella tracking well, no lifting off of the trial insert, 1 to 2 millimeter of forward translation, but no backward sag. That to me would be the best balanced knee. Spike, please. No?
And do you put drains post-operatively?
No, we don't use drains. I actually, at this stage, I would be washing it with warm saline.
So it's very impressive that there is hardly any bleeding, but I think for most of the beginners or those who have less numbers, the bleeding is definitely more. So in your opinion, is not putting a drain a very good option?
Small option, Manuj. See, the thing is, you have to believe in something. All the evidence in the world is saying that there is no need for drains. And my personal experience of a large number of cases shows that drains are unnecessary. So I don't really use a drain.
So I have a question.
Yeah?
Sir, even if today we are not bleeding at all, but I personally have been around you, I think. And I think even if it is bleeding a lot, do you mind that bleeding, sir? Actually honestly telling me.
No, see, the thing is, tranexamic acid is a brilliant thing. And what I would do is infiltrate tranexamic acid inside here now after closing the capsule. So that will take care of the secondary hemorrhage that may occur. I would also use tranexamic acid post-op.
So, but even if intraoperatively, if you are bleeding, do you really mind that, sir? I have never seen that with you.
What have you not seen?
I'm asking, sir, even if it is bleeding a lot intraoperatively, in some of the knees, in some of the patients, I have not seen you minding that. So that's what I'm asking, intraoperatively. So today we are not bleeding at all, but even if we are bleeding a lot, do you really mind that?
No, I don't mind. Even if it is bleeding a lot, it will be
the same steps.
Same steps, but what I would do is, and what I actually do for all my patients, I keep them in around 40 degrees of flexion post-op for the first 4 hours. Here actually it is not bleeding much, but if it was bleeding, you would have seen that when you flex the knee up, the bleeding stops.
Yes.
So if you keep the knee in flexion for the first 4 hours, then the bleeding is much lesser and the blood loss also is much lesser.
Sir, is there any role of the hydrogen peroxide soakage after inserting the implants to stop bleeding?
See, hydrogen peroxide I have used earlier, but if you look at the bottle, it says that it is not sterile. 18 number. See, this is the MCL. I still find that it is a little tight. So I am going to further go a little pipe rusting. So that feels better. So there is a lot of feel and all that which is there. So when we are flexing the knee, you see there is no lift off. Can you see this?
Yes, sir.
Insert is perfectly in position. It is coming forward just a touch, 1 millimeter, and it is rock solid. It just won't go back. Yeah? So in differing degrees of flexion. So the question is, if the PCL we can preserve, then why do we want to take it out? Because the bone that is left is much more. Any further questions? Or we can now implant the final component.
So what precautions you take though so that the components don't get scratches because it's...
Yeah, very good. Small swab, saline ke saath. Yeah, that's a very good question. So you have to be aware of where the components are. You have to trust your assistants also, but don't allow anybody else to manipulate the knee. So now when I have to put the final component, I still have to expose the tibia properly. And to do that, I will again bring this here. I will put this retractor here. I will fully externally rotate the leg, fully, and bring it forward. Can you all see?
Yes, sir.
Small spike, please. I will remove all this excess cement. Small osteotomy. I have a much smaller osteotome than this, and a much smaller hammer to do all this.
This is, sir, affection from the Punjab. Mega
Sorry?
सब पंजाब में सब कुछ बड़ा होता है
वही मैं कह रहा हूँ लस्सी का ग्लव्स देख लो
पटियाला पैग पटियाला पैग
पटियाला पैग देख लो so be careful to remove all the cement, don't scratch the surface. Mop दे जरा तो तेरा इंसर्ट ला दे पंचन हम So now you can also see whether the joint line is elevated or not. So the stump of the meniscus is exactly in the same place. Yeah? So now it is closure. Any final questions?
Any question from the house?
So when we close, it
Steps in
is this to
closing.
this and everything will just fall in place. Yeah?
Sir, Dr. Nilen sir, steps in closure of the wound. Whether the closure is done in the extension position or the flexion position?
I think, see, those questions are relevant if it's a parapatellar approach. Here, since all this is intact, whether I close it in this position or this position, since it's an inverted L arthrotomy that I have made, this can only go in one place. It can't go anywhere else. So it doesn't matter how I close. Or if I close. I think maybe you guys can close my hair. No? So this is the first stitch.
Sir, great demonstration. Sir, never seen you closing for the last 10 years, sir. So happy to see it.
I know, I actually use a round body needle. All my closures are with a round body needle. There are saline towel. And I think although we don't close, my instructions are that the wound has to be irrigated. I don't use the suction that much. But the wound has to be irrigated. Don't allow the tissues to get dry. If you think in the normal circumstances, the tissues are moist. So when we are operating, firstly we have these OT lights which will dry up the tissues. We have very enthusiastic assistants who want to suck everything and keep things dry. So that's a non-physiological thing.
Sir,
So we have to irrigate.
before closure, do you recommend rinsing with betadine or any other solution, sir, or just saline?
I would use betadine. We haven't used here, but I would use betadine. I'm a little careful of the betadine when the patella is not resurfaced. It's toxic to the cartilage, so they say. But otherwise, all patients do get a little bit of betadine, lavage or whatever.
So it is repaired in one continuous stitch, no interplay sutures.
Yeah, I suture it like this only.
Sir, what is your post-operative protocol now?
Am I audible in the auditorium?
Yes, Shubhang.
Okay.
Sir.
Can we take this opportunity to thank Dr. Nilen Shah for an excellent demonstration of the subclass's knee. Sir, with your permission, can we move to the next theatre?
Sir, Dr. Nilen sir, thank you very much for such a wonderful demonstration of a sub-vastus approach. That in a very simplified manner.
Thank you
And
for having me, and I thank all the team who is present here.
it was really amazing and awesome to see surgery being performed without tourniquet and without blood loss. There were hardly any.
Thank you. Can I request the camera to shift to OT number 2?
Thank you.
Thank you, sir.
Thank you, Shubham. Chalo, now let me see what you do.
This is we end with the first live surgery.
Can we have a round of applause in the auditorium for Dr. Nilen Shah, please?
I thank all the moderators for a wonderful questions and sessions, and Dr. Nilen particularly for making this surgery look so easy, such a complex one. So, and going for the second live surgery, This is by none other than Dr. Shubhang Aggarwal. Can we have a round of applause for him? This will be on his mastery, that is robotic knee surgery. So may I request the moderators of the second live surgery session to be on the dais, please. Dr. Narendra Vaidya, Dr. Rajiv Sharma, Dr. Rakesh Rajput, Dr. Rajneesh Garg, and Dr. A.S. Pasi.
So while the cameras are getting shifted, we would like to tell you about the next patient. The next patient is a 67-year-old lady. She is admitted for bilateral knee surgery, right-sided total knee replacement and left-sided unicondylar, medial unicondylar replacement. So today we are going to do a robotic total knee here. The deformity that the patient has clinically is about 10 degrees of flexion and about 10 degrees of varus deformity. It is not correctable clinically. The range of movement is from 10 to about 21-30 degrees. So we've got 3 cameras in the OT. One will show you picture in picture the robo. One is the light mounted camera. So the moderators can please ask to switch between the light and the floor camera if needed. Am I audible in the hall, please? I see no response.
Yes, Shubhang, you're audible
Okay, great.
and visible now.
Please raise it up. Raise the camera. Tripod को ऊपर ले लो पूरा. Then camera नहीं camera height बढ़ानी है. ध्यान से please. Be careful. जल्दी मत कोई जल्दी नहीं आराम करो टच नहीं होना है. ऊपर ले लो. थोड़ा पीछे. Thank you sir. Somebody should escort sir. So right now what you can see,
Dr. Shubhang, while you are preparing, just ask the cameraman to show the positions of your robot and how you have organized for this thing and what are the components of robot.
okay. So this is the table, the cranial end, the caudal end. There are 3 trolleys. One trolley has been put extra today for additional staff. This trolley between takes care of the 20 instruments that we need for this surgery. Plus, this is a robotic and implant trolley, and that's standby for drills and other things. The robo is on the right side, in front of the surgeon. Am I audible, please?
Yes, Shubhang, you're audible.
So for the audience, I will just introduce this. This is the Cori robotic system, and it's a very portable system, and you have 3 components. One is this stand and a console. Then there is a sort of a screen which is draped and kept on the Mayo's trolley. It is like a tab, and the surgeon can operate using a tab. You don't require a big body for a big sort of a machine for this thing. And then there is an infrared sort of camera in front. The camera of Cori system is almost 4 times faster than any camera on any navigation or any robotic system present in the market. The advantage of that is the reaction time of the burr which is there, which is very fast, and then the errors which can happen absolutely are completely taken care of. So it's a very good system.
So from the audience, can we have, how many of you have seen robotic surgery? So except the faculty, of course. So maybe 5, 6 hands. So I think you can explain actually a little bit about robotic before he starts.
Okay, so we are going to start now. The approach we are going to take is a standard medial parapedal approach. Nice.
So
The
while
anesthetist in the OT today is Dr. Pooja. Ma'am is saying hi. So this is Dr. Pratik, Amit, Simran, Ankit. There we have washed up and the floor team is there. On the robotics, there is an option of the tab getting break and coming right in front, or an assistant who knows what the surgeon is saying and knows how to play video games can actually do it very easily. So starting.
So this is a handheld robotic system, the Cori and Navio. These two are handheld systems where
Sorry.
So I'll just, while you are exposing, I'll just explain them about the robot. So, actually what happens is you have the handpiece which rotates at 80,000 RPM and removes the bone. So overall, in robotics there will be 3 steps of surgery. First is the mapping, second is the planning, and third is the execution of the plan. And the advantage of robotics over navigation is that there is an execution tool which is actually performing what you are planning. Navigation also was, if you see the literature in various registries, now long-term results of navigation are seem to be better. But now this is one step beyond that, because the execution was not there in navigation, while now you have all the execution also to perfection when you are using the robotics. This is an imageless robot, so you don't have to do a CT scan of the patient. Some of the systems in the market require CT scan of the limb, and that is equal, there are literature which says that CT scan of one case is equal to 283 X-ray chest exposure, so it's quite high. And then imageless and image-based robots, you have seen that, again, literature says that there is no difference in the accuracy. So it is as accurate as the image-based.
Also, the argument would be that if you had CT scans with all the osteophytes, when you take away these osteophytes, your balance has changed. So your plan might change. So in the last case, you saw the osteophytes were there because you were doing almost like a measure dissection. In this one, you will have to first take away all the osteophytes. So that's a very important step in a robotic surgery. And then you do your planning and mapping. So you're only now dealing with soft tissues.
Can you increase the volume of the auditorium speaker in the OT so that I can hear them a little more?
The earlier view was better, Shubhang. This camera, the earlier camera view was better.
Yeah, I think he's just swapping the lens of the camera. You turn to the right camera first.
Okay.
So we need that camera, then we'll be better. So we're just doing the millisecond in routine, what you would do in a non-robotic in Wadhwa now. Are we on there?
Yes, Shubhang, yes, sir, here. Do we have a mic in the audience, Aarti? So if anybody wants a question, you can use a mic.
we are just creating space just to put the spike made on the middle side. So we are done with whatever obvious large osteophytes we could remove from the medial side. Nicholas, please. Large Nicholas. What is the packet here? Now we just remove the osteophytes of the femur. Can you show the X-ray of this patient there? So you can see the scanogram of this patient. Left column is moved. Have you got the other lens? No more. Touch me. Okay. So that you can see the X-ray.
Yes.
Yes. If you see the lateral view, she's got a lot of osteophytosis. She was advised medial uni on both sides earlier, but she didn't get the surgery done. Now she comes back, and we are now planning a uni on the left side, and we are doing on the right side. The problem has increased over the last she saw me. Okay, back to the building. So this is a robotic pin inserting sleeve. So we just put two pins on the anteromedial aspect of the femur in the incision. Okay. Yes.
Sorry? Sometimes, yes. Most of the things now in the incision. And tibia outside incision.
While I hold the sleeve in the position where I want it, the assistant puts the pins. And on the tibia side, because the smitten tibia, it has got a little longer keel. So in some patients, we put the pins like this if it's a shorter keel. But most patients, we have to go down. We approximately leave the space for the keel to come in the medulla, and then we just make a mark like this, make two stab incisions straight to the bone, and then put the sleeve in, and then we drill the tibia pins inside.
Do you put it unicortical or bicortical?
Unicortical.
Yeah, that is very important because there are reports where, you have got stress fractures. If the pins are, put bicortical, about 4% in some literature, which is quite high. And that's why you should be very careful that you should not put bicortical pins.
Yes, so this is now the array holder. You can see the array. So this is a tibia array, and the other one is a femur, which is a different shape. So each one of these has got 4 trackers, which the camera of the robo will read. So the assistant moves out of the way, and can we see the robo camera picture in picture there?
No, earlier it was better. I think the flip the cameras. You know, show the.
Enlarge the robo camera. Is it okay? Dr. Vaidya?
Actually, you should, now they are showing on the bigger screen, the robot screen. This is better at present.
This is better?
Yes, so on the left hand side you see the screen of the robot where, you know, this F and T, T, you see that is femur and tibia. You should ensure that these two are visible during the range of movement and the camera is able to detect the sensors.
So at this point, I also just take the probe and move it around so that it's, you know, in the field where I'm going to be working. So this is now, this is a checkpoint, right? It's a small magnetic spanner where we just put it out of the articulation. We put it into the bone so that the reference to the robo is given.
And you got to remember that you take this out at the end.
Sorry?
And you got to remember that you take this out at the end.
Okay, then we move to the next screen. Next. So we define the checkpoints for the femur, for the tibia, medial malleolus, lateral malleolus, center of the knee joint, center of the femur, that's knee joint colon, center of the tibial surface. Now we circumvent the hip to get a center of the hip. Okay, correct. Okay, reload, leave it, recollect.
So you've got center of the hip, you've got center of the femur, you've got center of the tibia and center of the ankle joint. So now you have all your mechanical axis. Clear?
So sometimes at this side, you know, the side support, it troubles you. So I have a green stakeholder also, but it gives position of line between the sandbag. So I don't give it to the team. Okay, can you please loosen the side support? That's it. So this green number that you see 0.7. Okay. Wherever there is a transition of the joint of the head of the femur, it will show you as an L. So what we do is less than 1 mm. Okay. Select neutral position. Correct. Any movement. Correct. Okay. Next. Let's support right again. I just use a mastoid here.
Dr. Shubhang,
Yes.
are you going to collect the joint laxity? We did not see the preferences actually. Are you doing a mechanical alignment or are you going to do the joint laxity collection?
No, I'm going to collect the joint laxity.
Okay.
In the preferences we have the PC as well. So this is we create a model of the femur now. Start please.
So this step is called as mapping. You move the probe on the surface of the femur and tibia, and it creates a three-dimensional virtual real-time image of the bone. So it tells you the size, it tells you the rotation, it tells you all the anatomical features of the that particular bone. And this is quite fast, and you don't have any radiation also, so it's very precise system. The anterior cortex of femur, what he is mapping right now, that's very important so that we don't notch or we don't have, any problem in the anterior cut.
Yes, and if you leave any, it will now tell you that you have left a point. So if you leave any points, it will show it as blue. So you can come back and just take those points. Okay. Continue. Okay, great. Now this is the femur axis that we spoke about. Take it. Yeah. So, that's the tibial connection. Start, please. Okay. Can you hold? Can you hold the foot? So you just go around the tibia, and if you take the anterior 2/3, it's not necessary to go right at the back to the back. If you take the anterior 2/3, map it, that's sufficient for the robot to calculate the slope. Unless there is a very bad postural medial grade. Okay. Continue. Okay. So that's the initial suggestion that it gives. Put the implant on. Go to joint laxity. Okay. So you can see that's the pre of deformity. It's showing a flexion deformity of 17 degrees.
Actually, ask them to show the robot output as on the bigger screen, so it will be, yes.
Okay.
And that picture in picture show what you are doing, yes.
Okay. Can you have the floor camera in the smaller screen and the robot output in the larger
Bigger
screen?
screen, yeah.
Vinay.
Yeah, that's correct, right.
Okay, can you see now? So if you see, it's showing a preoperative deformity of almost, we've released a little bit because to remove that osteophyte, it corrects some, but this is what it was. So about 17, 18 degrees of flexion and about 14, 16 degrees of varus deformity. Okay, from here we just collect, we give a lateral force and valgus strain to the knee and we collect it. Okay, can you please press the,
So,
No.
Shubhang, just go back to the previous one.
Go back.
We need to explain this screen,
Go back.
otherwise I think the
Go
audience
back.
won't follow what's happening.
Yeah,
Yeah,
collect
just
your
stay here.
phone.
So what you see so what you see, the purple one is for the lateral. What you see on the orange is for medial. So medial laxity or tightness, purple is on the lateral side, laxity or tightness. All the way arrows which are below are telling you these are tight. All the thing above will be loose. So clear? So you see the orange arrows which are coming down, it will also tell you how many millimeter. So you can see from the equator coming down like -1, -2, or 2, 3, 4. So you have that amount of tightness. So you'll even get a graphic description and you'll also get the actual numbers once the whole movement is done with varus and valgus stress.
I have put this retractor, a Z retractor. The Americans say Z retractor. So we just put it and that helps you because manually sometimes it's not possible to tension it the way it's supposed to be. So you get the accurate number. So this is the advantage of using a CORI system. You know, you can put a number to your tightness and laxity, which cannot happen in the other systems. I don't know if I'm right.
When you are doing it,
Vaidya can comment.
should the patella be in the center?
Okay,
when you are doing
next.
it?
Okay, now you see the screen, you can turn off.
It has to be like that, yeah.
Right? So it's giving you the preliminary side.
Dr. Shubhang,
Yes.
there was one query from the audience by Dr. Nilen Shah. When you took the stress range of movement, the patella should be central, or you took it when it was subluxated, or how did you take it?
I took it when it was subluxated, when I put the retractor. Otherwise it was done like this.
Yeah.
So when I did it manually, can you see? So
Yes.
this is how it was done.
The lateral side will be difficult to take with the retractor, with the patella on. So medial side of course you can do, but lateral side you can't do it.
So lateral also without the retractor, I did it with the patella, you want it, then you do it, put the retractor and stress it up. Okay, so that's the plan.
Can we see the better screen, the bigger screen on this one, so that we can explain now? Shubhang, yeah. So now you can see like what's happening. The purple side, you see that is showing in extension. It is slightly loose, in flexion, a bit more loose, And it gives you a number. So 3.8 mm loose, 1.5 mm loose. Medial side, you're looking at tightness. So in extension, you are 6.8 mm tight, and on flexion, you are 4.4 tight. So this actually gives you now a defined number as to how you want to titrate your releases or what you do with the actual surgery.
Also, there is a red sign which you see on the two screens, upper two boxes, which was there earlier. That is showing potential notching. So you should be careful about that. So what he is, can you explain what exactly you are instructing your technician?
So what I am telling the person who is handling the robo is to externally rotate the femur, right? So we rotated the femur by 3 degrees. So I like to keep that one notch because if you switch to the light camera on top, you can see that the femur is proud. If you see on the X-ray also, there are lots of osteophytes. Sometimes the femur is proud. And then if you cut it right there, it will give you the notch from the highest point, right, or the larger surface. I like to keep one point of notch, sometimes even two, and that will help us, to keep the femur as close to the femur, keep the component as close to the anterior surface. Now what happens is that sometimes you can just keep it proud and it stops the anterior patellofemoral compartment alone. Right, so we externally rotated the femur now by 3 degrees, right, and we have a 3 degree posterior slope on the tibia. The femur is flexed by about 4 degrees. It is suggested as a size 4 femur. We are going to go to size 3 femur.
So I think this is something we need to, as you work with robot, you'll understand robot always oversizes the femur. Just to make sure that you never do a wrong cut. So it invariably gives us, but when planning, sometimes it's helpful to actually oversize if you have, let's say, flexion laxity. But if you don't and you feel tightness, you can always downsize. So you can override the robot. This is in your hand. And also the slope which he's seeing 3, actual slope will be 7 because the poly itself has got 4 degree slope. So we are actually aiming for 7 degree slope.
Shubhang, this is Rajiv here. This is a very good point that you mentioned. Because in the navigated knees, in the robotic knees, the biggest problem is using the larger size of the femur. And I think it's very important to reduce it to the right size.
Yes, and so now, you've got the tightness in flexion, we are tight by about 2.3 millimeters. In extension, we are tight by about 3 millimeters. So go to femur, take superior tightness. So now we are almost equal on the tightness. So if I release further, we've done 0 release so far. So spike.
So actually what he has done is here, you can move and do virtually positioning in all 3 directions. So what he has done, if you see the that picture in picture is hiding that left side upper box. Actually that will show you a varus and valgus position of the femur. So he has taken the femur into some varus and tibia into some varus. So you see 1 degree varus in the femoral component and 2 degrees in the tibial component. So combined varus of 3 degrees, and he has almost corrected all the tightness. So you don't need to release do a massive release or a sort of unmonitored release here. Just to remove the meniscus, and this 2 millimeter tightness on the medial side is taken care of.
And when you see the osteophytes being cut from the back, you will see that even this 2.5 is actually gone.
Now and we go back to joint laxity again. Okay. Now, see, wait, please wait. Now we go back to the laxity after the release that we have done, and we see how it is, correct? So, we've ended up correcting our medial side tightness. You can see the orange line going closer to 0, right? And lateral remains the same. That's it. Okay, go back to planning. Next. Okay. So, without doing any more cuts, we've almost corrected our tightness on the medial side. Now you can inferiorize your femur again. What is the eyebrow? So I had taken the femur superior, I had planned it to be put 1 mm superior, but I'm bringing it down. Now if you see people who do major dissection, there is 8.5 millimeters of cut being taken on the distal lateral side and 8 millimeters being taken on the distal medial side. Bring it down further. One. Now this is what, now externally rotate. One more. That's it. 8. Just to check the notch, I will go 2 points up. Yeah, go back 2 points down. That's it. Now, if I want to close my flexion gap alone, I can show the on the femur. This is just to demonstrate. So, if I flex the femur, flex it. This is 4 degrees flexion. Flex it further. Let's say make it 6 degrees. So, if you see, you can see the flexion gap closes here. Go back to 4. That's it. So this is my plan. We are a little lax in extension. We can give 1 degree more whereas that will take care of it. So you go. Yes. Okay. I think we can. No, we're doing a little release after the cuts. So I think we are going to accept this plan. What do you say, Dr. Vaidya?
Yeah, looks good. On the rotation side, I think one thing I would like to explain, this external rotation 4 means that actually he is rotated at the 7 degrees because 0 degree means actually 3 degrees external rotation. So the interpretation of this screen should be done like that. And actually it is the tracking also, it improves after, externally rotating it. Against the, so many times you keep it neutral also, so many times you tweak with this rotation of the femur, and that is a great advantage of using the robot. Because all the patients we are giving, 3 degrees of external rotation as a set this thing, irrespective of their anatomy. But now we can actually assess it and plan it accordingly.
Okay, so next screen please. Now we select the cut here, make it distal cut. We can use it, go back, just for the audience, you have 3 options. You have 3 options how to cut the femur. So you can use an all burr where you just close your eyes, put the robotic handpiece, and it takes away whatever you have planned without any fault at all. Or you can do a cut guide. Yes, press the cut guide. If you do the cut guide, you can actually show me the cut guide. If you do the cut guide, you can actually become closer to it's in the transition phase. You can actually use the cut guide method, where you get an orientation, the robo will help you place the jig. Then you take a saw cut. Once you take the saw cut, then you can go back to all burr and then take away whatever bone is left behind. But we are going to do a distal cut, region distal, where we will cut the distal part of the bone. The distal cut will be taken robotically, and then it will place the jig to help us take the anterior and the sham. Select. Next. Checkpoint. Wait. Okay. So we just verify that nothing has moved. Yeah, so we have moved. So redefine checkpoint. Yes. Yes. Okay. So can you see the screen? Can you zoom on the robotic screen? First we start here.
So Shubhang, you continue to cut. I think I like Dr. Vaidya explain what these different colors are.
Yes.
So this is a virtual image of the cartilage being taken off. The red color is 3 millimeters or more, blue is 2 millimeters, green is 1, and white is where we want to go. So, this burr is a 12 millimeters burr, rotates at about 80,000 RPM. And it's really fast. You can see that he has almost completed the lateral condyle of the femur. And it is very safe. You can, this mode which he is using, you can use it in 2 modes. One is the exposure control where the burr, retracts itself if it is out of the zone of cutting, out of the cutting zone, or it goes deeper, it prevents, it retracts. So it is very safe and very, you can say, accurate. The second mode is a speed control, where you can use that mode also in some tight parts of the knee joint, where the burr will stop rotating. Here in exposure control, burr continues to move inside the sleeve and retracts if you are out.
Yes. So we are done with the distal cut already.
So it took hardly less than 1 minute. Means there is a lot of apprehension that burring will take a lot of time, but you can see that it hardly, almost the time equal to the saw, he could complete the distal cut.
Okay, so now I just wanted to show, now you see these red marks here. The red marks is like, it will not cut, but if I put it here, it will show me that you are going wrong, boss. No need to go there, it's already done. So it will show me the marking where I am touching, but it will not cut any bone or take away anything. Now, if you see the target there, the green is the front of the handpiece, and blue is the back of the handpiece. Okay?
So that's the video game part.
In this sclerotic bone, you must be putting more effort, I'm sure. It must be taking more time. Now, this looks like a soft bone, but in another patient who's male patient with a severe varus, sclerotic, stone-like bone, I'm sure that must be taking more time than this.
Now, if you see,
Actually, the Navio system, you are right, it used to take some more time, effort, but the handpiece and the burr which is there, and it's a deeper burr, it's really not, we don't require much effort.
now we just confirm that in the center, you can see this here, it's exactly, it's some millimetric accuracy. Not this one, just cut standard. Yes. So we can do this. Yeah. So just to make the course, what we can do is, this is a 45 millimeter punch available. So just make it, and we can remove it. It creates, see exact. This is your standard jig for legion. So it's already created the holes for it. We just put it with the hand, just to get the feel and to show you. We tap it. Conventionally.
Dr. Shubhang, before putting this, please show the accuracy of the cut. You can use the angel wing and show this how the cut is accurate.
Yeah, that's what I was going to do, sir. So if you see like this, can you come onto the light camera? Swap it. Come to the light camera.
No, use the distal cut. We want to see the accuracy of the distal cut. So you remove this and show the digital angel wing, and yeah, correct. So every cut you can verify and refine if required. So, and you can see even if it is burred, it is absolutely like a smooth and absolutely like a saw cut. So this is the digital angel wing, and you can see that it's a sub-millimeter accuracy is there.
Yeah, so it is less than 1 millimeter. Actually, it's 0.1 millimeter, 0.1, 0.2, and it is 0.1 degree. So that's some high point anywhere. If you want to take that out, because sometimes we just leave it in the notch, that gives you this feeling. Graph, please. So we can just use the rasp like this, and it takes away clear the notch just to show. But it will not really make a difference to placement of the jig. That's how it is. Okay. So we put the jig back. So we've already checked it with the conventional angel wing, and if you see, there is no notching at all. In spite of having that red mark there is no notching. And we can show you this with the digital angel wing now. So that's the accuracy. Are we clear?
Yes.
Yes. Take a next, please. Okay, now this cut is being taken by the saw. So can you come in, please? Okay, now we would like to see that the accuracy of the cut with the saw will come out. Visualize cut. Okay, it's come out well. Okay, but if we want to still, make sure that we have not missed anything. But can you go to bar all? Then one of you hold the femur here. Okay, refine. Yes. So, can you show the anterior part? Now you see, this is what it looks. It looks good, but as per the plan, we still have the bone left there. You get the green is of almost 3 millimeters of bone, 2 to 3 millimeters of bone. Okay, so now we are going to use the burr and good burr. Start please. Just the surface is getting removed. That will give you a perfect fit of your box preparation. What is the femur, please? Good morning. So the blades can spray and they can leave a part of the bone. The jigs can move in spite of your pins. You put 1, 2, 3 pins, still they can move. And you will keep on going, taking the cuts. That's it. Okay. That's it. So it didn't make any difference visibly, but it has made a lot of difference in millimeters there. Yeah. So this is the side. Now we are doing a more narrow. In this. Okay. First preparation. Hold it. So Smith and Nephew has been kind enough not to provide the replacement mill here. Not to provide is the emphasis. Okay? They test the mind of surgeons in Jalandhar. I hope the message is loud and clear. So we prepare the box. Now to prepare the tibia, it is possible to leave this in and flex the knee and do this. But I like to remove it. So sorry. Please take the trial is down. So the trial is down, but we are using a 4 narrow. Right. Give me. Can you open the other set and give us a 4 narrow trial? 4 narrow trial. Spike. Okay. Forceps.
Can I ask a question, Dr. Vaidya?
Yeah, sure. Yes. Mike.
It's about the gap collection step. So it's about the gap collection step during registration. Did you release the PCL while you were collecting the gaps, or you did it without resecting the PCL?
No, I resected the PCL, sir. I've just created a little more space here now.
So did you resect the PCL earlier?
Yes, sir. I did resect the PCL earlier.
Okay.
Yeah. Now, so what we are going to do is one more trick here.
Just change the camera again. This view is not very, we cannot appreciate what you are doing. Ask them to, not from the light camera, from the...
Told us he has done many CMEs, but...
switch on to the floor camera, not on the light camera.
I think they have some technical issue there. They are correcting. In the meanwhile, can you show me that? Can you straighten the ticket? Straighten the ticket and show me.
Shubhang, in that case, the light one, you make it big.
Yeah, In the meanwhile, light camera can come in. Visualize cut pe jao. In the okay.
So what he is trying to do is take a tentative cut. This is not the final cut he is aiming. With a jig, he will remove the sclerotic bone on the top of the tibia and then refine it.
This can be done even without the second.
Yes.
You can do it freehand and then
Yes.
move on to the rope.
Yes.
But freehand, probably you can commit a mistake of cutting too much and we may not be as accurate. I think it's a better idea to put some jig and have some assessment.
You can't go below the defect. You just remain above that. You won't be doing anything wrong.
Right.
Are we on? The camera is on?
Yeah. Yes.
So what I'm doing now, as you said, sir, it's a tentative cut. So I'm going to leave some bone behind to be sure that we cut it accurately with the burr. Okay. So that's just about 4 millimeters or 3 millimeters of bone will be left behind. It's planned proud full time.
Now it is a better view.
Okay. Sit down, please. Yes, now you can see the top surface of the bone here. Am I audible?
Yes.
Okay. So you just move the spike out of the way. You can refine it or we can just go straight away also. Okay, start please. Now it's removing the bone that it had planned. Can you place it down? थोड़ा सा नीचे कर दो. नीचे surface दिखा. No, don't touch the camera. Yes, नीचे put your hand up here. Rotate it to the right. Yes. Okay. Inevitably, your saw will splay, the blade will splay upwards. This is one way of doing it, or the other thing is just to make a trough like this here, both anteriorly, anteromedial and anterolateral. And in that trough, you just take a tentative cut and everything comes up. And then you can just go down and burr it. So if I just do this here, it's showing me red not to go there.
While doing this, only one precaution that it doesn't see the soft tissues, the burr. And that's why, you should be careful in the anterolateral side where your patellar tendon is there. You should be very careful. Otherwise, the burr can damage sometimes the patellar tendon. Similarly, when you are doing tibia, it will not see the femur. And so when you are on the posterior lateral side, it can just remove some bone from the posterior condyle of the femur. So you should be careful in these two things, that the burr, when it is doing tibial work, it will not see femur. So you should be careful in that.
Okay. 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 That's it. Can you give me what is the size that you plan? Okay. Give me a size to begin. So that's a size to figure fit. little, please. Okay. Give your size good. So we can check it again with the digital angel wing. Visualize cut, please. Yeah, so that's the cut. You can see now that's the cut. So it's perfectly zeros. Okay, the burr has taken away exactly what we wanted to remove. Yes. Yes. Okay, good.
Shubham, the rotation of the tibial tree is your assessment, or do you check it up as well?
Well, in this particular case, it is assessment. What we can do is robotically do it. So I have to mark special points earlier on the tibial tuberosity and then rotate it to that. Okay. Give me a full turn now. Leave it. Remove everything. Spread up. So like up here, whatever is the remnant of meniscus left behind by me earlier. Sometimes there are osteophytes. If you see on the lateral view there, okay, there are 3-4 small osteophytes there, which we now remove. Okay, curate please. Curate. Okay. There. Give me a small please. Okay, so we are doing now. Give me a full trial.
That is like a tab. एक tab आता है कि जो आप खुद कंट्रोल कर सकते हो या तो there is a screen also which a technician can control. I use my own tab. मैं उस पहले पे उधर रख दिया. खुद अच्छा लगता है.
Please put down. Yes. Hammer. Hammer. Okay. So we had planned for a 2-9 spacer. That is what it is. Can you come out? Checkpoint please. I'm just verifying the checkpoints again, that in case your tracker has moved or anything, then it will tell you. Okay, no. So that's the correction we have. So we planned for a 4-degree varus. That's what you have. And what the robo shows as 5 to 6 degrees actually is clinically zero correction. That is the feeling. Any comments on that, Dr. Vaidya?
See, it is always better if you are using robotics to keep the, the flexion here about 5 to 6 degrees, because this depends on your mapping of the points also. If you map the ankle malleoli slightly posteriorly or anteriorly, this flexion will change. So don't try to go to zero flexion. Always keep it in 5 degrees flexion.
So this is what we planned. You can see the final graph start with
See, it is
perfectly tracking and fully corrected. You can see that opening on the lateral side. That's what
yes.
Dr. Shubhang, can you show us the extension without touching the knee with your left hand?
Yes, this is it.
So, how much is that?
It is showing 10 degree, but if I just press it like this, it's showing 6 to 7 without using force. By using force, I can bring it to 0.
No, but you can't use force actually.
Yes, you can't use force.
To my
this is trial. Once we wash it and clean it, I'm sure that this will come back to 5 to 6 what we planned.
Shubhang, do you also assess by the finger the tightness of the MCL on the medial side?
Yes.
Because that also will tell you if it is a elastic tightness, then you will say that yes, this joint is okay.
So that's how we were trained conventionally.
Right.
Now if you look at, can you please retract here? Focus here. Now you see that's the MCL, and it's not, you can see that in flexion there's a little opening, and anyway that is showing, Dr. Rajiv, welcome, and that is showing almost 1 millimeter of laxity. So anything above the line is laxity. They're showing 1 millimeter of laxity on the medial side, and it's just what we want conventionally.
Actually, this is, if you see this, then the lateral compartment is a bit lax. That is what is recommended now, that you should have 1 or 2 millimeters laxity in extension in lateral compartment, and probably a millimeter more in flexion, so that the movements are more physiological. And that is what has been actually achieved here.
That is very right. If you have too tight a joint, then it is rather a problem.
I think what's more important is that, when there's a surgeon and there are 2 assistants, it's always the surgeon who is right. Whereas if you see the screen, surgeon cannot cheat. Even the assistant can see whether the surgeon has got it right or not. So this is a more, I would say, pragmatic approach to a laxity, inflection, extension, lateral, medial, which the boss is always right is not true anymore.
Dr. Vaidya, one question for you. When we are collecting the flexion and extension gaps, in a fixed flexion deformity, say about 20 degrees, and the machine is showing the extension gap as, say, 2 millimeter or 3 millimeter, whatever the reading comes over there. Is that the extension gap at that deformity, or it is at 0 degree?
It is at that deformity.
So then if it is at that deformity, that doesn't depict the gaps at 0 degree. So
yeah, you will have to take some more bone from the distal bone.
This is what I mean to say.
Yes, distal femur you have to. See, basically robot doesn't change the principles of conventional surgery. Like, if the knee is tight in extension, then you need to remove some bone, if posterior release is not enough, then you need to remove some bone from the distal femur.
Yes.
If there is a tightness in flexion, then you have to, if you are doing anti-referencing, then you have to, undersize it. So these basic principles don't change. Robot is a tool to get whatever you are planning to perfection, the planning, mapping and execution to perfection. So there is no sort of imagination left there. We saw here that he did a ligament release, which was very judicious, and because I think there is no measure for words like adequate or something like that. Do an adequate release. What is adequate? For adequate maybe, or feel. These are very subjective things.
Yes.
The robot brings in objectivity, gives a number to everything you are doing and measures it, and it is a evidence-based sort of thing, like Dr. Rakesh said.
So if you have to do this knee, will you go a little bit higher up on the femur?
Yeah, I think, I don't know if he has released the posterior capsule.
He has done that already.
Already done.
Yeah, so I think, I did go in the planning 1 millimeter up, and I saw this completely lax, and I brought it back, the femur back down. Now we are just talking about the patella right now. So we are going to replace the patella here. Now we are using this jig. We measure it with the vernier. This is showing a 24 measure thickness of the patella before cutting. And then we use the jig and we remove 8.5 millimeters from the top. Can you hold this please? Don't touch this please. Hold it. Come closer. Yes, hold that. With 2 hands. Okay. That's the cut, and we measured it again. So we have 15 millimeters left behind. Right? Can you give me a proper? Okay. Right. Last. Just take that cartilage away. Patella cycle. So this rasp with the cori is nice. It's like a grater in the kitchen, and it takes away the cartilage very well. I was going to say that just now. Okay. So we size it to 29. We just mark it. So there is a horizontal line here which is going to coincide with the 2 marks on the patella jig, so that there is no rotational error and there is no uncoupling. Wait. Okay. Take final component. Take final component. Take 7. Okay. So I just hold it and my assistant drills it. Can you put a 3.2 drill? So on the lateral ridge, it's very sclerotic most of the time, and the patella jig doesn't negotiate that straight away. And instead of using a lot of force and displacing what you are holding, what I do is just make a small hole and re-point with the 3.2 drill bit, and then change the drill back to patella. It makes life very easy. Okay, small drill please. Just taking the cartilage off. Okay, that's the patella trial button, and it's fitting well. Now there are 2 jigs that we use. One is a Smith & Nephew ultra big jig, which is quite cumbersome and it can actually move a little bit. The other one is another jig that we have, which is lighter and easier to use. Okay. That again. One section on please. Injection. So we use a cocktail here and the 7-point injection. The antibiotic prophylaxis we gave is a Magnex at incision with 1 gram of tranexamic acid. Start mixing please. You don't need a bone block. The bar suction is on. Let me go from there, please quickly. Give your hand. Yes, okay. That means, sir, I already said that.
Shubhang, we are running about an hour late. Do you want us to wait till the implantation?
Sorry?
We are running about an hour late.
Yeah, please, you can, we are just going to cement it, so you can start the session, please. Thank you so much.
Okay.
Thank you, Dr. Shubhang, for the excellent demonstration.
Shubhang, one last
Big
thing.
round of applause for him.
Shubhang, one last thing. Can you show us with the spacer, just before you put in the cement, if you have a half a minute?
Yeah, that's how I've already put it, but I'll show it to you.
Yeah.
Remove this, please. Spacer. That's a 9 trial.
Okay.
The spacer block. This is what you want to see?
Right.
Okay, so we just put this. It's going smooth. And that's the full extension. If you want, you can bring the camera here. Or to the side.
Yeah, it looks okay. Right. Thank you, Shubhang. It was a wonderful presentation.
Yeah, just going to show you from the side and then you can close the...
Right. Yeah.
Bring it down.
Yes, it is quite straight. Yeah. Right.
दीवार के साथ चले जाओ, कैमरा नीचे ले, कैमरा नीचे ले आइए.
Shubhang, thank you so much. A wonderful surgical demonstration.
Right, thank you.
Just one last thing before we move on from here. So the flexion which this shows is not very accurate, which mimics with the clinical flexion, and also the internal external rotation. That bit somehow still doesn't mimic. So there are still, I think, a few more improvements which can happen even with robotics.
Thank you. I think you can announce for the next session.
Is Dr. Sharma here?
Yeah.
So, sir, we'll hand it back to you.
Yes. Can we have a big round of applause? I thank the moderators for giving such a big interactive kind of discussions for this topic. And I also thank Dr. Shubhang Aggarwal for such a eloquent presentation of such a precise technique. It was really wonderful to watch this precise movement in this knee replacement. And for the next session, we are going to have now knee talks. It will be a set of various lectures on the different topics. May have the privilege of inviting on the dais the chairpersons for this knee session, Dr. Dalwans Pandher, Dr. Davinder Lal, Dr. Suneet Aggarwal, and Dr. R.R. Sagar.
Dr. Sagar has not come because he is not well, he has developed fever. So I hope he avoids.
Okay. Then can I request the other people, Dr. Suneet Aggarwal, Karan Satish.
Keep recording it, but live switch to the auditorium.
Jaswinder, can you help us?
Keep recording it. इसको बात समझ नहीं आती, इसको समझा. तो आपका कैमरा नीचे आ गया है.
Dr. R.R. Sagar, Karan Satish. Do you have the chairpersons? Yeah. Your name. Your name. Yeah. The first presentation will be by Dr. Manuj Wadhwa on the management of FFD and recurvatum. Please, sir.
Good morning, chairpersons, and thank you, Shubhang. I think you'll be in the OR, but for organizing this wonderful IAA-NHS workshop on total knee arthroplasty. My apologies for jumping in a bit earlier because I have certain commitments to follow through, and in the next couple of minutes, we'll be speaking of an important topic. RK, I know this is your favorite one. The management of fixed flexion deformity and recurvatum, getting the straight and right. So these are all complex deformities, one of the toughest ones in the OR to get through, especially the moment you have recurvatum, you have split going across your spine. So talking of this correction of fixed flexion deformities, the residual flexion contractures are the biggest problem because they give a poor functional demand, higher amount of energy of quadriceps getting through. Though there is a controversy on how much, we were discussing in robotics also, how much to leave on the table. So many times in inflammatory cases, we leave a bit 10 degrees thinking it will stretch out. But the best part is if you can neutralize the leg on the table. And it is important and essential that we correct these deformities on the table and do not leave anything to the future to be get sorted out with time. So fixed flexion deformities, you get pictures like this, a kid at 17 or 18, rheumatoid, with this kind of a gait, tried all conservative parameters. When you're going to move through in, there are a lot of issues, what kind of a tightness you're going to be getting through and what you need to be correcting on table. Because it's not purely the bone, it's a bone and a soft tissue combination that moves in tandem. So the assessment that we move through is, assessment is what are the tight structures we need to manage in these scenarios. So whenever we have these clinical assessment scenarios, the first thing is what is the diagnosis you can reach on to, whether it's an osteoarthritic, inflammatory or a non-inflammatory, any intra-articular or extra-articular deformities you have through, and the associated the varus and the valgus that goes across with that. Many times FFD with the acute varus deformity or FFD with valgus, the protocols are different. And equally, in a very delayed cases, what is the status of extensor apparatus? So all these three things need to be kept in mind. The structures that we get through are the adhesions, basically the obliteration of the posterior recess that you will get through. There are osteophytes anteriorly, which cause mechanical block. There are osteophytes at the back of the femur and the tibia that cause a capsular tenting. So equally we have tight hamstrings and there is a tight posterior curtain which needs to be addressed in these scenarios. So in all these varus and valgus deformities that go along with them, many times you have a posterior subluxation of the tibia also. The bone becomes softer, stiffness reduces, and what you have is a chicken leg femur, a consideration, very important, when you are using a non-robotic or a non-navigated surgery, whether you are going to use posterior condylar axis alone as your benchmark for referencing, and at the same time, how are you going to size your femurs? So beware of posterior referencing in all these kind of clinical scenarios alone. So grading of flexion deformity defines what kind of a steps you are going to take across for the correction. The Lombardi classification of 1, 2, 3 or severe deformities more than 60 degrees, the protocols are clear whether it is in any of these formats. You need to be clear on what you're going to release, what are the kind of implant systems you need to have on the table for correcting these deformities. So a lot of these deformities, when you see them in the pre-op stage, the moment you give them anesthesia, a lot gets corrected. So normally they're not as horrific as you would see a 60 or 70. You give them anesthesia, the same 60 goes down to 30 in a lot of those scenarios. So stage 1 is the easier part. You take off the osteophytes at the back of the femur, back of the tibia, release the posterior capsule, and just a CR or a PS, whatever philosophy you believe on, should let you cross these kind of scenarios. So when you have a corneal plane varus or a valgus going along with, there is no correlation or definitive correlation between the degree of flexion contracture and the contracture of ML structures. So you need to be now equally looking in. I have to correct the FFD, I have to correct the corneal plane deformity also, and both things will go hand in hand. So grade 2, 30 to 35 degrees of flexion contractures, you reject the posterior osteophytes and then you go on to the capsule. So these are the cases where a capsule also requires to be released from the back of the femur and the back of the tibia. And a lot of surgeons at this stage would like to have a PS knee alone to circumvent these. When we do a very high volume of CR, I would still love to do a CR. But anyways, for a normal message to go through, PS is the easier part to bail these options. And you need to release the posteromedial and the posterolateral corners. So femoral capsulectomy, so you release from the back of the femur, use a gauze and go across on the posteromedial side, posterolateral side, come back in on the tibial side, go at the back of the tibia and release the capsule. Normally, this capsulectomy should work up. So many times you have to move to the other step, which is resecting the capsule. Now this is an important part. If you believe in resecting the capsule, that has to be taken with a bit of caution. You need to put up the laminar spreaders. Your control of a bovie or a blade, whatever you use through, has to be very, very precise. And you need to save the MCL, the LCL, and the popliteus. So the balancing gap, when the moment you release these capsules, is you have couple of times of flexion gap going bigger than the extension gap. So you need to look into the sizing and the recession in these cases. And as an end point, as we saw in the last couple of surgeries, you need to have symmetric flexion extension gaps. So the moment you do a posterior release, the concern is the flexion instability that gives through, or many times when you have a flexion extension gap mismatch, the kind of constraint we need to add up to circumvent these cases. Also, while we talk about the tight osteophytes, we talk about the tight posterior capsule. The semimenosis is also tight. This also requires a release in a lot of cases. So we discussed, Dr. Avatar was speaking about this FFD correction with the additional distal femoral resection. So if you still have a tight extension gap, you have tried all those parameters, you have no choice than to fall back upon resect around 2 millimeters of extra distal femur, navigated, non-navigated, whatever procedure you want to move through, and approximately 2 mm of every correction would correct 15 degrees of flexion contracture. But you have a caveat, you can't go more than 4 or 5 millimeters of additional section, else you will have a patella baha and a back patellofemoral tracking to move, and your physiology will be compromised. So while at the same time, when you are doing these sections, you have to be very careful. You do not want to give the patient a mid-flexion instability or a quad laxity. So alignment, without trials, you put in spacers, you need a judicious balance of both things. You want to maintain the joint length as well as the minimum amount of constraint in the implant you move through. I've seen a lot of people, I corrected an 80-degree flexion contracture just using a hinge. So that's too radical an option. You have to go through the steps. Yes, hinge can be required, but that has to be the last step. So grade 3 are the real caveats that we need to look in. There, bone resection versus soft tissue dilemma. So what to choose, or maybe a equal balance of both things going hand in hand. A sequential extensive soft tissue release of the posterior capsule from the back of the femur, the back of the tibia. So you do a section, check on extension gap. If it is tight, still tight, you move back in and do an additional 2 to 4 millimeters of distal femoral section. So at this stage, you would get an equal flexion extension gap restoration. So if still not there, you have to do a posterior capsulotomy in extension. But if you do a posterior capsulotomy, the U-shaped curtain has to be kept in mind because you have posterior neurovascular bundles. It's not that easy. As we keep reading on text, you need to be very, very careful if you believe in this philosophy. So in a lot of inflammatory conditions, despite every correction, what you still leave behind is around 10 to 15 degrees of FFD. If it is an inflammatory condition, you can leave it as such because that is still a better option than to cause a compromise of the neurovascular structures. A lot of studies today say that you correct these things and ideally you should achieve a full correction. But if in certain situations like this, that was a pre-op on the left, a week post-op, you were around 10 degrees of FFD, you do bracing and a stretching and a rehab, it corrects to full normal. So modest amount of correction, 5 to 10 degrees in inflammatory conditions does get corrected with time, but that's a last resort to accept through as a challenge. At the same time, leave it in 10-degree flexion, let it stretch out, but do not overstretch on the table in osteoporotic bones, because what you do not want to have is just supracondylar fractures and then going on with plating in these scenarios. CR devices can be used in stage 1, stage 2 lombardic classification. In grade 3, many times you have to reach the PCL with the bone block. So 1, 2 and 3 does work on, but as a majority, CR only for stage 1 and 2, else move on to PS if you are not a very high CR user. So the level of constraint is equally very important. The minimally constraint for stage 1 for grade 2, 3 or beyond posterior stabilized devices. So the rhythm is very clear. Do a posterior recess, do a posterior capsule release. You can go on to additional distal femoral resection and appropriate amount of constraint and stability only in severe cases. A line or two on the hyperextension deformity, that is when alignment in the coronal plane goes beyond a 0. You have a recurvatum that needs to be corrected. One of the worst things to handle across for even the expert of the surgeons, and my front panelists and the chairpersons would agree that this is one deformity. Once a recurvatum gradually comes back to a recurvatum. So be very, very cautious and never ever leave these knees into say 1 or 2D recurvatum, because they will always stretch further. And that's one of the worst things to go through. Your cause can be a malnutted post-traumatic fracture or a post-fractured HTO or neuropathic conditions. Neuropathic have the worst outcomes in these scenarios, or a failed TKR. So these are the pictures that you get through on table. These are the kind of recurvatums, and they're always very, very troublesome to handle. So when you correct these deformities, they turn back to normal, but you have to be judicious, balance of soft tissues as well as the amount of constraint you're going to get through. So the idea for handling this is, in the initial stage, if you're going non-navigated, minimal proximal tibial section, minimal distal femoral section. You can always come back and increase it, but once you make it a normal cuts, it becomes very problematic to come back without using a hinge. So the is on the side of overcorrection of hyperextension. That means leave in 5 degrees of FFD rather than leaving it in neutral or a hyperextended condition. So for the majority of these non-paralytic conditions, your PS implant will work, jumping on as a backup to the varus valgus constraint. But all paralytic conditions and a very severe flexion extension gap imbalance, you have no choice then to use rotating hinges. So the key points to remember are: do a soft tissue balance, minimal bony resection, and minimal amount of constraint, whatever is required for these conditions. That's a similar neuromuscular condition. Just use a hinge and you are off it. So all these kind of post-traumatic extra-articular deformities, just a simple system, this was navigated at that stage. The last slide across. So the collateral frame needs to be protected. Your constraint devices need to be used only when actually needed for. So attention to alignment and balancing enables full correction of your deformities, restoration of stability with usage of very optimal kind of constraint if your collaterals are intact. Thank you so much. It's a big topic. I wanted to just comprehend it onto the very, very basic points to remember through.
Thank you, Manuj. I think the time is a real constraint. That's what I am told.
Yeah.
So only one small comment on this. Fixed flexion deformities are very difficult deformities to be corrected. The direct release of the posterior capsule is, especially on the medial side, is okay, but not on the lateral side. So anywhere beyond center to lateral should be avoided. Just the posteromedial is okay. All right. And I think how much distal femoral bone to be cut, you have to be careful that you don't damage the beyond 4 millimeter. You have very rightly mentioned. Thank you so much. A wonderfully explained situation. Right.
Thanks, Rajiv. Thank you.
M.Ch. Aggarwal ko. Next.
Thanks, Dr. Wadhwa. It was a very nice presentation. So may I request for the next presentation by Dr. Shubhang Aggarwal. He'll be speaking on limb alignment and kinematics. Dr. Shubhang Aggarwal, please. Sure, sir.
Thank you, sir. Thank you. So, respected chairpersons, respected my seniors, my mentors, dear friends and colleagues, I bring greeting from Royal City of Patiala. So first of all, I am thankful to you, to Dr. Shubhang Aggarwal, for taking such a great initiative for the live surgery workshop on the arthroplasty, and that too by the stalwarts of the country. And just now you have seen two wonderful surgeries being performed by two different techniques by the stalwarts of the orthopedics, and the basic purpose of different techniques is the limb alignment and kinematics. The success of the surgery depends upon the restoration of the knee to the neutral alignment in the post-operative stage. All the three components, femoral component, tibial component and the patellar component, they should be aligned in the native position to give the normal alignment to the knee joint. That's the basic purpose of any technique for doing replacement. So the aim of the total knee replacement is to achieve the excellent alignment of the femoral, tibial and the patellar components with the ultimate restoration of the patient's lower extremity to the neutral position. Proper alignment of the knee is considered to be the one of the most factor in determining the long-term outcome after the knee replacement. Advantage of the proper limb alignment is it decreases both the mechanical and the shear stress placed on the bearing surface, both on the bone as well as on the prosthesis, and it balances the forces transmitted through the soft tissue, which is crucial for the suitable functioning of the joints. That's why everybody was now talking about the medial and the lateral balancing and the tissue alignment. Now, what is the disadvantage of the poorly aligned component? If the knee components are poorly aligned, it leads to decreased implant survivorship due to increased wear, poor functional outcome, and the early failure leading to the component loosening. Now, what is kinematic alignment in the knee replacement? The word kinematics means kinesis, that is the motion of the objects. Kinematic alignment is a customized method of positioning a knee replacement with the aim of restoring the native pre-arthritic joint and rotational axis of a patient's knee. And the aim of the kinematic alignment is to restore the pre-arthritic alignment of the knee, to restore the pre-arthritic knee joint orientation, to restore all three kinematic axes of the native knee. I will tell you that there are three kinematic axes, and by that too by positioning the femoral and the tibial components. So ultimately the resurfacing of the knee joint is done in such a way that implant thickness replaces the exact amount of the bone plus the cartilage that have been removed during the procedure. What are the three alignment axes of the native knee? They are vertical axis, mechanical axis, and this is the vertical axis. It is on the normal weight bearing AP view, the vertical line extends from the center of the pubic symphysis up to the midline of the both ankle, and this is the mechanical axis which starts from the center of the head, determined by a line drawn from the center of the head to the intercondylar notch of the distal femur, then to the center of the ankle joint. And anatomical axis, this is the anatomical axis, it is intramedullary axis in relation to the intermedullary canal of the femur and the tibia. Anatomical axis of the femur and tibia, they are not in one line, they are angled with each other. But the mechanical and the anatomical axis of the tibia, they are parallel to each other. So in the normal knee alignment, there is a angle between the anatomical axis of the femur and the mechanical axis of the femur. This is known as the femoral tibial angle, and this is about 6 degrees. And the normal knee joint line alignment is about 3 degrees varus. As you can see in this picture, that there is a lateral distal femoral angle of about 81 degrees and in relation to the anatomical axis, and it is 87 degrees in relation to the mechanical axis. But the medial proximal tibial angle remains almost the same, 87 degrees in relation to both mechanical as well as anatomical axis. So now what is mechanical alignment? It aims to position both the femoral as well as tibial components perpendicular to the mechanical axis. These are the both components, they have been placed at perpendicular to the mechanical axis, so that we are able to obtain hip, knee and ankle axis of 180 degree, which we measure with the alignment rod. Then there are kinematic alignment axis. They are different than the, now what I have told you about the anatomical and the mechanical axis. And these are the three functional kinematic axes about which the knee rotates. And what are these three kinematic axes? There is a transverse transapicondylar axis, transverse axis in the femur, and there is a longitudinal axis in the tibia. Kinematic axis, they intend to mimic the dynamic movement of the knee. And what are these three kinematic axis? There is one primary axis, that is transverse transapicondylar axis. This one is the transverse transapicondylar axis. It passes through the center of a circle which fit to the articular surface of the femoral condyle. This is the articular surface of the femoral condyle. It fits over here, and tibia flexes and extends around this axis. And second one is the transverse axis. This is transverse axis in the femur. Patella flexes around this joint. And third one is the longitudinal axis. And this is in line with the tibia. So third axis is perpendicular to the first and second. Only 2 minutes, please. The main goal of the kinematic alignment is to align the second axis, that is the transverse axis of the femur, to align the second axis, transverse axis of the femoral component with the first primary transverse axis in the femur. Dr. Vaidya will tell you about the detail about the kinematic alignments, but I am telling you just the brief. The basic purpose of all these techniques is to align, give neutral alignment to the knee joint by various precise surgical techniques. There will be maybe measured resection, gap balancing technique, or the newer techniques by computer navigation, patient-specific instrumentation, or the robotic assisted surgery. These are the various pics of the various techniques. These are the about other various techniques which are being used for this normal alignment of the knee joint. So ultimately, all these techniques, they help the surgeon to achieve the neutral mechanical axis of the knee joints. So, to all my dear friends, while evaluating the post-op X-ray, we should see few things, that is there any overhang, whether the X-ray looks good, whether the joint line which have been created looks good, medial and lateral gaps are equal, and whether the femoral component is well aligned.
Very good presentation, sir. We are running short of time.
So this is the last primary goal of all techniques, is to achieve the neutral alignment of the knee joint. Thank you very much.
Thank you so much.
Sir, just like, I want to ask one question. You have to choose, because I have to act as a devil's advocate. You have to choose between alignment versus balance. What will you choose? Because you have emphasized very well emphasized the importance of well-aligned knee, that to 5 to 6 degrees of valgus. So you have to choose between balance, oblique alignment. What will you choose?
Sir, when you are balancing, ultimately alignment will be attained.
Why I ask this question? There are certain situations where you want your knee to be mal-aligned. Like in severe tight varus, where you do not want to resect much of a bone. In very obese ladies.
Yes, yes. These are some specific conditions where you may go for them.
Right. Thank you so much, Dr. Aggarwal. You explained so well about the mechanical axis and kinematic axis also. And rightly so, that balancing is very important, but not that we will be accepting the varus alignment. Yeah.
Yes.
Thank you so much.
Thank you.
Can we have a big round of applause for Dr. Shubhang Aggarwal? Thanks a lot for this talk, sir. Then next, may I request Dr. Rakesh Rajput to be on the dais as the speaker. Dr. Rakesh Rajput will be speaking on balancing valgus knee. Can we have a big round of applause to welcome him?
Sorry, first of all, it's my turn to thank Shubhang. He's not here. But I think Rajiv is representing IAA and I am from IAA. So thank you all for having us here. Now, just go on to the talk. The valgus knees. Now, all of us who've done knees, whenever we see a valgus knee, we start trepidating. And there's the reasons for that so. And I'll go across for the reasons why we have this trepidation when we meet across the valgus knees. So it is a bit more challenging, and I wouldn't say bit, it's actually a lot more challenging than a varus knee. And there are reasons for that. First of all, in medial side, if you look at, it's mainly a bony defect. As soon as you sort of do that, it corrects. There's only one ligament which gets tight, and if you can correct somehow that, it's done. On lateral side, there are plenty of structures which are tight. And the bony defects are also there, but it's the ligamental structures which give us all the nightmares. Also, when you actually correct it fully, sometimes everything will go on well, and in post-op period, as soon as patients awake from anesthesia, you realize there's a common peroneal nerve palsy. 4% of your cases are going to have that, not less. So again, trepidation. And it is also much less. I'm not talking about the mild valgus, but severe valgus, you know, you'll see a lot of severe varus. You won't see too many serious valgus knees to get a lot of experience from it. So again, a problem out there. So I'll go a bit fast now. So the first thing is to know, are we dealing with valgus only, valgus with flexion, and valgus with even extension? I think Manuj's talk was very good. If you have valgus with hyperextension, be very careful. Those knees could be a trouble. So examine them properly. They're not neurological, they're not congenital, osteoarthritic or rheumatoid or post-traumatic. So there's going to be something very wrong if you have valgus with hyperextension. Valgus with flexion is what we are normally going to see around. Now what actually gets tight? So some structures get tight ligamentous wise, some we have bony defects. But if you just look at the valgus column, there are plenty of structures right from ITB, lateral retinaculum, posterolateral capsules, tendon of popliteus, lateral collateral, even lateral head of gastrocnemius. So you know, so many structures which can be tight, and we've got to deal with all of them. There's also something bony which is not right. And I'm not just talking about bony defects, I'm just talking about, look at the lateral condyle. It's so hypoplastic, both distally and also posteriorly. So you may not even get your jigs right. So you have to be very careful when you deal. So whenever we start sort of dealing with this and balancing them, we need to know a classification we need to work on. And any classification you go on lateral side will take the degree of deformity, the ability to correct that deformity, which means passive correction, and medial soft tissue integrity, very, very important. So for these knees, very, very important, and if previous osteotomy has been done. So the two major classifications we talk about, Krakow, Ranawat, really there's not much difference. I've mentioned it here. So I'll just go according to the Ranawat classification, which is what we normally all follow. So grade 1, the majority of our knees are going to be less than about 10 degrees. So it gives you a very diagrammatic representation that 10 degree or less is 1, more than that is 2. Now 2 will have some amount of medial laxity, but still medial collateral is competent. So you have laxity, but it is competent. From grade 3, which is more than 20 degrees, you will start having fully incompetent medial collateral ligament. So you got to devise a different strategy to deal with that. What implants? If you're a CR user, like for Manuj, most of these cases you will be able to deal with CR knees. If you're a PS surgeon, and I think you need to be more constrained in these knees, you might start using a PS design for more. If you're a sensible CR user, you will start using more and more PS here, and sometimes even for semi-constrained knees, like a valgus varus constraint. And for very severe in grade 3s, which I said, most likely you'll be using a hinge. So what we want is a quadrangular box. And in majority of these cases, that box will be parallel to the transepicondylar axis. On medial side in varus knees, that's almost always correct. But on lateral side, this box-like structure may not always be parallel to the transepicondylar axis, because you may have metaphyseal deformities, which are not that common on the varus knees on the femoral side. But in the femoral side on the valgus knees, you may have these metaphyseal deformities. So the transepicondylar axis is not that good. So you may have to use something else to correct that. So the workhorse approach for you, even for a lateral side deformities, are going to be a medial approach. Okay, so the medial approach still is very good. There will be some differences. Like you see that we went all the way in the back with the medial approach for these last 2 knees. We will not be going all the way back. You do not want to loosen out any more than what you already have. So medial sides are loose. Don't go all the way till back. Probably stop at deep MCL. Okay, so just resect that and stop there. Don't go anywhere in the back. The patellar reversion will not be difficult, but tibial cut. Do very minimal amount of tibial cut, maybe 4, 5, 6 mm, something like that. Don't go around 8, 9, 10 mm. Okay, so resect less. Now varus cut on the actual femur. So normally we cut around 5 degree on femur. So universally that's what we've been taught to. In these cases you can reduce that. That's one type of belief. there's another type of belief that in these cases you need to increase your valgus cut because you want to not to be releasing too many soft tissues. So if you cut varus, you are rotating the femur slightly on the other side. So you'll have even less of a lateral gap. You already are tight. So that's another theory. So there is this dichotomy of belief in this thing, and both of them are right. So if you want to correct at bony level, you can reduce, but if you want to be at short tissue level, you can increase the cut. So a lot of robotic surgeons think very differently. Now, you got to be very careful with femoral cuts. That's what you are aiming for, okay? Remember when you put your jig, and if you are a posterior condyle referencer, the posterior condyle is hypoplastic, so don't use that as a reference. So use your transepicondylar axis, use the cut surface tibia, use the Leo-White side line, but whatever, don't use the posterior referencing, okay? Not very good. Now, what are the structures which are tight? So lateral collateral ligament we know is tight. See where it attaches to the fibula head, all the way from epicondyle. So lateral epicondyle to the fibula head. Also you have a oblique popliteal ligament, okay, that is also attached in the fibula head. And you have gastrocnemius I mentioned about in some cases, particularly if you have flexion deformities. That is posterior. So you got to think about what we do, and that is what the sequences of release happens. I think Manuj showed you very well and Rajiv pointed to you very well. Medial side releases are very easy if you want to release posterior capsule. Lateral side, remember where your ITB band is, remember where your posterior cruciate ligament is, and remember where the tendon of popliteus is. Between tendon of popliteus, look at the picture, and the posterior cruciate, you are safe, okay? But you are not safe between the tendon of popliteus to the ITB band, because that's, and in the cut surface of tibia, so that forms a triangle. That is where the common peroneal nerve is. So in normal cases, we see this nerve about 4 mm far away, but in a lot of rheumatoid patients, this is being dragged on to that, only about 2 mm away. So any slip, and you've cut the common peroneal nerve. So be very careful when you do releases there. And if you see majority of these cases, there's not an issue with actually flexion. The deformity is all in extension. So don't go correcting this deformity in flexion, correct it in extension, okay? Sequential of releases, I'll just quickly go through this. We have insoles, release starting from LCL. We have Krakow, all done on cadaveric bone models, starting from LCL. Then we have Laskin, which probably was a bit more rational, starting from ITB. You don't need to take pictures. I'll give you this presentation if you want. It's here, so you can take it from here if you want. Okay, and if you, Frederick Buechel, he was a very good thinker if you think about Frederick Buechel. You know, he was the first one who said all the contractures are pinning down onto the fibula head, so just chop the fibula head. Now that's too rational, but this guy actually gave the first idea about what is actually contracted. And what we follow is a Ranawat release, not what he originally came out, but what subsequently he started talking but didn't publish very well. So we actually release a bit more sequentially. So this is one diagram if I want you to take home from today's talk is this. If you release just one, either LCL or just popliteus, you get about a 9 mm opening, okay? If you release both, you're going to get 20 mm opening. So this is something you need to worry about. So don't release popliteus and LCS at one go. Then you are above domain, and then you might suddenly find that you need a TC3 implant, which is semi-constrained. So be very careful, don't release both of them together. If you have to, then probably do a sliding lateral condylar osteotomy, not releasing both the structures, because that your stability is also very important. So that's what I would now suggest, that this is the sequence we go at. Remember the last one, popliteus and LCL never together, okay? If you are still in doubt with all these releases getting confused, just remember this one slide. So if you only have an extension, ITB is the one you're going to release. If you have both flexion and extension tightness, LCL is what you're going to release, plus minus a tinge of popliteus. And if you still then after this you are in tight, go at ITB. So this is one slide which will help you out to bail out. So occasionally we do lateral approach also for very severe deformities, very good approach. And it's a very sensible approach also, though for very few cases. And it has got its own advantages also, but there are drawbacks also. One, unfamiliar tibial tuberosity osteotomy is quite commonly needed, and the closure sometimes can be a nightmare. Like, so this is one more structure which we do for lateral, not that common for medial side problems, but sliding lateral condylar epistomy if you are tight in flexion and in extension. Very good thing to bail you out. If only in one area you are, you need to release. But if you are really tight in both sides, maybe this is the way to go forward. And if you are, suppose you've got the balancing right, but medial side is still lax. I said some knees are very lax medially. In those cases, this is one thing you can do, though I have never tried this. But this is something which has been advocated, that you can take up the ligament, osteotomize, and then bring it up wherever you find it's more. There are some very bad knees, we know this, straight away hinge, don't worry about them, okay? So you can go straight. In the end, what are we aiming for? This is again we want to know, what is our end point? Are we going to aim at neutral, slight valgus, half correction, what are we aiming for? Like in varus knees, we don't want to bring them even to neutral at times, we want to leave them slight varus. They don't like leaving them in valgus. So don't bring varus knees into valgus. Similarly, valgus knees, don't bring them into varus. So leave them slightly short of full correction. This is very important. And this is a paper by J.L. Brad which will tell you that be very careful how you correct them. Correct them to slightly less than valgus. Those are best performing knees. So that's a clear evidence for that. In the end, I think I would like to conclude by just saying this, valgus knees are different and treat them differently. Thank you.
Thank you so much, Dr. Thank you so much, Ramesh. Just the one small comment on this because we are short of time. All these valgus knees will also, the native knee will also have the increased lateral rotation, external rotation. So one has to be careful when you are making the anteroposterior cuts, that you should use adequate amount of external rotation in these cases.
Absolutely, and there are some surgeons who will, at the drop of a hat, they will do an osteotomy and just correct it. I think Narendra might be one of them also. Yeah, right?
And one last thing, that the skyline view is very important, pre-operative,
patella tracking,
because that will tell you that what is the position of the patella.
Absolutely.
One more thing.
So if you have bad patellas, very severe deformities, lateral exposure might be the best way to go forward.
What are the criteria of doing lateral parapatellar approach?
Yeah, so I thought I was a bit hurrying there. But if you have, like say what Rajiv just mentioned, if you have a patella which is tracking very mal-rotated or even sometimes fallen off completely, and then if you have more than 20-degree valgus, straight away go for lateralizing. That's what will be the best way for you for that. But then you need experience to do that. And then we can talk about here what Kablish approach is. That's a different topic.
Thank you. Thank you so much.
Thanks a lot, sir. Dr. Rakesh Rajput traveled all the way from Kolkata. Can we have a big applause for him for such a nice talk? Can I request Dr. Rajesh Sharma to be next on the dais with his presentation on TK tips, pause of valgus knee, varus knees.
Thank you so much, Dr. Sharma. Thank you, Shubhang, if he is back here. Thank you, Dr. Avatar Singh, and all the dignitaries here, chairpersons. I've been asked to speak on the arthroplasty, the varus release, and how to do it in a good and easy way. Now, it is important that we understand what kind of a varus knee it is, whether it is an intra-articular deformity or extra-articular deformity, whether the patient is having is it a fixed varus or it is a lax varus, because in a fixed varus you may have to release more. In lax varus, which is correctable under anesthesia or under the valgus stress, you will have to release less. So it is very, very important. It is also important to differentiate between the intra-articular and extra-articular deformities, because both will have a very different way of management. What is important is, as the medial structures are tight, and especially the posteromedial structures, and the whole of the capsule and medial collateral ligament on the middle side will remain tight, and also the osteophytes which are tenting the MCL. Now osteophytes also may be the reason. So first you release the osteophytes, then you assess. Posteromedial corner is very important to be released, and that is that is the whole trick of how to do a good release. And reduction osteotomy of the tibia is also very useful. Create a sleeve, the posteromedial, and never touch the pes, because the moment you touch the pes and release the pes, it becomes the whole joint will become the unstable joint. And it has to be, the medial release has to be as a sleeve, subperiosteal dissection. And posteromedial release is very important. It is very, very easy. You just put the humerus retractor on the back and then keep rotating it, external rotating it, and then you will keep on having the gradual release. And it is very important that it has to be a gradual release. Sorry, this video was not functioning. And posterior clearance is also very important, because when you do the posterior clearance, sometimes there are so many osteophytes on the back side. So under the distraction, if you do the posterior release, the some amount of release will be there. And release only as much as needed. The judicious release is the right word, because if you do too much, it's really bad. A stable joint in flexion, extension and mid flexion, that is the aim of all these good surgeries. One example, patient is having a severe varus, as we can see here. You see the surgical on the table, there is significant amount of varus, but it was partially correctable. There is a large amount of bone defect. And this much of the bone defect we can see, and whenever you do the release using the cautery, you must keep having putting the saline over it. And you see that this is reasonably released. And moment you do the reduction osteotomy of the tibia and remove the posterior osteophytes, you have an adequate release in most of these patients. And that's what you are seeing here. Then you see the extension gap is reasonably managed. You see that the patient, after the cementing of the components, it's a very well balanced joint. And that's what you see this patient. Both the knees are straight and patient is able to have 90 plus function. The varus knee with the stiffness of the joint is another major issue. Now these patients will need much more release than what we saw in the last. You see that this patient having a excellent function after the judicious release. Varus knee with the intra-articular deformity, the intra-articular correction needs to be done. And that's what you see. And you should have in these severe varus knees or severe fixed flexion deformities, all the kinds of the implants, the constraint implants available with you on the table. When you leave a varus, the knee after the replacement in some amount of varus, there will always be some amount of concentration of the stresses in the proximal tibia, and that will become the reason for the loosening of the implant, aseptic loosening of these knees. Now varus knee with bone defects, what you see here, the extensive bone defect in this young girl, I operated some about 22 years back. You see this patient had the bone was used, so part of this varus deformity was because of the defect. And that's what you see this patient post-operative having excellent function, a comparison of pre and post-operative. And this is the patient 18 years after the surgery. Now this patient is almost 22-year follow-up and the joint is absolutely stable and there is no signs of the loosening at all in this tibial or the femoral component. That's what this patient at 18 years. Another severe varus deformity with a large bone defect. You see that bone defect was almost 1 inch. But these severe bone defects also will reduce significantly if you do the reduction osteotomy of the tibia. You can use the bone graft and have an excellent function on these patients. The metal wedge can also be used, especially where you have the sclerotic bone. So it's in a sclerotic bone where the defect is sclerotic, it is better to use a metal wedge rather than the bone graft. And as we mentioned, the intra-articular and extra-articular deformities need to be differentiated very clearly, what we see here. One example, in short, the metaphyseal deformity at multiple levels. So in these cases, the release will be important, but also the osteotomy will be important, like what we see in this patient. It was not just the varus release, medial release or posteromedial release, it is also the osteotomy, the metaphyseal osteotomy of the tibia, metaphyseal osteotomy of the femur. And also sometimes the lateral epicondylar sliding osteotomy to balance the joint in the right way. The message is, don't over-release the MCL, which is a major issue. do not touch the pes, because if you touch the pes, then the joint becomes very unstable on the middle side. Mistakes are, you can damage the middle collateral ligament, you address the middle collateral ligament too soon or unnecessarily. That's very rightly mentioned in today's surgery, the surgical demonstration by the robotic.
Thank you so much.
Thank you so much.
Can you have a big round of applause for this really nice talk
Just
by
one
Dr. Rajiv Sharma from Delhi?
Question from
I just saw the MyTech anchors. Anything specific about the MyTech anchor, or can we use any other anchor?
In the MCL damaged, we have a series of such patients, which I'm sure Rakesh and Dr. Sen has seen in many times in my talks. The augmentation of the MCL or the reconstruction of the MCL is possible. So if you have a partially damaged MCL, use an anchor 5 millimeter or 6 millimeter anchor and suture it back and give a plaster for some time.
So my question is, you said the MyTech anchor.
Right.
So anything specific about that anchor or the technique, or you can use any anchor?
Any anchor which attaches the damaged portion of the ligament to the bone is what is important, right?
Can we have the next speaker, Colonel Zafar, on the dais, please? Big round of applause for him. He's from Jalandhar itself. So, can we have the applause? Why is missing for the around people?
Hello, good morning, ladies and gentlemen. Topic for me is bone defects on tibial side in a primary TKR. Okay, so it's very common in revision scenario, but since we are doing this complex primary TKRs, it is fairly common. So there is variability in the size and location of tibial defects, and the pathology is bone erosion, consequent to the overload of medial or lateral compartment and followed by collapse of the subchondral bone. There are multiple methods to fill this defect, and our aim is to have proper tibial component positioning, joint balancing, stable and lasting fixation. So initially we used to have this uncontained and contained defect. Rand used to classify them, and we have been following this. So next, more comprehensive classifications is AORI, Anderson Orthopedic Research Institute. Type 1 is in which minor bone defects with intact metaphyseal bone that does not compromise stability. Treatment is cement fill and impaction bone grafting. Coming to type 2A, when we have metaphyseal bone damage involving tibial plateau of on one side, and 2B when both the sides. Treatment again is cement fill, augment, small bone graft, and a revision stem to offload the construct. AORI type 3 is a revision scenario in which there is massive bone loss, a large portion of the condyle plateau is involved, and collateral ligaments and patellar tendon can also be involved. So treatment here would be bulk allografts, custom implants, megaprosthesis, porous tantalum, metaphyseal sleeves, rotating hinge, which we are not talking today. So coming to location, so peripheral posteromedial defect is common in varus knees, and contained lateral compartment defect in valgus knees. So the chronic situation and underlying bone osteopenia is the cause. Others which have been implicated are chronic ACL deficiency, osteonecrosis, bone cyst, trauma, previous osteotomy, and inflammatory arthropathies. So management options, we start with the first one, which is the easiest one, is to downsize and lateralize, translate the prosthetic component away from the defect. So downsize and lateralize, use the tibial spacer to reduce the size of the defect, avoid tibial resection as deeper tibial resection, as there will be poor quality metaphyseal bone there. Also there will be chances to injure the soft tissue attachments, and we have to keep the joint line preserved. So type 1 contained defects, using only the cement. This, if defect is contained defect and 5 mm or up to 10 mm. So Ritter and Dorr have published that if the defects are less than 5 mm and contained defect, then cement alone is enough. For peripheral bone defect, less than 50% area, less than 5 mm is okay by, in 2012, Fosco have published that it is enough. And the strength is comparable to morcellized bone grafts and metal augments. For type 1 peripheral defects, size 5 mm to 10 mm and contained or uncontained, cement and screw is good. So you can use 4.5 or 6.5 screws embedded in the cement, 5 to 10 mm apart. The screws will reinforce the cement and distribute the load away from the joint line and the cement bone interface. Screw heads are placed 1 mm lower than the tibial implant. So AORI type 2, in which the defect is more than 50% of the tibial surface, so we should think of bone grafting. So the host bone has to be freshened. The bone graft size has to be from 0.5 mm to 1 mm. Size less than 0.5 mm gets absorbed in the inflammatory process. Size greater than 1 mm is slow to incorporate. And cancellous bone graft remodels is what we want to achieve. So Windsor et al. Have shown this technique in which distal femur bone cuts, other cuts can be used and reappropriated, fixed, so that we can take care of the uncontained bone defects. The aim is to restore the joint line, and we have to be sure that the cement does not intrude into the graft host interface. However, if the defects are bigger, greater than 3 centimeter, they may require structural allograft. So in such scenario, we'll have to use tibial tuberosity as the reference point if we are using intramedullary entry point. If we are using extramedullary, then go as using the extramedullary jig. So defects, an oblique defect has to be converted to a rectangular defect, stepped defect. If we are using allograft, then we have to resize the allograft, fix it with temporary K-wires, go ahead with the tibial preparation, serial reaming for the tibial stem, finish the tibial preparation, fix definitive screws, use stem tibial implants, and do trialing. The K-wires can be changed to screws, and final situation. So structural bone allografts, advantage is it restores the bone stock, it is biocompatible, cost effective, allows custom reshaping. There is possibility for ligament reattachment, but due to in Indian scenario, it is difficult to get allografts. Tigani et al. Have shown that 5-year follow-up, there were no acute or chronic complications. Graft host bone incorporation was good. There was no prosthetic loosening, no radiolucent lines. Survivability of autogenous bone graft. There's a classic paper by Dor and Ranawat, which they have published in 2006. And they have shown that 22 out of the 24 cases had good graft incorporation. There was no tibial collapse. And the graft choice were distal femur, iliac crest, or femur head. And the time taken was 6 months for the graft incorporation to complete. Okay. Coming to modular metal wedges, used for uncontained defects, size greater than 60% of tibial plateau and depth greater than 1 centimeter. So there's this Korean paper in which they have said that 4-year follow-up, 67 knees, good functional scores have improved, but 10% they had radiolucent lines. However, they said there was no progression of these lines, and there was no difference between 5 mm or 8 mm wedges. So size, there are different wedges, different companies make it. We have to use intramedullary stems when we are using thicker wedges. And addition of stem allows for proper component positioning, enhances the fixation, decreases stress at the bone implant interface. And there's another study, a Japanese study, in which they have compared 33 knees in which they have used metal wedges with 132 varus knees. And they have said that there is no difference in implant survival rates, no difference in knee function scores. However, with metal wedges, there is a radiolucent line in 30% of the cases, and 51% of the cases had rounding of the medial edge of the tibia. So metal wedges have given rise to rectangular blocks. This study by Faring et al. Have shown that metal blocks transmitted better torsional loads as compared to wedges. And multiple blocks can be used if defect is more, but we have to take care that they can be downsized according to the tibial, proximal tibia. Thank you.
Very lucid talk, Doctor. The only one thing that the metal wedges you rightly mentioned, the sclerotic bone when you have in the defect, probably the metal wedges is a good option.
Sir.
But with the reduction tibial osteotomy, probably the use of the wedges or bone graft has itself reduced significantly now.
Sir.
Right. Thank you so much.
Thank you, sir.
Any question you?
Do you use allograft?
No, sir, I told you we have not used allografts. It's just demonstration.
Thanks a lot, Colonel Jaffer. Can we have a big round of applause? We have, because of certain constraints in time and the other things, little change or tweaking of this program. Next, Dr. Prashant Vaidya will be on the dais. Since he has to prepare for his live surgery session after that there will be a little pause for this inauguration ceremony for 4-5 minutes, and the talks continue after that. So, Dr. Vaidya, Dr. Narendra Vaidya, Narendra Vaidya. My apologies, my sincere apologies. Dr. Narendra Vaidya, he has come all the way from Pune. So, can we have a warm welcome like Punjabis to Dr. Vaidya? We heard a lot of big hammers today in the morning, so hands also should be like that, huh? While applauding.
Hello.
Select. नहीं वही बता रहा था, 1 मिनट मैं करता हूँ. First of all, let me thank Dr. Shubhang Aggarwal and his team at NHS Hospital for inviting me, and IAA for organizing such a fantastic live surgery workshop. So today I am going to talk about kinematic balancing. That is now there is a lot of talks we will see for alternative alignment principles. And why is that? That is what I am going to talk. Since 1970s, late 70s, we have all been trained to align the limb with a mechanical straight line, now 0 degrees neutral axis. So that has been practiced for more than 3 decades. So why such a change now? The main reason is that we are putting the knee in the straight alignment irrespective of their native knee structure. So if you see this graph, then you will see hardly 15% of the population has got a native neutral axis, HKA axis. So why put all the other 85% also in the same axis is the basic thought process behind kinematic alignment. This is one classification for the native knee which has been proposed, where the knee has been classified into 9 phenotypes or 9 types, and that is how this generated a lot of interest for the kinematic alignment. So now today, if you see in the world, there are a lot of thought processes like patient-specific alignments like UK, which I will be demonstrating later on today in a live surgery. Then kinematic alignment, restricted kinematic alignment, mechanical alignment, and anatomical alignment. So actually, these have been tried, but the alternative alignments did not work because the earlier generation of poly and the implants was not as good as today what we have, the better polys and vitamin E polys, etc. And so the wear was more in alternative alignments. So what is wrong in mechanical alignment? So there is a frequent prosthetic overstuffing on the distal femoral condyle. It stretches the lateral retinaculum during flexion. The gaps are frequently tighter than the native knee and makes the limb straight in every patient whose knee was not straight structurally and by birth. So kinematic alignment, it's a relatively new technique. It has been practiced more in last decade. Aims to anatomically position and kinematically align TK components, resurface the knee joint by removing cartilage, bone thickness equivalent to implant thickness, Implants are aligned on the knee, kinematic axis around which the patella and tibia will move. We heard the axis, what are the axes in the earlier lecture by Dr. Aggarwal. It restores the constitutional knee joint orientation and the physiological knee laxity, especially on the lateral side in flexion extension, like we discussed in the live surgical demo. And that's why robotics also play a very important role. Vast majority of the patients are eligible for kinematic alignment. Patients who are less than 50 degrees of deformities, 15 degrees of deformities, relatively supple, partially correctable deformities. And if it is rigid, then we can go for a restricted kinematic or a hybrid approach also. So these are again at the cost of repetition. Some things are there where different types of implants, technologies have not solved this 20% of unhappy patients. So this is one attempt, I think, which will go further to satisfy these patients who are actually not happy with their results. So it's more physiological, reproducible implantation, improvement in the knee function, better patient satisfaction, and it is like a true knee surfacing. So these are the three axes. You can see it's a transcondylar axis or cylindrical axis is green, patellar axis in purple, and tibial longitudinal axis in yellow. And the aim is to reconstitute everything. So the typical cut, which will be, you will see the left, the yellow cut, that is kinematically aligned. It will be slightly in varus. And mechanically aligned, you cut less, it's absolutely neutral cut. So the cuts will look different actually in kinematic and mechanical alignment. Even the implantation also will look different. This is how the mechanical alignment is there, which is straight, and kinematic alignment in a varus, constitutional varus knee, initially it will be slightly in varus. So these are, I use always robots since last 6-7 years for doing kinematic alignment. And now more and more patients I am doing kinematic alignment with a window of 5 degrees of residual deformities. So these are a couple of patients. This was a 8-degree varus, partially correctable patient. So this is the implant planning. You can see. I don't know. Which is the pointer here? Yes. So if you can see here, the initial, this is the by default sort of a position given by the robot. And then after that, we have given 2 degrees varus to the femoral component. You can see it is perfectly matching the yellow thing, that is the bone surface. And in the posterior side also it is matching. And the flexion extension gaps, you can see they are perfectly matched under 1 millimeter. So it's a completely balanced sort of a knee. It is important, there was a question asked by the moderator in some time back, whether balance or alignment. So it has to be 100% balance. Balance is very important. That is what we are watching here with robot. There is a absolute evidence that you have got a perfectly balanced knee in this situation. And this is the X-ray. This is the second case, which was a slightly severe case. You can see 17 degrees of varus, which was partially correctable. And this is a scanogram. You can see the gap assessment where medial structures are very tight. This is the initial screen where there is 0 degree neutral alignments. You can see here. And then we have given some degrees of varus. You can see 1 degree, 2 degrees of varus in the femur here, and 1 degree in tibial component. And we have got sub-millimeter sort of balancing here. Once we remove the meniscus, this gets corrected. Doesn't need any ligament release at all. So from 17 degrees varus, we have come to 2 degrees effective varus, and that has given me a completely balanced knee without touching the ligaments. And this is the final X-ray. Sometimes in severe deformities or severe cases, we have to use a hybrid approach. For example, this is a case which has got a combined varus. He has got a periarticular deformity also in tibia. You can see that 16 degrees of deformity just below the tibial tuberosity. In sagittal plane also it is 19 degrees deformity. And so there are 3-dimensional deformities. This is a challenging case. It is a rigid varus. There was a talk by Dr. Sharma some time back, and the rigid varus you require a lot of release, which has to be judicial. That is what he said. But with robotics, you have got now a tool which can assess what is judicious. It can actually objectively assess and tell us exactly what is to be done. So in this case, we started with 19 degrees varus. On table, slight correction was there. The pre-operative was 23. Then we have got this neutral sort of placement. Then we have given 2 degrees, 3 degrees of varus in the femur. Generally, my overall this thing is that I go up to 5 degrees of combined varus, not beyond that. And this is post-balancing. You can see from 19 degrees, we went to 3 degrees the achievement, and that is a complete correction without, even releasing much ligaments. So slope is also whatever we planned, we got it. We planned 3 degrees of varus, we achieved 2.7 degrees of varus, and that is how the perfection is achieved with the help of robotics. So what is the evidence now? There are a lot of papers coming up which are showing that the forgotten joint score, then the knee society score are much better in kinematically aligned knees, and so probably in coming time with emerging technologies, we will be using more and more kinematic alignment philosophy. So take home is that kinematic alignment may help in better reproduce physiological knee function. It preserves the soft tissues. Robotics and other technologies will help immensely, and a lot of evidence is gathering for kinematic alignment. Thank you very much.
Thank you, Dr. Vaidya. I think it's a very well explained and difficult topic. Kinematic alignment has been recently been talked about a lot, but we have been seeing most of our population has been in the virus, and the virus has been one of the reasons of the progression of arthritis in younger population as well. So do you suspect that at the moment we have a short-term data for kinematic alignment? Do you suspect that in 10 years time, 20 years time, this thought process may change again? What's your present day feeling?
I think we will go for more and more kinematic alignment and functional for 2 reasons. Kinematic alignment earlier was tried, but it failed because of the quality of poly and the wear which was there. And the way we were used to cement the prosthesis. Now there are better prosthesis. Even there are kinematically designed prosthesis also, like the Journey 2 prosthesis or medial pivot joints, which have got, designed by itself, it's kinematically designed knee. So I think more and more, and with emerging technologies, I think we will be using more and more this thing. Only thing is that when we are talking of, my apprehension is that we should not go more than 2 degrees maximum varus on the tibia, because I am still concerned about it. So what my, this thing is that combined 5 degrees is what I do. Rotation, I go up to 6-7 degrees also. So, you shape the bone more than releasing the ligaments, you shape up the bone in such a way or sculpture the bone in such a way that your alignment is near to 5 degrees, not beyond 5 degrees.
Very right. One interesting observation, when we were doing the LCS knees 25 years back, and I followed some of my patients for a long time. Now these patients who were left in the virus, they were very happy. What you mentioned, the forgotten joint score, they were very happy, and I think with that, it looks like that kinematic alignment will be the thing in time to come.
Yes.
So my concern is that as we have seen in the chart, like only 15% of the people are mechanically aligned. So let's talk about a patient who is in a constitutional varus of 8 degrees. So what should be your target?
You should not correct it to the full, at least correct it to the half this thing, and keep it in slight this thing.
So is it right to say that when we are seeing a kinematically aligned knee, we are actually talking about a less mechanically aligned knee, because we are not going back to the original anatomy of the knee joint?
Yeah, mechanical, I think these are 2 entirely different principles. Mechanical means 0 degree, but why we should go, for a person who is in 8 degrees of varus, we should not go to 0 degree of the mechanical axis. So you should, without releasing, what is important is your gaps are balanced. So numbers are not very important. That's what I want to say. With the limit of 5 degrees, if your gaps are equal, especially because I am using robot and I have access to the technology, because kinematic alignment with a conventional technique, it's very difficult to achieve. How will you measure 2 degrees of rotation, or how will you measure this thing? That is a major block. So some tool, some technology you have to have. Otherwise it is safer to do a mechanical alignment. Because if you want to give 2 degrees to, say, tibia, with conventional, at least I will not be very much comfortable to do a 2 degree varus cut. Some of the companies have got jigs with varus, this thing. But it's really difficult like that.
Yes, thank you so much.
Thank you.
Thanks a lot, sir. Dr. Narendra Vaidya had a very nice talk. Big round of applause again for him. Thank you. Next, we are going to have the inauguration ceremony. Can I request the people on the dais as chairperson to excuse us for a while? We'll continue with this neat talk after a brief inauguration ceremony. And may I request all the delegates who are in the refreshment area or outside to join us inside for this auspicious ceremony. Then may I request Dr. Ramesh Sen, Dr. Narendra Vaidya, Dr. Rajiv Sharma, Dr. Nilen Shah, Dr. Rakesh Rajput. Banna, kindly escort this chief guest on the dais. Dr. Manuj Wadhwa, please be on the dais, sir. Then can I request Dr. Shubhang Aggarwal, Dr. Naveen Chitkara, Dr. Sandeep Goyal also to join us on the dais. I also have the opportunity of inviting Dr. Rinku Aggarwal, Dr. Vibha Chitkara, and Dr. Shali Goyal also to grace the dais with their presence. And I also take the opportunity of having the presence of Dr. Avtar Singh on the dais. Please join us, sir.
जननी
Can you have the big round of applause again?
This was just to make it quick.
Thanks a lot, sir. Yeah. Can we request the chairperson to be on the dais again to complete our NEET talk session? Dr. Devinder Lal, Dr. Colonel Nitish, and Dr. Rajiv Sharma. Can you be on the dais, please, sir? Dr. Rajiv Sharma, Colonel Nitish, and Dr. Devinder Lal. Dr. Devinder Singh Lal. And I will request Colonel Nitish to be on the lecture podium to deliver the lecture on bone loss and femur. We had another colonel talking about the bone loss in tibia. So this other part, bone loss and femur, talked by another colonel. So big round of applause again.
In Australia, most of the revision surgeons have become excellent revision surgeons because they were not so good primary surgeons. So the topic related to me, given to me is bone loss in femur, which is generally not seen in most of the time by the people who are not doing many revision cases. This situation of tibial bone loss is still seen because of various varus deformity, valgus deformity. The tibial bone loss is still seen in some of the primary cases. So, if I may say, this is the most important slide of my lecture, anticipation and preparation. You have to anticipate that in all revision cases, you can have bone loss to the extent where you may require anything and everything. So, go prepared, and you will always underestimate the bone loss which is seen on the X-ray. So, pre-operatively, we are assessing, we are going for a case, you will always underestimate the bone loss which you will find once you open the joint. The causes of bone loss can be osteolysis, septic, aseptic, stress shielding, or it can be mechanical while you are removing the implants which are well fixed. My job has been made easier by Zafar. He has already given you the classification of Anderson Orthopedic Research Institute, which is being followed everywhere. So that three kinds of defect can be contained, uncontained, or combined. So type 1 defects are contained where the cortical rim is there. Type 2 defects are uncontained where cortical rim is lost, and type 3 are combined defects. So these are the type 1 defects. Generally, how you assess on X-ray, there will be no subsidence of the components. Osteolysis will not be seen. You can see normal joint line and normal epicondyles. That's how you will assess that there is hardly any bone loss. You can go ahead. And in type 2 defect, there will be some joint line elevation. Means there is some bone loss, some metaphyseal bone loss, and the condylar profile will be reduced. If it is present on one side, it becomes F2A defect. If present on both the femoral condyles, it becomes type B defect. In type 3 defect, there will be extensive metaphyseal bone loss, at which may require some structural bone graft or some special implants. So, what are the goals of treatment for a bone loss? Why we want to replace the bone? Why not replace it with the metal? Because we want to support the implant and we want to restore the joint line, which is best possible by replacing the bone with the bone. But sometimes it's not possible. And also in order to get a good, strong fixation, as there are at least 2-point fixation should be there among the 3 zones, metaphysis, surface, as well as diaphysis. So the solution is, the best solution is replace bone with a bone. If not possible, then there are various other methods which has already been discussed by Jafar. It can be cement, screws, bone grafts, metallic augments, metaphyseal fixation in the form of cones or sleeves, and some So this is general guideline. How can you assess on the X-ray, see the joint line, see the epicondyles, then assess the bone loss. And always anticipate that whatever you are assessing, it's on table you are going to find more. So this is a Morgan zone classification for the 2-zone fixation. At least 2 zones should be fixed properly. So for small defects, you can use bone graft, which can be structural or which can be allograft, autograft, any form of graft, whatever is available. The bone banking system, which I've seen in AIMS, generally bone bank is not been, it's not present in most of the hospital. It's easy to, I was in Army Hospital RR, where it was proposed that we develop a bone bank. Developing a bone bank doesn't require much of thing. Nowadays even, I wouldn't surprise, hospitals are doing hospital, the industry grade of this thing, irradiation. So it's possible even in hospital. I'm forgetting the name of the hospital. I was surprised when I found this thing. So you can use cement with or without screw, depends. It's already been told, my half of the job is already been done. So you can use autograft, allograft, impaction grafting, structural. I'll talk a few minutes about impaction grafting because it is also not been done everywhere. The real impaction grafting is where you create a void, fill it with a reamer, and then keep on impacting. It's a very time-taking, tedious, boring kind of process. It takes at least 30 minutes to do impaction grafting about 3 to 4 centimeters. I've seen in a few cases being done because I've worked under Professor Malhotra. He loves talking about bone grafting and bone banking. So impaction grafting is a real, actual real grafting. But it should be a very tedious, you need to have all the shapes of mallet, which can be modeled according to your own needs. You may require a mesh to do impaction grafting. Structural bone graft can be used if all other things are normal, but you may require a stem extension. You will require a stem extension. You will require some metaphyseal augment to do structural bone graft. APCs are required, especially in young patient. We are thinking of future revision. Patient is going to last more than 20-30 years. He's got life beyond that. Then probably yes, you will require bulk allograft. Metal augments, there is no problem with the metal augments, except you should not use metal augments more than 15 millimeter, because then the problem starts of stress shielding. There was a topic about stem extension that I'll talk about only 2 things. There are 2 kinds of stems you can use, either short stems or long stems. You can use it in a cemented or an uncemented fashion, depending on the age of patient. If a patient is, you are not thinking of future revisions, there was a infection, you want some antibiotic load, use a short cemented stem. When patient is relatively young, he is going to last, the implant is not going to outlast his life, then try to do uncemented. This is just a basic concept. So stem selection, you can, it depends on basically what you want from the stem, other than method of fixation. In certain cases where the defect is severe, bone is bored, you need to have offset stem as a backup as well, in each and every case. So metaphyseal fixation, it has to be biological fixation, so you require impaction grafting. You need to fill the large defect, and it gives you immediate structural support. Finally, coming to sleeves and cones, when to use cone and when to use sleeve. When the defect is contained and large metaphyseal defect, one need to use cone, but nowadays I think companies are not even providing cones. And when there is an uncontained defect, then you need to put on sleeve. Cone is more of a biological thing because it matches to the bone, its structure, properties, they are closer to the bone. So they are more physiological, and bone regrows over cones as well. There are a few examples where TM cones are used in the femoral defects. It is a loss of metaphyseal bone, but it was a contained kind of defect. The cortex was relatively preserved. So tantalum cones can be used on both the sides, femur and tibia, but it has to be used in contained defects. And it's, I have already told that properties are closer to the bone. There are a few examples where we used femoral cones and as well as tibial cones. The various shapes and sizes, they are made, they are custom made. There are a few examples where femoral cones are used. One more example where tibial cone was used. And few words about sleeves. The only important thing is if you are using a sleeve, you have to use a rotating surface above the sleeve because it reduces the stresses on the sleeve. Sleeve is a weight bearing structure. It requires some time to integrate, and in India generally they do not give us fully coated sleeves. The sleeve is only proximally coated, and in cases of bone loss, half of the sleeve is exposed. It is not in contact with the bone. So when you are using sleeve, try to use a mobile bearing. There are a few cases where a sleeve being used. Sleeve can be used for both femur and tibia. You are expecting, like in this case, there is a metaphyseal bone loss. That is the reason sleeve was used. So this is a basic algorithm. When you can use cement, metal augments, bone graft, whether autologous or allogenic, when you require impaction grafting, advantages and disadvantages. So as when I started the talk, I said two things are important. What is anticipation of bone loss, and second is preparation. Always be prepared. Each and everything should be in your armamentarium when you are opening up for the surgery. Thank you.
Thank you, Satish. I think it's very well explained on bone defects. Only two short comments. The cones and sleeves. Cones are basically fillers, and sleeves they do provide the stability, and you rightly mentioned the same. The second is about the stem. Whenever we are using the constrained implant to take care of the intra-articular instability of some extent, I think these are the conditions when the extension stem must be used, because we are adding the stability to the joint by the use of the constrained implant or semi-constrained implant. So these are the cases where the extension stem is a must.
Sir, we have to identify that we require two zones of fixation: metaphysis, diaphysis, and surface. If either of the two are good, like if there is hardly any bone defect, you do not use stem. If there is a loss of metaphysis as well as surface, then you require a stem. So it's very simple, sir. The use of stem is when you are not having there's a bad metaphyseal bone as well as surface is bad. Then you require a stem.
Yeah, very rightly mentioned. The good fixation of the components and the stability of the joint, then you don't need the stem.
Exactly, sir.
Thank you so much. Thank you so much. Any question from you? Thank you so much, Dr.
Can we have a big round of applause for Colonel Satish Sharma? The next, may I request Dr. Avatar Singh to speak on constraint poly and stem extenders, when and why. Can we have a round of applause to welcome him?
Good afternoon, chairpersons and dear friends, and thanks Shubhang for the invite. And I'm thankful to the Indian Army Colonels for explaining most of the things which are there in my talk. And I'll be talking about the stem extenders and the choice of constraint. So friends, there are a lot of indications for stem extenders in primary TKA. When you are treating the bone defects, especially the uncontained bone defects, then osteoarthritis with stress fractures, previous hardwares in the tibia or the femur, and then treating severe varus and valgus deformities or osteoporosis associated with rheumatoid and otherwise. And then a lot of obese patients these days we are getting, most of them they will need stems. And to add on, you can treat fresh upper and tibia fractures associated with osteoarthritis. And now people are talking about the height also. The taller people will also need stems, and a lot of studies are going on about that. There are several advantages of the stems. They decrease chances of aseptic loosening by increasing the mechanical stability. They offload the upper end of the tibia, reduce the micromotion between the bone and the implant surface. They correct the deformities as well, and they restore alignment, and they convert tension forces into compression forces. So what is the ideal stem length? And what is the ideal canal fill ratios? Stems can be short if they are up to 80 millimeter length, and they can be considered longer if they are more than 80 millimeter. And a minimum of 4 centimeter of diaphysial fit should be there with the stem. We shouldn't be less than that in the distal fragment. And canal fill ratio should be around 0.85. So this has already been talked about, the short stems and the longer stems. And there are advantages and disadvantages of both. Disadvantage of metaphyseal stems are that they are difficult to remove because most of them they will be cemented, and there will be more bone loss if we need further revision. And they don't serve as reference for aligning your implants. Then about the diaphyseal engaging stems, they are generally uncemented in the diaphysis but cemented in the metaphyseal. So they are a kind of a hybrid, and they achieve press fit fixation in the diaphysis. And if you need a longer stem, say more than 150, especially in the femur, they need to be curved stems, which are available with some of the companies. So friends, as of any normal TKR, you need to assess your patient, especially about the bone quality, bone loss, severity of the deformity, associated stress fracture, which is not that too uncommon, and about the obesity, previous implants, and the height of patient as well. Few examples: if you have a contained defect which is more than 1 centimeter deep, then you need to freshen it up, put some screws, then you must protect this with a short stem. You can opt for longer stem if you want. Then about uncontained defects, you will see many of these in your practice. And I address most of them, rather all of them, with the autologous bone. I have never used bone from the bank, and very rarely I have used those implants which are now available. We need to cut tibia slightly little more, maybe 10 millimeter, that's the upper limit, because you will need more bone for reconstruction of these defects. Make an oblique osteotomy to the defect, and you should have 80 to 90% of the bleeding bone in the bed. It should be very flat osteotomy so that the graft fits intimately with the bone. Fix them with 4 mm cancellous screws, 2 of them, but put the screws in a direction so that they don't interfere with the direction of the stem, because you have to use stem in these patients. And cement should not be allowed to creep between the graft and the recipient bed. And then you must protect this with a stem. And then when you are treating severe varus or valgus deformities, there is enough literature now which suggests that you must use stems, and they show better results. Otherwise, they'll come back, these deformities, and you have early failures. Some of the examples of severe deformities: bilateral stems, severe osteoarthritis with flexion, varus. These are from my early days of navigation: 34-degree flexion deformity, reconstruction of the defect. You can balance these knees after the reconstruction, and this is a couple of years later. Another very severe windswept deformity, you could take his knee into hyperextension, severe varus, and initially I thought that I'll need a hinge or a CCK to sort it out, but surprisingly after good releases, good resection of the bone, I was able to solve it with a normal knee, just a constrained insert, and that to PS, not the CCK kind of. You can reconstruct your defects by using these meshes. I have no experience with that, and I rarely use these augments because they are expensive and their availability is also a problem for a normal orthopedic surgeon. And then you have a lot of these osteoarthritis with stress fracture of tibia. So one thing I will recommend is that you should always have a long leg. I can share my personal experience with you. About 2 years ago, I did a TKR. I was very happy with the result. In the theater, when I went to the room, she was complaining of pain. I examined the knee and there was a fracture. So I had to go back to the OT, then revise the tibia with a long stem extender. So always take a full length X-ray so that you don't miss on these things. And it's better to treat them at one go rather than treating your fracture separately and then coming on to do the TKR. And it's very well highlighted in the literature as well. You can kill two birds with just one stone, sort it out together. A couple of examples: severe osteoarthritis, osteoporosis, stress fracture, and that's the result. A couple of more patients. And then some of these patients, you may, especially if the fracture is little more proximal in the metaphysis, you may have to add plate to get stability. You will not need this in all your patients. And if you have previous hardwares in the tibia or in the femur, you should definitely use stems. And coming on to obesity, it has been shown that they will always do better with stems, especially on the tibial side. Couple of examples. So in this patient, I had to do a hinge also because I had to resect the proximal part of the femur because of a previous fracture. Then osteoporosis, I always prefer to use stems. Acute intra-articular fracture, I have a couple of these patients which I couldn't get the slides. This is from the net. It can be done very easily. Just remove the proximal part of the tibia and then put an extender. They heal very well. Then coming on to the constraint selection, this has already been discussed by a number of speakers. I don't have to speak much about this. Constraint selection, friends, depends upon your stability, your collateral ligaments, degree of bone loss, and integrity of residual bone. And what to choose is entirely your choice. You can use a CR knee, deep dish insert. Throughout my career, I had been relying on deep dish inserts and some PS inserts. Very rarely I have used the CCK insert. Thank you so much.
Thank you very much, Dr. Avatar. It is a nice talk. But how many defect is there? If it is one third or percentage, you decide to put the stem. Suppose there is defect in the tibia on the medial side. If it is only 10% or it's 20%.
If the defect is, say, more than half of the keel's length, I will use the stem. I calculated from the
more than half of one condyle of the tibia.
Keel of the tibial implant I'm using.
And in all, how you decide that in all osteoporotic patients you put stem?
Yes, most of the osteoporotic patients.
But some of the surgeons, they don't use the stem.
I believe that when you are treating osteoporosis, severe osteoporosis I'm talking about, when you extend them, and if you don't have a stem, your tibial slope will tend to change. So to protect that, I use stem in these patients.
But in don't you feel, sir, that there can be a stress fracture at the tip of a stem in case of osteoporosis? Because osteoporosis is a contraindication, especially on the femur side.
No, there cannot be any stress fracture, and I have not got any till date.
Because most of these stems are dangling stem. They are not tight fitting osteoporosis.
You don't need a tight fit stem in this situation. You just need a dangling stem.
But you agree that even in a very severely osteoporotic bone, like a rheumatoid, even if you don't put the stem, and then if there is no instability of the joint, in due course of time the bone becomes much stronger.
You can get away with that.
Right. But the instability or the constrained implant, probably that is the main indication.
Then you will definitely need that. Thank you.
Thank you so much, Doctor. Thank you.
Thanks a lot, Dr. Avtar Singh. So may I have the honor of inviting Dr. Amit Sarsi also on the dais as chairperson. Dr. Amit Sarsi, please. He is our orthopedician from Railway Hospital, Firozpur. Kindly join us on the dais, sir. And may I have the honor of inviting Dr. Shubhang Aggarwal, who will be speaking on Is Robotic the Solution for Everything? Can we have a big round of applause for him? Shubhang Aggarwal, please.
So good afternoon and thank you everyone for attending this program and making it a success. And I would like to take the opportunity to thank Dr. Ronen Roy and Dr. Natesan for giving us the opportunity to be able to host this program. And I thank all the faculty who have taken out time and traveled all the way from all over the country. And I hope that we are able to do justice to your time. Right. So I would like to speak on robotics in TCAR. Does it solve all the problems? So just, in the morning there was a query left at the end of the surgery if the flexion deformity, if it was showing a little flexion or not. So this is just from the side. We wanted to show just after the final implantation. Just after the final implantation. And that's the final tracking without touching it was 6, and that is what we aim at. Okay, so we started this hospital in November 2017. And why did we choose robotics in the operation theatre? Accuracy, precision, of course, partly it was glamour. So apprehension for starting robotics was cost, the additional cost, the stress for it, the transition for navigation. We've been using navigation since 2008, patchy in the last 10 years. Learning curve, increased surgery time, we were worried if there'll be infection or not. Stepping out of the comfort zone and actually, learning something new. When something is going on right, why do you want to change it? Why should we change it? Changing the implants that we were using earlier as a routine, staff training, and results, will it actually work, what they are promising? And extra costing issues for our patients. Finally bought it. First we had the Navio, now we have Navio and Cori. Initial 20 cases was euphoria. The staff just needed one sawbone demo because they were doing navigation, so they were able to adapt to robotics also. The first 5 cases we opened up all femore, conventionally cross-checked with jigs. We had some hip registration issues with the side supports. And questions to be answered in total knee replacement. Exposure, not yet robotic, still have to be there. Osteophytectomy, not robotic. Planning, of course, robotically possible. Bone removal, robotically possible. Release is robotically possible, deciding how much. Ligament balancing, robotically possible. Alignment is robotically possible. Tracking, it is robotically possible. Complex primary bone handling is robotically possible. Soft tissue handling like snips, cordyceps snip, and other special exposure techniques, not robotically possible. Avoiding complications, that's the idea with a disclaimer. Implant options, somewhat possible. We've been doing other company implants with the Cori system. And improve outcomes, yes, somewhat possible. It's technology in evolution, and more, more data needs to be, and more robotic surgeons need to pool their data and come out with, a scientific basis for showing that it's better. That's how you plan. So bone removal, ligament balancing, deciding the releases, it is possible robotically. Alignment and tracking, of course, it is possible robotically. That's how it is. You can see, you've seen 2 surgeries already, and you'll be seeing 1 robotic uni now. So that's the tracking that we aim at. Avoiding complications, like I showed in the live surgery also, if it can show red, you can just keep on rubbing it with your burr, nothing will be cut. It will just turn red and it will warn you that don't go there because it's already finished, that part. Implant options, now this is another company, Merrill Implant. We've used Cori to do it, so it's a very versatile system. It helps you plan. I mean, Smith and Nephew may not like it, but you know, it's a good thing about their system that it's a versatile system and you can adapt it to use other company implants also, which is not possible with all the robo companies. So that's one advantage of using Cori. Improving the outcomes, what does it mean for the patient finally? Minimum retraction, minimum ligament release, so minimal pain, minimal bone removal, perfect tracking with the kinematic balancing, minimal bleeding and risk of embolism, we don't open the canals, better alignment and tracking, will it lead to long-lasting knees? So this is a small study that we did, the consecutive 508 patients done robotically in 890 knees, 126 unilateral, 382 bilateral, average age range was 46 to 84, most of them were females, and around 85 kg was the mean, was the average weight. Implants used, various implants were used. Tourniquets, 140, you saw no tourniquet surgery. I worked with Dr. Nilen 20 years ago, and you know, he's still doing surgeries without tourniquet. We are moving there, but you know, it takes a long time to adapt. First is the mindset of the surgeon. Once you get there, then you need to train your OT staff, be convinced, but don't get sold to no tourniquet only. You can keep the tourniquet on in the beginning unless your anesthesia and everything else is perfect. You know, you cannot do no tourniquet just right for all the cases. So drains we've stopped using now. This was the time we were using drains. 63 cases we gave spinal adductor canal block and cocktail injection intra-articular. And bilateral we used to do combined spinal epidural at that time. We've stopped doing it completely now. This was the medication protocol. We give a Nicoxia and gabapentin in the morning, and we give adductor canal block. Used to do the IPAC earlier in those patients, now we don't do. It's again operator dependent. Intraoperative cocktail is saline, ropivacaine, clonidine and epinephrine. Patients who are hypotensive, usually low baseline blood pressure, we don't use clonidine in them. And otherwise, anyway, this gets divided into two. And we give one Magnex Fort, which is cefoperazone sulbectam at induction. And one, this is 100, no, this is 1000 at Tranexa at induction, and one at closure again. And we give one 750 mg amikacin for selected patients at closure. So 863 varus knees was average pre-op deformity of 13.2, and 27 knees average 10 degrees of valgus. We were able to achieve 96.8% planned target, you know, mechanical axis in with less than 1 degree variation, and 7 out of 225 had 3 degrees variation. So we recognized in these 7 patients, we recognized error in tibia vara, in the tibial varus and in femoral valgus, probably because of hip registration issues. Like today also you saw, in spite of being a live surgery and 300 instructions, still the side support was a little tight than what I would want. So circumduction of the hip, you know, the side support can actually hinder it. So we use the green leg holder for that, and becomes easy. So no pin was knocked down or moved even in a single case. Trackers were changed in 9 cases during surgery. We ETO them to save some costs. Besides the first 5 patients, 2 patients were rechecked with conventional jigs intraoperatively. We opened the femur, put the jig and rechecked if the if the bone removal was okay. 1 patient had cellulitis at the tibial pin site, just 1 patient of all these. 2 had superficial wound infection needing IV antibiotics for 5 days, at 7 days onwards. And 3 knees had superficial wound infection not needing any IV antibiotics. No clunks. 1 patient had a bilateral patellar subluxation almost 6 months down the line from surgery, and he turned out to be asymmetrical polyneuropathy, which was probably not detected in the earlier preoperative examination by us. So 83-year-old had a cordyceps rupture 3 weeks, which was repaired and immobilized for 4 weeks. Another 78-year-old gentleman had a spontaneous hemarthrosis 3 weeks. He started driving a scooty at 20 days from surgery. We evacuated the clot, and 2 weeks later he subsequently bled in the calf which was again evacuated. So no blood dyscrasias were detected. The patient's doing well now. DVT was detected in one patient of all these, obese, classical patient. In spite of the prophylaxis, she developed DVT. All patients more than 65 years of age or 70 kg weight, we give them post-op DVT prophylaxis for 3 weeks. We had MI in 2 patients post-operatively. Both were unilateral patients only, both second day post-op with previous histories of ischemic heart disease and CKD, either of the two. Both were resuscitated during physiotherapy. They had it in the corridor in the ward. The MOs were present there, resuscitated, and both did well. One of them had angioplasty in-house itself. No stress fractures were seen. So distinct advantages of robotics TKR, unbelievably detailed planning. You've all seen what the eye can't see, we can see with artificial intelligence algorithms. Extremely reliable sculpting of bone in ways which is not possible with conventional tools. Kinematic balancing, much faster functional recovery, and no opening of the bone, so minimum blood loss. Thank you for a patient listening.
Thank you so much, Shubhang. It's a wonderfully done surgery and good talk. Now, robot is a new kid on the ground. Now, when we started using the computer navigation 2005, we realized after a few surgeries that the computer was suggesting a larger femoral component. Now, today we saw you also choosing a smaller component than what was initially planned. So, do you do it in a routine? I mean, is that your observation?
It's our observation, yes. I think the other surgeons will also concur that it definitely suggests bigger. I think what it takes into account is the outermost point for suggesting that mediolateral of the implant. So with the company that we are using, Smith & Nephew, they've got an option of a narrow implant, so you need not change the size, just change the mediolateral dimension. So most of the times you have to undersize one mediolaterally.
Yeah, and two recent cases that I revised, the robotic knees are done, and both these cases we found out that this femoral component that was chosen by the earlier surgeon was larger, and you rightly mentioned. Yes.
Can I have one question? Sir, your robot can't choose correct femurs for you. It requires more exposure than conventional, sir. Probably for robotic surgery. You require 2 additional pins. Initially it's a time consuming.
Yes.
So what are the advantages the robot is giving to you over navigation?
Okay, so one thing in navigation, there is a burr removal of bone exactly where it is. In navigation, unless you have the spring tensor, which is rare, not everybody gets it, not all the systems have it. So unless you have the spring tensor, you cannot really assess your ligament tension in navigation. All it does is tells you your mechanical axis and then you take the cut. And like I showed today, you take the cut, but the cut is still wrong. You think it is correct. We have been jamming your femur and feeling nice with nice fit of the, box preparation guide, and you feel it's a very nice fit, but actually from the plan, you've left bone because the blade has played. Now, whether this is going to be clinically relevant or not, time only will tell. This is a technology in evolution. More and more surgeons are using it, and it's giving good results so far. The functional recovery, alignment, everything looks better.
Navigation, the trackers, where the small amount of fat will spoil it. And so I think the robot is not having that issue.
No, it doesn't have. The trackers are nice and they are ETOable. Right. So you can just re-sterilize them. And even if there's a splatter of blood, you just wipe it off with a wet mop. It will mostly be okay. Right. After a few cycles of ETO, it will bubble up. Then it doesn't detect it. You have to discard it. Right.
We can do 20 cases with one set.
Yes. I didn't want to disclose that.
Now, that's a major saving.
And about the oversizing, yes, it's a problem in, I'll say about 1 out of 10 patients. Right. Not all the patients will have oversizing problem. And I can suggest that you chop off the anterior part of the femur with the saw, and then we should not have this oversizing problem. Right. And then you should register after that chopping off the anterior lateral femoral.
Yeah, so just like you do your conventional, you remove all the osteophytes so you get a better size. Yeah.
Right. Very nice.
Thank you.
Thank you so much, Dr.
Thank you, Dr. Shubhang Aggarwal, and I also take the opportunity of thanking the chairpersons for this session. So we are grateful to you, sir, for your presence here. So next, I think we can take the time off for tea because let it be running because we are just falling short of the time. We are roughly 1 hour behind the schedule. So for that thing, I think we can start with another very interesting third live session by Dr. Narendra Vaidya. For that, can I have the moderators for this third live session on the rise, please? Dr. Ramesh Sen, Dr. Nilen Shah, Dr. Avtar Singh, and Colonel Nitish Kumar. Kindly grace the chairs with the presence, sir. Can we have the live surgery feed? The topic is again the robotic topic. It is a robotic unicondylar knee replacements by none other than the expert in this field, Dr. Narendra Vaidya from Pune.
Yes, hello everyone. Can you hear me in the auditorium?
Yes, sir.
Yes, so we have this patient who is a 51-year-old male patient with a typical anteromedial osteoarthritis. I'm going to do a medial compartment UK. So now I'll start with the indications of selection of my patients of each age. So typically I select the patients who are whose BMI is less than 25 first of all. Number 2, they have a typical anteromedial osteoarthritis. I do not do the MRI of the patients preoperatively, but do the true lateral X-ray to see that the defect is not going posteriorly, posterior to the midline in the coronal plane. Clinical stability is very important. ACL impact is important, but it is not as important as the patient whom you are taking for Oxford, because that is a mobile bearing knee, whereas this journey knee is a fixed bearing knee. So you can see now I have done a paramedial approach, parapatellar approach. We take out the fat pad. Is the vision clear there?
Yes, it's clear, Doctor.
Very clear.
Right. Retractor.
So this is probably without tourniquet?
No, I applied tourniquet.
Okay.
I have elevated the limbs, no edge marks, and I am comfortable with tourniquet there. So you can see it's a very nice case for a unicompartmental. Number 1, the patient is thin. Number 2, the patient's age is 51. That is, both the extremes are good candidates for uni. Number 3, he has got only involvement of the medial compartment. You can see the bare bone there on the medial side. Now in uni, I would like to say some things that in uni, the principles are different than the total knee replacement. In TKR, our aim is to correct the deformity, whereas, in the
Dr. Vaidya, what is normally the length of your incision? It's like your TKR or slightly smaller?
Sorry?
What's the length of the incision? Length of the incision.
Length, I have taken slightly bigger incision here, about 4 inches. More than length of the incision, it is the accuracy which is very important for me.
Right.
And I have taken slightly 1 inch above the tibial tuberosity, and this is just above 1 inch above the patella theta. So now I will be placing the pins outside the incision anterior-posteriorly.
And that pin you have put is for retraction?
Yes, because I cannot have somebody standing in front of me because the camera will come in the way of my camera.
Yeah, that's a good idea actually.
Yeah, so I put these 2 small pins there. You have to ensure that you are, in pin placement, you are in the center of the bone and not going transcortical.
Narendra, will this impinge the quads or the quads are retracted?
Quads are retracted.
Okay.
I have taken that actually retractor there. Yes. So you have to ensure that the pins are unicortical. This is at a 45 degrees angle to the tibia. So now these are the trackers which are very fast trackers, and they have got fast registration properties, so you have to put it in the femur and tibia. You have to ensure that it is visible on the screen. You can see now, is there the picture on? Yeah, so camera 1 is big, right now? Okay. So once I am done with this, I ask you to change the camera.
But patients इतना मानते नहीं हैं.
Right, so you can see in the screen that I am taking it throughout the range of movement and ensuring that I am visible throughout the range of movement. Yeah. So now we go for the next. You can, now the setup was slightly different than what Shubhang did. So I generally like to operate the screen myself rather than the technician operating it. So I have kept this tab which is draped here on the other side of the patient. Generally I have a Mayo's trolley here and then it's easier to operate. But here the situation is slightly different. Picture. So now we have to register. I don't put those pins. There are some laser marks on the tracker. So I registered these laser marks itself. The medial malleolus. So I push. Yeah. So the medial malleolus, lateral malleolus, and then you have to take the limb through a circular range of movement without moving the pelvis so that there is no error. So we determine the center of the hip, neutral alignment. Then that was a non-stressed alignment. Then I take this Z retractor and I put it on the medial compartment, press with my thumb, which gives a physiological pressure to the joint, and then take it through the range of movement. So you can see there is the opening on the opening of the joint. This is to assess the ligaments. So
that's a good option. But you also must cut it.
Right. So after this, we have to start the mapping.
We must embrace.
First point is the tide mark, the center of the femur, the most distal point, most posterior point, and then you have to just move it on the medial femoral condyle. So it creates a real-time virtual image of the medial femoral condyle. Any questions up till now?
How many lateral unis do you do?
Sorry?
How many lateral compartment unis do you do?
I have done only 2.
And you take the same approach or you go from the lateral side then?
Lateral side.
Okay. And the patellofemoral joints, how many you have done?
Patellofemoral 4 to 5 I have done, I think.
Okay.
That was mainly post-traumatic patellar thing. So this one point I would like to emphasize. This now, can you focus here and show my tracker? See, it is very difficult in uni to get the tibial rotation right with a conventional instrument. Whereas in this, you can put this tracker in the notch here and take it, and you can see that it is not properly oriented. So I make it parallel here and go back and then take it again. So my orientation is absolutely parallel. Can you appreciate that now?
Yeah.
It's parallel to the central line.
And do you have to register till the far point on the posterior side?
Yes, that yellow point which is here right now is the furthermost point. Sometimes it may not reach there, but that's fine. That is to, even in tight knees, it is sometimes difficult to reach there. But it has already calculated the slope, so that's no problem. If there is some remaining bone, you can take it off with either nibbler or the socks that are on.
And you remove the medial meniscus beforehand or you do it later?
Say again.
Removal of the medial meniscus.
Meniscus later.
Later. After you have made all the cuts?
Yeah. Actually, I will remove whatever is possible right now.
Okay. Okay.
Just so that it doesn't come, but I will not try to remove the entire thing right now at this stage.
No, I need tea. Tea. No, normal tea.
Okay, so now we are done with the registration part. Now you can actually show the camera 2 as a large listing for planning. Camera 2. So you can see the robotic screen now. So now this is a planning screen. You can move all the components in all three directions for both tibia as well as femur.
Dr. Vaidya, can we remove the surgical video?
Sorry?
Can we remove the surgical camera now? Because we can't see the upper right corner.
Oh, actually, PIP is blocking the robotic screen. So, Vinay, can you just remove it and just show the robot?
I want this screen to be big, the robot screen to be big.
Yes, but when we do the robotic screen big, the PIP.
We don't want this image right now.
So, for a minute, you can just remove.
For the time being, only the robot screen.
Vinay in the OT, can you please switch off? Yes, thank you.
Yeah, they are doing it, I think.
It's done, sir.
So, yeah, it's okay now?
Yes.
Yes, so we have this sticky images where you can see that how the implant is going to fit on the bone. Yellow is the bone and the silver is the implant. So it is like this. But I like this cross section. You can see this cross section, which is gray is the implant and yellow is the bone. So I match this particular thing. It's actually child's play. You have to just match the component to the natural contour of the bone, and this is my basic planning at this stage. Ultimately, when we see the balance the knee, we can again adjust it. So this is the tentative sort of alignment which will be there. I'll move the prosthesis medially. So the beauty is that you can actually visualize it before cutting. So the advantage of robot is that you do a virtual surgery on computer first and then take cuts, which is an extremely great advantage. On tibia, generally I am having a fixed planning that I do only 5 to 6 millimeters of cut. I have aligned a midline here and then slope I keep it at 5 degrees. So this is my standard planning. After this, now this is the graph which I am getting. So you can see that in extension it is quite loose, whereas in flexion it starts becoming tight. So I have to balance this. So just remember this graph, which is extension loose and flexion tight. So I will distalize the femur now. So to tighten the extension gap, so I distalize it and anteriorize it to take it, like this. So this is my graph now. So I have got a completely sort of balanced graph, which is from 5 degrees varus pre-operatively to 2 degrees varus. In unicompartmental, the aim is not to correct the deformity, but the aim is to resurface the bone which is damaged without release. So under-corrected. Overstuffing of the uni is always a problem, and that's why you should never do it.
So
Any doubts at the planning?
was good. And Dr. Vaidya, in doing robotic uni, I think we are addressing most of the issues by the femur. Not by altering the tibia, but by altering the femur.
That's a great point. Actually, see, in a uni, most of the failures occur on the tibial side. So my tibia is always constant, 5 to 6 degrees, 5 to 6 degrees of slope, and 5 to 6 millimeters of the cut. That's a standard thing. So you can adjust all and balance the knee with complete repositioning of femur. So if you saw that, we moved the femur superiorly, that means proximally, and we moved it anteriorly. So actually the effective movement was diagonal. Can you appreciate that point?
Yeah, we could.
That's why we could correct the extension and flexion deformities both. Extension laxity and tightness on this. Both we could correct.
And another thing which I have analyzed about this technology is that our younger generation will be good at this technology because we are old timers and we had never no exposure to the computer technology. But the younger generations, they play with the computers like anything. And hopefully they will do better with robotic technology.
So now you see this robotic screen where articulation is going to be there. So you move this and you know how this is going to articulate. So it is showing you everything. Before actually starting to operate, it is showing you everything.
Narendra, one point, the femur is 5 and the tibia is 4. So is that usual, or would you try to get a larger tibia? Because if the failure mechanism is...
I will believe this basically robot because it has showed me my mapped area and it has actually done this thing. But after trial, you can always change the tibial size. But generally I go by the robot size.
Would you try to put the biggest tibia possible?
Yes.
Okay.
So now I have started preparing for it.
Can we have that other screen, surgical floor camera on?
Yeah. So keep the robotic screen larger and
PIP
operating screen smaller. Boss, larger here रखना है और ये.
Vinay, please switch on the PIP. Yes. Robot. We are ready.
See, actually uni-compartment replacement is a great surgery in select group of patients. And the main determinant for the long-term success or long-term survival of a uni is the accuracy of implantation. Uni is very technically demanding surgery conventionally. And no company, I have used many company implants, but no company's implants are actually precise. And there are a lot of variations. Just to tell, people read about Oxford and talk about Oxford, nothing against Oxford, but in last year I revised 8 Oxford knees done by a very good surgeon. So it's not the surgical problem, it is basically the instrumentation which is not extremely precise and the variation will give all sorts of problems. I had breakage, device for breakage of poly of Oxford, dislocation of bearing, substituents, all sorts of various reasons. So with this now, the accuracy is extremely high. Number 2, the reproducibility is perfect. The reproducibility, you see consistently the X-rays are same. You don't have, any variation and, any virus in media or, sometimes it is slightly in tighter knees, difficult to go all the way posteriorly. That time you can change the mode to speed control. Right now I am just doing the exposure control mode.
While you are shaping the femur, sir, can I ask you, if you choose between mobile bearing versus fixed bearing uni, what would be your preferred implant and why?
See, basically my preferred thing is robotic UKR, not implant wise. So any implant put right will give you good results. Now you see the registries, then you have seen, we can see that even the fixed bearing has got, initially Oxford or mobile bearing results were better. But now you have many papers coming up with fixed bearing which are equally good as far as the survival is concerned. With robotics, it is going to add accuracy and I think
what I think is most important rather than type of implant, it is the accuracy of implantation, which is the most important determinant as far as the results of uni are concerned.
So what are the what are the modes of using the burr?
Yes, we have two modes here. I will just show on the screen till they are cleaning it. So you have this exposure control and speed control. So I am using the exposure control in which the burr will continue to rotate and it will retract and come out of the sleeve. While in speed control, it will stop rotating if I am out of the zone of cutting. So I am almost done now. This part is a bit tricky, posteriorly always, and if required, you can change the mode of burring.
Are there any special tricks for burring, or you just hold it and do it?
Actually, if you are doing arthroscopy, it becomes easier because I am looking at the screen and burring. You should not look at the bone and do the surgery. This surgery after exposure, you have to look at the screen and do it. So, burring you have to come from superior to inferior and go clockwise. So that is the only recommendation from the company. You should not go from below upwards, it creates more bone dust. So I will prepare the logos now. So all the, going back to conventional and robotic, all the conventional instruments which are not very precise with any company are replaced with one intelligent handpiece which I am using. I have not used any other instrumentation right now. So this one handpiece is doing all my work. So my logos are also done now. Now for tibia, so for tibia I will use the tunneling method. So I will protect the MCL here. So instead of going from top, what I do is I tunnel this and go vertical, directly posteriorly, removing the bone. You have to take care of your eyes. There are a lot of sharp bone pieces which come out. Generally I use a helmet, but today I am using this screen shield. But you should take care of your eyes when you are doing robotics, with especially burring technique. So unlike TCAR, where we can use various modalities, in uni-compartmental, only total burr helps us because it's a restricted area, you can quickly finish it off, and it is absolutely precise, so there is no need of refining anything.
So here it appears that the burr has kind of migrated a little bit more than the intended area. Is that so? I mean, it must be a very small thing. Like I can see some impression on the intercondylar eminence. I can see a little bit of impression on the anterior tibia also.
This one?
Yeah. So
actually, it doesn't damage it. Now I am touching it here, not burring, but it is showing me that I am on wrong place.
Okay.
My burr is not on right now, but it will, if I go out of the zone, then it
Yeah.
will show red. It is like a signal given by it. Actually, it has not removed the bone. So as I told earlier, this camera is a faster camera, so the reaction time is almost 4 times faster than the Navio. And that's why, the chances that it will damage the normal bone is very slim, or almost negligible, you can say. So that's it. I think I will give a wash and show you the surfaces.
Nilen, there's also studies which says that if you have like saw cut on the proximal tibia and very smooth, whereas if you have the burr, you have these small serrations and depressions. The cementation actually is much better, the fixation of the implant.
They are coming up with the data for that. It's very logical. If you have enough surface, then cementation will be better.
As you saw, when Shubham took the cut, there were a few rough surfaces.
निकलेगा थोड़ी अब वहीं रहेगा धोगे तो भी निकलेगा It's very easy.
So you can see the surfaces absolutely. Just check for any posterior osteophytes. There are none. So we are good to know. Just to remove those small green spots, this raft is very useful. This has got, one smooth side and one double side. So just rasp it lightly from all sides to remove any spikes of the bone. Yeah. So this side 4 is, I think it is fitting for absolutely perfectly.
I think this Cody system is the most versatile. If you have to go back in planning, just touch of a button and you can refile it.
This base plate has got small spikes, so it fixes integrity. Before making the lug holes, there are small lug holes here. I always like to do some K-wiring because sometimes the bone can be sclerotic and it can, develop a stress fracture there. So I will do that and then
That's a good point, similar to what I was saying in the morning,
Correct, yes. So this is the 8 poly which I am putting in right now. Yeah. So now I check what is the alignment and how we are doing. Product Mango. I just clean the tracker. Yeah, so we plan for 2 degrees of varus. We are up to 1 degree varus now, and 2 to 3 degrees flexion. That is fine. And this is my alignment. You can see it's nicely, evenly, aligned, and you can see the graph about 0.5 millimeter loose. so I'm not overstuffing the medial compartment. So now I go for the final implantation. Any questions?
Looks very nice.
Yeah.
Have you done unis with a medial release also? Little bit?
Sorry?
Have you done unis with a little bit of medial release also?
Generally, I don't do much with it. Mostly not. I will rather adjust it in the positioning of the implant.
Okay.
In general, for UKS, this medial release is not allowed.
I know it is not allowed, but I think a fixed bearing uni may tolerate it.
For fixed bearing, some people say that it can be done, but I generally don't do it.
And he said that he would do it in ACL deficient knees. Those would have some degree of contracture of the MCL.
Yeah. So, but still, I think you need to be very careful about, because if the moment you do touch deep MCL, the gap opens up.
ACL deficient knees and MCL contracture, they are two different things, sir. In the medial contracture where you require release, uni should not be done. ACL deficient knee fixed bearing unis can be done because they are going to last at least 7-8 years. Generally, their condition where patient age is 70, 75, and you think the implant is going to outlast.
Yeah, but my point is when the ACL is deficient, generally the patients have a fixed deformity in the osteoarthritic process.
Not always, sir. I've done roughly about 10 cases, sir. Generally, there are cases, it may or may not be correct. ACL may be deficient, but still the deformity has not progressed that whole compartment has become arthritic. There is still some time has left, you have picked up early.
So, good point, Nilen, but I think we have studies even from Oxford coming up now. Hemant Pandit and companies who have said that you can do Oxford in ACL deficient knees also with almost same results. The ones where we had failure were the phase 2 trials where the Oxford did not have that much of the curved lip on the actual poly. But now that, since they have had that, they said you can do deficit in ACL also.
In mobile bearings, the problem is of
Dislocation. If there is ACL deficiency.
So now that the poly
removes this problem.
Yeah, now the poly has much thicker lips, so that dislocation rates have been taken care of. So now they are more adventurous.
Dr. Vaidya, one question for you. Dr. Vaidya, one question for you. Have you ever done ACL reconstruction and uni in the same sitting in a young patient, say around 50, and who is athletic? Uni and ACL reconstruction together.
Two patients who have done. They have done well.
And they were young patients?
Yeah, they are young active patients.
Okay. So how do you adjust your tibial tunnel in such patients? Or it remains the same?
How do you?
Adjust your tibial tunnels in such patients.
Actually, it's slightly, when we take it slightly medial, the tibial, this surface not exactly going to the base, it's 1 millimeter or so there. And this doesn't have a fixed touch, the tibia, the journey tibia. So actually it doesn't come in the way of the conventional ACL connect also.
So the message is that they can be done together.
Yeah. With this implant, this can be done. I don't know the experience of Oxford surgeons, whether they do it or not, but for fixed bearing, if the patient is elderly and ACL is deficient, but clinically it is, what you can do is reduce the slope. Instead of 5 degrees, do it 3 degrees or 3 to 2 degrees, and that gives a good stability in fixed bearing. So that is another way of tackling ACL deficient knee, in fact that is in slightly elderly people.
But that thing will hold true of these osteotomy on the other side also, sir. You are reducing the slope on one side, and the other side slope is normal. So it's kind of confused me.
So the poly should fit easily, that is the trick, and we have, I think, got everything. So I will check the alignment again because we have saved the tracker from this. Ensure that you remove the entire snow.
Narendra, fantastic work. I think all of us deserve a good lunch now.
Yes. I will join you in some time.
Yeah. Thank you.
Thank you.
So since sir has already demanded for the lunch, we are going to break for lunch. I would just like to acknowledge the anesthetists in the OT, Dr. Pooja and Dr. Harleen, and the entire OT team who are present in this case. Thank you, wonderful job done. So we would like to break for lunch. There is a master panel on the knee which we were supposed to have, but I think we'll have the master panel of the knee and hip together so that it saves time. Thank you.
Thank you. I take the opportunity of thanking the moderators for this session. Thanks a lot, sir.
studied the dislocation, and these dislocations were in the safe zone only. The cup was in a safe zone, and it did not matter as far as the dislocation rate was concerned. Meaning by, when we are doing all these activities, our patient is doing all these activities, is that safe, reasonably safe? First thing was told that when you take an AP view, as Professor Sudhir told, this was an extra element, that this view for the assessment has to be in a standing AP, not in a lying down AP, because there is little tilt if you see the difference in the two within the standing and supine. That difference becomes much more clear, and obviously this standing view gives the right amount of inclination, right amount of aversion, and that is an important part to understand. So standing AP view, internal rotation, as was told by Professor Sudhir. We all know from our standard perception that the classical element of offset is an important part in the restoration of the offsets. This is very well proved. Now look at what is happening at the lumbar spine. When a person is sitting, if now he is kyphotic to stand because he has to maintain himself, little lordotic, that mobility occurs at the spine to readjust. If his spine is flexible, this is a natural way of adjustment, he doesn't get a problem. But if the spine is stiff, lumbosacral area is relatively stiff, what happens? When he tries to stand up, there occurs a hyperflexion and anterior impingement, even when we have put the cup in a very right position. And anterior impingement leading to a dislocation. So a stiffer spine will make the hip in a properly safe zone unsafe. No fault of hip positioning of the cup. It is the fault of the spine. And they say have the two views in this position. Now look at these x-rays. In a flexible spine, this is the kind of a tilt which happens when the person sits over there. His sacrum, you can see, moves like this in the sitting position. So this cup, which was like this, actually becomes like this in a sitting position. Now this sacral slope, whatever can be measured, it is usually between 10 degree to 30 degree. So this is a kind of a natural range which is likely to be there in a standing position to a sitting position. But there could be hip like this. There is hypermobile kind of a hip. There could be situations when the spine is hypermobile, more than 30 degree also. Or there could be a minimal change. Now look at this patient. This and it is same. So practically less than 10 degree. Now this is the patient where your cup placement will be affected. Because the kind of movement which is required for a flexible spine to allow for the standing position may not happen in that case. I'll give you. So this is the importance that we have to understand the importance of implant position in this kind of a scenario. So I'll take you, if the video works, that when we are sitting or standing, this is the kind of the movement which is happening around between the stem and the cup during this posture. So that's the basic understanding we are going along with. Now look at this. Right now what happened normally? Normally this is along with the sacrum, this is the horizontal line and this is the angle. When the person sits, the cup moves like this. It has moved like this, and this is the axis of the cup opening, and here there is no impingement. Now look at the other scenario. There is no movement here. So here look at it. Because there was no movement, cup stays like this. And what will it will lead to? This is anterior impingement and posterior opening out, and the hip can dislocate out. That is the reason what we need here. We need little more change in the position of the cup to reduce that part. And when the stiffness is happening, when there is a lumbar spondylolisthesis, and all these problems are actually restricting the lumbar spine from a movement. And what it is leading to? It is leading to a stiffness. Now, depending upon how much the stiffness, Now, as Professor Sudhir told the various things, this thing also comes into that very category. When you are expecting the spine to be stiffer, you have to look at it. So this leading to this kind of a situation, the tilt which is there, it is becoming static due to the situation is there. So this is what we need to. Another line which is taken as important is this line between anterior spherical spine and pubic symphysis. This is a anterior-posterior plane of the anterior plane of the pelvis. In routine, in a flexible spine, it is always straight. We all from our anatomy knowledge that the both are likely to be in the same line, the pubic symphysis and anterior spherical spine. If you have got an X-ray little tilted also, you can have the center of the two ASIS and have a center from that, that becomes the straight line. What happens? It could be tilted back or it could be tilted in front. Here it is tilted into the front from the neutral line, from the vertical line. This is 8 degree. This is tilted backwards. Here it is tilted backwards from the front. So you can see this is a different way. If this is again with the normal range, it may not affect the placement of the cup. But if there has been a deformity, this is not my X-ray, here there has been a deformity, it could be a significant change. And when that is a significant change, it might affect the movement. Now, there are many lines drawn around the spinal pelvis. I am just picking the essential ones only. This is the another line which is supposed to be pelvic incidence. This is a line along the sacrum from the center of the sacrum and one towards the hip joint center. This is constant 55, whatever is the position. This is whether sitting or standing, it remains somewhere. That is a fixed, it doesn't move. Another thing is, you can see the same example in this area also and this area also. This angle remains same whether we are sitting or standing. Another important thing is now the lumbar spine, how flexible it is. So what is the level of the lumbar lordosis happening? And this is the line between two axes. The angle could be this way or could be this way. This is the lumbar lordosis level. Why I am talking about these two things is, if the difference between pelvic incidence and lumbar lordosis is more than 10 degree, it is a sagittal deformity of the spine. Another very important factor. So we could have a normal spine, we could have a flexible spine or a stiff spine, or we could have that flat back deformity where the anterior line is going posteriorly. Is it common? This is the data of prevalence of sagittal spine. 60% will be normal, 16% will have flat back, 25% will be hyperlordotic. So it is not uncommon. And what it can do, it can make our so-called safe zone unsafe if we put the cup in that very position. So it is a beautiful classification, easy to understand. I have reduced it to this classification. Understand, either it is normal or there is a spinal deformity. Spinal deformity, it has two further factors, normal spinal mobility and stiff spine. So either it is one with A, normal with normal spinal mobility, meaning by normal, there could be a normal with stiff spine, one. There could be spinal deformity with a normal mobility and a spinal deformity with a stiff spine, and these are the conditions. So this is a beautiful classification which has been given, and this is the kind of a management given. If it is 1A standard, it is 1B when there is a stuck standing normal element but spine is stiff, you change a bit. And if it is a flat back deformity, the deformity is there but mobility is there, again you are normal. And if it is a flat back deformity, depending upon which way, you will have to alter the position of the cup. And how this can be achieved? You are a good surgeon, you do a good planning, you can do an excellent workup with your technique or believe in what the company is putting up here, you can have a robotics for that. So my message is, when performing, I am adding to what Professor Sudhir told, standardized evaluation of hip and spine also, and pick up those patients who have either a stiff spine or a deformity of the sagittal axis, and if that is there, redefine your positioning of the cup. Here safe zone, so-called described, is not safe, alteration might have to be done. Thank you.
Do you think the such much high anterior approach that predisposed to instability in these cases?
The anterior approach is meant to take care of the capsular problem. Cup positioning will still be abnormal. So that is no remedy for this thing. That's no remedy. Cup position is a cup positioning. It might give you a little more liberty, obviously so, but then you cannot really feel foolproof in all those things. So it's better to be careful about stiffness and the flexibility of the spine.
So can we add a little
Please.
bit more to this? So our understanding, and correct me if I'm wrong, one is that you are normal. Spine moves well, you can forget about those patients.
Yes.
Whatever is at the hip, you go ahead and do it. One is they are stiff, but they are still in normal alignment, like normal lordosis. So again, you can more or less ignore them. One would be hyperlordotic. So those patients, you need to dial in more anteversion. And the ones which are like stiff back in the kyphotic, then those ones you need to dial in a bit more anteversion. And the amount you can dial is only about 10 degrees, not more than that.
Yes, that's the only thing. But we have to know about it and we have to do that kind of a dialing. Is that okay? Thank you. Thank you, everybody.
Thanks a lot, sir, for this elegant presentation. And in fact, you will get the another chance of hearing this elegant voice with another live surgery performance by Dr. Ramesh Sen as the 4th live surgery workshop on total hip replacements. Next, may I request Dr. Sanjeev to be on the dais, please. He'll be speaking on anterior approach. Dr. Sanjeev, please. Can you welcome with a round of applause?
Good afternoon. So my talk is on anterior approach to the hip. So can I ask from the audience if anybody does the anterior approach to the hip? Because traditionally hip replacement involves incision on the side of the hip, which is the lateral approach, or on the back of the hip, which is the posterior approach. And most of us are trained to do either of the two approaches. So direct anterior approach was first described by Carl Hutter in 1881 and then was propagated further in 1990 and 80s by Smith and Peterson. And with the special table for arthroplasty, direct anterior approach was popularized by Joel Mata. The principles and basic techniques of the approach are the same, whether we use a specialized table or not. So indications are many. So the hip, any pathology for the hip can be managed by direct anterior approach. So surgical approach involves positioning supine on the table, standard table. We can or cannot use the specialized table depending on the experience of the surgeon. And sterile field is up to the xiphoid process to the entirety of the lower limb. A standard approach involves an incision approximately 7 to 10 centimeters, 2 centimeters below and lateral to the anterior spherical spine, and goes down up to the lateral epicondyle, in the direction of the lateral epicondyle. So superficial dissection is mainly concerned about prevention of injury to the lateral cutaneous nerve of the thigh. So incision is made over the TFL and musculature is dissected of the medial fascia bluntly and retractors placed around the superior aspect of the neck of the femur. The deeper dissection involves fascia overlying the rectus femoris is opened and bluntly expose the anterior capsule, and the retractor is introduced on the medial aspect of the femoral neck outside the hip joint. We incise the hip joint capsule in a longitudinal or a T-shaped incision, and this exposes the femoral head and neck. The hip is dislocated by traction and external rotation, and the acetabulum is very well visualized now, and the procedure on the acetabulum part is carried out. The approach can also be extended down distally on the lateral aspect of the femur by either releasing the vastus lateralis from the region or bluntly dissecting it. There is a problem with regard to the femoral component because it goes down and it needs special retractors to be lifted up. So wound is closed in layers and care taken to close the lateral femoral injury to lateral femoral cutaneous nerve. Advantages of this approach are it's a rapid recovery of the patient, lesser hospitalization, lesser pain in the immediate post-operative period because we are not cutting any muscles, unlike the posterior and lateral approach, and more normal gait biomechanics, less soft tissue damage, more stable hip, no need for hip precautions as we do in the usual posterior and lateral approach, and access to the iliac crest in case we need to take a bone graft. So disadvantages are, it's a learning curve. A lot of studies which say that a lot of complications in the initial 100 surgeries by most of the surgeons. The injury to lateral cutaneous nerve, risk of fractures of the greater trochanter or of the femur, and we need specialized instrumentation to have access to the femur. So in conclusion, it's a minimally invasive surgical technique which involves a small incision on the front of the hip, involves less injury to the muscles along the natural tissue planes without injury to the tendons. There is a quicker recovery, less pain, and more normal function. Hip precautions are not necessary. It allows patients to return to normal shortly after surgery with a reduced risk of dislocation. So this small video.
So, forward centimeter incision from the anterior superior iliac spine, 2 centimeters distal, 2 centimeters lateral. Superficial dissection between the intramuscular interval of the sartorius and the tensor fasciae lata. Exposure of the femoral neck, resection of the capsule, exposure of the acetabulum, preparation of the acetabulum so the tight cortical fit is achieved with the appropriate reamers, compaction of the appropriate size acetabular component followed by the polyethylene bearing, exposure of the femur, resection of the superior capsule to allow for delivery of the femur, sequential broaching until the tight cortical fit is achieved. With the trial, femoral head reduction, confirming absolute stability through a full range of motion as well as equal leg lengths. Removal of the trial, compaction of the real femoral component, followed by the real femoral head, reduction of the hip, confirmation of stability and leg lengths, and then closure.
So in my opinion, it's a good approach to know about, but we should stick to the traditional approaches that we are used to, which is the anterolateral approach or the posterior approach. Thank you. If we're talking about the hip replacement, I think most of the surgeons are trained in anterolateral approach or the posterior approach. Only some of the surgeons that I'm aware who want to venture into something new and something different are going into the anterior approach. It leads lot of, it's a slow learning curve, a lot of specialized instrumentations are required, and indications, there are hardly any. I think maybe one indication that I can think of is when the acetabulum has been fixed anteriorly, fracture of the acetabulum, and you want to do the replacement. So that is one indication where we can use this approach. But even that can be done by the standard anterolateral approach.
Is there any advantage in the ankylosed hip or with patient with AS
if we do anterior approach as
No.
compared to posterior?
I think access to the posterior part is less. Of the acetabulum is less.
The stability with the spine component, stiff spine component, will have more stability as compared to the posterior approach.
Again, as Dr. Sen and Dr. Sudhir gave the planning, if the planning is good, with the standard approaches are good enough.
Thank you, sir. Thank you.
Thank you.
Thanks a lot, Dr. Sanjeev. After that, we have the presentation from Dr. Abdul Ghani. He has come all the way from Jammu with us. Have a grand Punjabi applause for him.
Bearing surface. दूसरा bearing surface. ये वाला टॉप वाला. Very good afternoon to one and all. At the outset, many thanks to Dr. Shubhang Aggarwal and his team, and many congratulations for organizing such a wonderful show. My topic is bearing surface in THR. So at the outset, what is the background, why the topic is needed anyways? When we are talking bearing surface, essentially we are talking of the articulation between the femoral head and the cup liner, and what exactly the surface should be. Actually, there is ever-changing trend. Ideally speaking, the arthroplasty should last forever. I mean, as it should last with the life of the patient, but it does not happen. One of the reasons is because of the bearing surface, because it can lead to wear, and wear particles are one of the cause of aseptic loosening, osteolysis, and that leads to need of revision in the future. Because especially when you are talking about young patient, if you do a THR, their activities are high, the wear rate is going to be more, and hence there is a need of revision. So that is the reason there is a talk about the bearing surface. Although the THR, the total joint replacement, has been a successful and wonderful surgery, but there are essentially the failure rate, especially in the young patient, and one of the reasons is the choice of the bearing surface. If you take this slide, on this left top, there is a metal and poly, then you got metal and metal, you got ceramic and poly, and ceramic and ceramic. So why has to be variation? Why this controversy is anyways? Because there are limited long-term studies of the good bearing surface. Lack of long-term follow-up. It is mainly experience-based and at times maybe evidence-based. There are lack of RCTs with direct comparison. Ideally speaking, it should take 20 to 30 years to have a good result outcome. Then only you can decide. And in mid-term, however, there are similar outcome more or less with all the bearing surfaces. So what is ideal bearing surface, and do we have that? The ideal bearing surface should have a low coefficient of friction. It should not have any wear particle generation, no tissue reaction. It should be biocompatible. It should have a high resistance to the third body wear, and it should have enough of deformation of article surface to permit adequate fluid film lubrication, and of course it should be affordable so far as cost is concerned. When we talk of bearing surface, there are two major classifications: hard and hard bearing and hard and soft. When we talk of hard and hard, we are talking metal and metal or ceramic and ceramic, and we are talking soft, hard and soft, metal and poly or ceramic and poly. This is example on the left side in metal and poly, metal and metal, and an extreme right ceramic, and in between ceramic and poly and ceramic, metal and poly. So what are there are advantages and disadvantages. The main disadvantages when we talk of metal and poly actually get divided into two types, traditional poly and highly cross-linked poly. And there is invariably some disadvantage with each. With the traditional poly, there is more wear and osteolysis, whereas even with highly cross-linked poly, there is a decreased mechanical strength. And when we talk of ceramic and ceramic, there is a part of problem is breaking and squeaking. And metal and metal is going to lead to more high level of iron, osteolysis, pseudotumor formation, and other stuff. I mean, this is a picture, huge metallosis and wear, and that leads to early loosening, early revision, and lot of metallosis intraoperative. This is another example of chip fracture of both the head as well as the liner, and this is oxynium head, which is another type of bearing surface. The potential advantage of metal and metal was actually we could use larger femoral head, and that is going to lead to better range of motion. It is going to be more stable, it will increase the range of motion and decrease the articular pressure. With the decreasing head size, one can have a less wear, reduce friction, but it is going to be more unstable. But unfortunately with metal and metal, there are a lot of metallosis, pseudotumor, alveolar lesions, and there are potentially theoretically chances of high generation of ions, cobalt, chromium, which can lead to systemic toxicity in the form of cardiotoxicity, neurological damage, ocular toxicity, nephrotoxicity, and even potential malignancy as well. Hence, it has almost been abandoned now by surgeons and withdrawn by the manufacturer as well. Then the next line bearing surface is poly, essentially more or less called as polyplastic, and traditionally it used to be polytetrafluoroethylene. That was started by John Charney, and actually he inserted in his own thigh just to test whether what is the tissue reaction going to be there. But again, the traditional poly had major two disadvantages: high wear rate, and there is a lot of amorphous material. Then came high molecular weight polyethylene, and the latest is highly cross-linked poly, which is now available, and more or less all the companies, they are making this type of poly, which essentially is made up of more cross-linking. It is treated by heat treatment, and it is sterilized, avoiding any oxidation or exposure to air. Because this has got 86% less wear compared to the traditional poly. And latest is addition of vitamin E, because vitamin E is antioxidant, and because it reduces the exposures of the free radical and increases the wear resistance. It has got also the advantage that various offsets can be available, whereas with the traditional, with the ceramic, you do not have that option. Head sizes also, you can have variable head sizes, you can have elevated lips, and at times you may have to change the liner face. Nowadays, the latest is ceramic, which is more commonly used, particularly in younger patients, and it started though in 1970, and there is a lot of improvement so far as the composition is concerned, and now we've got 4th generation of ceramic available, and that is mainly comprises of 82% of alumni and 17% of zirconia. And in Australian registry, with this, there is a 92.8% survival of THR in young patient at 15 years. What is the advantage of ceramic and ceramic? This is hard, this is hydrophilic, inert, it is resistant to any scratch, it has got high biocompatibility, the wear is independent of the size of the femoral head. So that is obviously, this makes this particular bearing surface to last longer. And that is what the requirement, particularly when you are talking of young patient. However, it does have disadvantage. This is also not immune to complication. It has got a risk of fracture, both of head as well as the liner. And the squeaking, whenever the patient walks, there will be a particular noise, and that can be irritating. Of course, it's more costlier as well. Particularly the risk factor for the fracture is if there is this does not tolerate too much of malalignment, and especially version more than 25 degrees do not tolerate if there is any abnormal version. So you have to have a perfect alignment so far as the insertion of implant is concerned. Your technique has to be better. This is an example of breakage of the implant, ceramic implant. This should be avoided in extreme cases of excessive deformity, particularly severe DDH, or in excessive laxity. If the patient has got excessive laxity, more range of motion, again, even in younger patient, it should be avoided. There is also change in the version of the ceramic, and delta ceramic is more available, and it has got 97% more tougher. However, the rate of ceramic fracture is much less with the latest ceramic delta type, whereas the head diameter if it increases, the chances of liner fracture is going to be increases. You can also have another combination, ceramic and poly, and this has got obviously low wear rate and no squeaking and no fracture. Another bearing is oxynium. Again, the results are not as good as was projected initially. Ceramic and ceramic THA is correlated with better 10 years outcome. When it comes to the ceramic and ceramic bare surface, another study, lower rate of revision, osteolysis, radiolucency and aseptic loosening or dislocation compared to metal and poly. In New Zealand registry, the best combination, best bearing surface is ceramic and poly, even in the younger patient. This is a study from America in pediatric THR. Again, previously they used to do ceramic and now they have come up to ceramic and poly. Effect of the bearing surface does have a bearing on outcome and longevity in NGR in UK registered. In conclusion, long-term survival and satisfaction of patient is linked to the proper bearing surface selection. Not all polys are same, not all ceramic are same, they have got a different make. These features differ from one brand to another. Implantation tool can make a great difference. Ceramic in young and active patient, and ceramic and poly, highly cross-linked poly and metal and poly are valid option. What actually makes the difference is not just the material, but the correct surgical handling and the technique of the component, especially mainly the positioning of the implant. Thank you very much. Thank you.
Very good afternoon, sir. I'll just ask you, what is your personal opinion in young patients, whether you like to do a ceramic on poly or a metal on poly or a ceramic on ceramic?
In younger patient, personally, I would choose ceramic and poly. Reason it's slightly more forgiving. Cost-wise also it's slightly more balancing. So that is what it is.
Any personal experience with ceramic on ceramic squeaking or noise that the patient is complaining, something like that, sir?
Not much. Thank you. Thank you.
We are again having this company coming with Oxenium and Oxenium.
Yeah.
They're coming back. So after having metal on metal, again we are switching back to Oxenium and Oxenium.
I mean, we have to wait for the long-term studies, as I told you. Ideally speaking, it takes 20 to 30 years for comparative study or cities. Then only we would be able to conclude actually. But there is industry is going to evolve, of course. They will keep changing and becoming better day by day. Thank you.
Thank you, sir. Thank you.
Thanks a lot, Dr. Abdul Ghani. Can we have the next speaker on the dais, please? Dr. Rajneesh Garg. He'll be speaking on extended trochanteric osteotomy. Can we have a warm round of applause for welcoming him?
Thank you. Good evening, ladies and gentlemen. At the outside, I would like to congratulate Dr. Shubhang for organizing such a wonderful and informative conference workshop. So we really had, we enjoyed 2 or 3 live surgeries in the morning. So my topic of discussion today is extended trochanteric osteotomy, ETO. So I'll start with the case. It's a case 1, 61 years old female patients, hemi-arthroplasty done few months back somewhere outside, presented with a severe pain and movements, painful movements. All the movements are restricted. There was a history of, in this patient, there was a history of discharging sinus and debridement by the primary surgeon. So ES and CRP was high. So it's a cemented hemiarth. Similarly, another patient, again, almost similar complaints, hemiarthroplasty done just a few months back only. I think it was done in Jalandhar only. So patient was, again, had inability to bear weight and ES and CRP was high. And this was quite painful. So both the hemis probably, they both are infected, right? So what is the problem? How would you proceed with the surgery? What do you think?
Sir, kindly go back to the case 2.
Cemented hemiarthroplasty, 70 years old female. Now she has presented with a severe pain, fever, ESR CRP is high. So we had diagnosed TLC was high, it is infected hemiarthroplasty. So the plan is to actually remove the hemi and the cement. So what we are going to discuss here is that how you plan to proceed with the surgery, what are the problems you are anticipating in this case, how much time you think that it would take, blood loss, single stage or a double stage surgery, what is the prognosis and anticipated complications during and after the surgery. So like we have seen earlier talks also by Dr. Sudhir Garg also, that we have to plan all this. We have to keep all these things in mind. So what are the things you have to keep while removing this component? So first of all, it is difficult to remove the well-fixed component itself, right? And then you have to remove the cement. You have to plan that how will you remove the cement? How much time you are going to take? Blood loss, you have to prepare for the this blood also, and single stage or double stage. So most of us would definitely agree that we would like to, since it is potentially infected cases, so we would like to go for a 2-stage. First, we will plan for a removal of the implant and the cement, and second, we do some secondary surgery. So this hemiarthroplasty or total hip replacements, they are quite successful procedures. But in spite of all these success stories, we do have some problems where we face the failure and they need revision. But this revision surgery is going to be quite challenging in terms of the labor, time consuming, lots of complications, and has a guarded prognosis. So one of the most challenging aspect of this revision surgery is going to be the removal of the well-fixed femoral component and removal of the cement. Choice of the procedure in this case would be ETO. So ETO, this is starting from the greater trochanter and almost minimum 12 centimeters the trochanter along with the lateral diaphysis of the cortex to the variable length is ostomized to expose the femoral canal. Earlier in 1981, way back, was the first one to describe the trans-trochanteric approach to the native hip. But it was mainly popularized by the Sir John Charley in 1960s. So he advocated trochanteric osteotomy in all the patients, primary as well as the revision cases. But he also had the non-union rate of 4.2% and other complications. So this was a study published in 1972. But what are the problems with trochanteric osteotomy? In the hands of even great Sir John Charley, it was about 5%. But normally, the non-union rate is almost up to 10 to 15%, 9 to 18% chances of non-union. Then we have increased dislocation rates, proximal migration of osteotomy, Trendelenburg gait, and reduced patient satisfaction. So these are all problems with the, so there were then certain improvements. Glassman et al., he described trochanteric slide osteotomy to remove certain complications. Similarly, Wagner et al., 1999, transfemoral osteotomy, but ETO, it was 1995. It was first described by Younger et al. It was basically used by Peprosky in his revision cases, which he again published a paper in 1995 in Journal of Arthroplasty. What are the indications? The first and foremost indication is to remove a well-fixed, cemented or uncemented component. So if this component is very well fixed, what if we try to just pull it just like that only, or do lot of apply lot of force there? So what do you expect? The high chances of accidental fracture of the femur, perforation of the femur, and sometimes, especially in the case of both cemented also, but especially in case of uncemented, there can be a significant loss of bone stock. But ETO will allow a controlled removal of component in this scenario. Similarly, a well-fixed cement mantle in both septic and aseptic cases. This is one of the most challenging and time-consuming step. If you just try to remove the cement without ETO from a tube, it is very, very difficult to, believe me, remove the cement. Septic cases, if there is a certain level of quantity of leftover cement is there, still there, it will be always source of a recurrence of infection. So if we do ETO, it will allow us to do a thorough debridement and removal of the whole mantle of cement under direct vision. Similarly, in aseptic cases, if there is a leftover cement, what will happen? There are cement pieces there, it will, there will be undersizing of the stem, thereby subsidence. And also this components of the cement, they will put the, will put the, this stem in a malpositioned place. And there will be, since there is a cement, leftover cement is there, there will be lack of osseointegration in the cementless component which we are going to put. So this is a study which was published by Lurch et al. In non-ATO groups, there was 14% patients had a accidental femoral fractures and perforation, whereas no such complications was observed in ATO group. And even clinical and radiological outcomes were superior in ATO group because we were able to remove whole of the cement and there was no infected component of the cement which was left in the canal. Similarly, another study, Perk et al. Published in 2007. So almost similar views that stem subsidence, cortical perforation, complications, they were all less with the ATO. Another study published by in 2011, Journal of Arthroplasty, by Lim et al. So osteotomy along with the removal and debridement and temporary cement spacer insertion was done in 23 cases. 100% union rate of this ETO, the osteotomy at the second stage. So this is very, very important that if it is a well done osteotomy, you will be able to get 100% rate of the union. And there was a successful eradication of the infection in 96% of the cases. Another study by Pratik et al., Journal of Arthroplasty again, 2017. Similar results, 100% union rate, no case of perforation or accidental fracture, infection eradicated in more than 90% cases, and especially in this study, they had seen that in how many cases they were able to put a primary standard processes, not a revision processes, and 70% of the cases they were able to use the standard processes during the second stage. So this is so many advantages of extended trochanteric osteotomy. So what are the other indications? We talked about the revision cases, but what are the other indications? There are certain other indications also. So in certain, you see that there is a erosion, protrusio of the acetabular. So this is like this head of the process, it gets logged in the acetabulum. So sometimes it is very, very difficult to actually dislocate this head. Okay, difficult to remove this head, to mobilize this head. So ETO can be really come handy in these situations. So this is an example. So ETO was done and this stem was removed very nicely without any complications. So sometimes there is a varus deformity in revision cases. So you can do ETO and you can put a revision processes. Similarly, you can adjust the tensions of the abductor mechanism. You can also use it in a periprosthetic fractures, Vancouver type 2 and 3. So as compared to Chanle, who used trochanteric osteotomy for all cases, nowadays we are recommending ETO for a complex primary cases like we have just seen, femoral deformities, high congenital dislocations, or the revision cases. The approach, mostly used approach is the direct lateral or posterior lateral approach, though the posterior lateral approach is most commonly used. The mainstay of this, the success of this surgery will depend upon the vascularity and soft tissue attachment of the osteomized fragment. So in all cases, by any this thing, you have to preserve the vascularity and soft tissue attachments. The surgical technique, position of the patient, cleaned and draped. So this is one very important aspect, surface marking, extent of the osteotomy. So this you have to really plan pre-operatively. Many of us would get confused. Just 2 minutes, please. Last slides, 2-3 slides. So many of us would get confused the extent of the surgery. So we will do at one level, then it will not, the bone plug or the distal cement will not come out, then we'll again go back and again do a osteotomy. So you have to plan that well in advance, that what should be your plan. It will depend a lot on the quality of the bone, the isthmus, everything. So I'll just skip, this is the exposure, and I'll just go to the video last. So this is video. This case only, just operated last week only. There were 2 cases, so which we operated last and did the ATO. So this, since it is a polished stem, the removal of stem is very easy in this case. But in cemented case, or if it is a well-fixed stem, sometimes it is very difficult. So you can do osteotomy with stem in situ, or with after the removal of the stem, like we have done in this case. It is slightly easier when you have removed the stem. So now this is how, from posterior to anterior, you start with the posterior, just anterior to linea aspera, and all the soft tissue you see, the attachments are preserved, very well preserved. So you drill the holes from posterior to anterior. So you prepare it for the osteotomy. And then you have to do the transverse cut also, where anterior and posterior holes are meeting with each other. And then with the saw, you cut the posterior cortex like this. So anterior cortex, either you can cut, you can weaken with the saw only, or you cut it with complete the osteotomy with the osteotomes. But most important aspect in this surgery is to preserve the soft tissues and the vascularity, and prevent the complications like any injury to the neurovascular bundle. Sciatic nerve is there on the posterior side, femoral artery is there on the anterior side, so you have to be very, very careful. So once the osteotomy is complete, so this is the transverse leg of the osteotomy. This is again very important aspect. So you complete this step without any stress rises. So then complete it with the osteotomes like this. It should be anterior 1/3 of the cortex which should be removed, okay? Not through and through, half and half. It should be, and then now you can see the cement directly, and with the cement removal instruments, very carefully, you can directly see in the canal, and you can remove whole of the cement. And since, as we had discussed, it was an infected case, we had to do a thorough debridement and remove the whole cements, that there is no infected material is left in the canal. So once everything is right in front of you, so you can remove and debride under direct vision. So this is the post-operative X-ray, and then this is the another very important, this thing is the distal prophylactic encerclage wire. So it is very, very important to put a distal prophylactic encerclage wire distal to the osteotomy. Minor and at all, they found that even all the patients, in 15% of the patients, 10 to 15% of patients, they are always undisplaced cracks which are extending from the level of osteotomy to the distal end. So if you will put in you do the reaming, or you try to put an uncemented stem, it will open up. So it is always better you put in a prophylactic cable there. Method of fixations. Various cadaveric and non-cadaveric studies have shown that 2 to 3 cables are sufficient, and then steel cables are better than the steel wires. In case of steel wires, there is a 10% non-union rate, but in case of cables, it was 100% because of the uniformity of the compression, but they are slightly costly. So if you want to save costs, so you can use the steel wires, otherwise cables would be better. Method of fixation. So this is case 1, post-op. Antibiotic beads have been put. Case 2, which we have just seen the video of it, and again, and then they are waiting for they would go for the second stage surgery. So in conclusion, so it is basically reserved for the either revision cases or a complex primary cases. We have a direct access to the femoral canal. We can remove the cement, we can remove the component, we can remove the infected material from there, thorough debridement under direct inspection. If we completely remove the cement, we can put in a better Pacific uncemented stem. It will not be undersized, it will not be malpositioned, and minimal chances of fracture and perforation. It is less time consuming, less chances of subsidence and loosening. Union rates are 95 to 100%. And promotes induction of bone healing and ingrowth in revision with uncemented cement. Thank you very much. Any questions?
Sir, very good evening. Sir, I want to ask, like in case of aseptic revisions, in case you have a patient with a cemented stem, you have a loose stem, you take out the stem, you definitely go for a ETO, or you try to remove the cement with the flexible osteotomes?
See, you can try, if you can pull this whole mantle with something, if it is, you can, pre-operatively, you can see that a whole mantle is lying separately, which is very rare, okay? It is only possible sometimes in a septic cases or in a very osteoporotic bone. In those cases also, chances of complications are very high because the bone, quality of bone is very poor, bones are so I've seen, and earlier I also used to try, so I've seen many patients, it takes 2 to hours, the whole procedure, otherwise it is 45 minutes or 30 minutes. The cement removal, it takes 2 to 3 hours. The time is blood, and patient is going into shock and having so many other complications just because we are trying to remove the cement from the tube, which is very, very difficult, very cumbersome, and it is always inadequate. And then sometimes even I was able to remove the cement from proximal side, but I was unable to remove the cement from distal side and the bone plug. Again, I had to go for a osteotomy after struggling for 2 hours.
You can do cement in cement technique.
That is yes, cement. That's why I was told you that if you are going for a uncemented implant, or if the cement is infected. If it is aseptic technique and you are planning for cement and cement, then it is okay.
Sir, you mentioned, sir, that extended trochanteric osteotomy can also be included in very complex primary cases also, and not only.
There are few examples.
Yes, sir. Can you please elaborate on that, sir?
Yeah, few complex cases like I showed you, there's a locking of head in the acetabulum. So there's a fibrosis, lot of fibrosis. It is really very, very difficult to mobilize the head, and this you cannot do in normal cases. So we can cut with a saw. The head sometimes we cut in situ only. Here you cannot do that also. You do ETO and remove the whole stem from distally. Or complex primary cases like there's a bowing of the femur. There actually the primary stem will not go because it's straight. So the chances of perforation or the fracture or high dislocation, congenital high dislocations. So these difficult primary cases where you need more exposure of the acetabulum. So you think that the acetabular exposure needs to be enhanced. In those cases, you can primarily go for ETO. But not every case. As we just discussed, Chanle used to do trochanteric osteotomy maybe in the beginning of his series in all the cases. But it has its limitations, so you should try to avoid in all the cases.
Thank you, Dr. Nitish, for excellent talk.
Thank you. Thank you, sir. Thank you, sir.
Thank you, sir. Thanks a lot. My apologies for the next speaker. In fact, we have a call from that force surgery live session that the patient is ready. We are just going to operate. We have to pause for a while, sir. Kindly excuse us for that. Can we have the live surgery relay for the force surgery? That is by Dr. Ramesh Sen, dual mobility total hip replacement. My apologies, Dr. Rajesh Kapila. Kindly be with us for a while.
Hello.
Yeah. We are able to hear you, sir. We are just having the dais, the moderators. Kindly give us a minute, sir. So for this live surgery, may I request the moderators of this session, Dr. Rajesh Kapila, Dr. Abdul Ghani, Dr. Neeraj Bansal, and Major Parduman. Kindly grace your presence. So grace the dais with your presence, sir.
Dr. Sen, good evening. So we are ready here for you. The X-ray is being seen on the screen.
Okay, so am I audible right now? Hello?
Yes, sir, you are audible. Very much audible, sir.
That's great. So I'm going to the X-rays and let's evaluate the X-ray. If I have a point, some kind of a pointer, can you give me some wire or pointer? Yes, I'll take care. So
Is my artery visible? Sir, आपके पास mic? Yes, sir. Let it be visible. Is it visible?
Yes, sir. Yes, sir. Yes, sir.
Okay, so now I am concerned. Is that X-ray visible?
Yes, sir. It is visible.
So, yeah. So the important thing here right now we are able to see it. Little tilt in the pelvis, then we coming down to the hip. This is the normal side hip, and this is the affected hip which we are likely to operate right now. And here, if we notice it down, the overall external background is not very clear. It's all fluffy around. The femur head may be little visible around here, but definitely the intensity is not very good. Then we come down to the lesser trochanter as compared to the normal side. It has migrated up, neck is quite short over there, and it is also muffled in between, not very clear now. Overall, there is no inlet increase or an outlet increase, so we do not feel there is any lateral deformity right now. Here there is little rotational deformity which is visible, but otherwise it's not there. So the hip is relatively stiff, so we don't have much of the movement around the hip. Here what we are looking for is an offset which is a very standard offset for a hip joint. So we'll have to reconstruct the same offset. We have about a centimeter of shortening here which might manifest as a 1.5 centimeter in the real position. So we are looking for a hip shortened by 1.5 centimeter and with very short neck and a kind of stick. So we can now shift over to the from the CT scan. Is that okay?
Yes, sir.
So when we come over to the CT scan, as we go from up down to the level of the joint, we are able to see here lot of osteophytosis anteriorly. And this has changed our perspective of the hip because it looks very much retroverted right now. Lot of osteophytosis here in these images. I don't know how magnified they look at here because I don't have any idea about how you are looking at these X-rays, this CT scan. But there is a significant retroversal. So basic thing is we have to do lot of osteomatization of this anterior osteophytosis. So there is a lot of it. Rest of the walls are okay. The head definitely is necrotic over there. And this is what we have got in stock, and the superior part is relatively altered over there, but we still are able to feel the anterior and the posterior wall. So any specific query about the CT scan? And if no, then I am going to the patient. So here, am I okay at the table?
Sir, excuse me, sir, what is the age of the patient?
40 years.
40 years. So then what is the specific indication of dual mobility? If you can clarify a little bit.
Right now you know what is the indication of dual mobility, is introduction of dual mobility. Yes, it is a stiffer spine, we expect everything to be stiffer. So technically speaking, we do not have any specific point to make it dual mobility specific. The procedure we are doing this because this is a demonstration.
This is a first dual mobility surgery for this particular implant Smith and Nephew.
Yes. So
in India.
In India, this is the first dual mobility from Smith and Nephew which is coming out. So if that can be indication, then this is the indication. Okay. So right now this is the proximal side, this is distal, this side the front side and the back side, this is our marking. And here we have what is that light okay with it because we have decreased the light from the area. So inside we don't know how much the visibility because if we bring the light directly then it becomes totally whitened out. So is that okay right now?
The light is okay, but the camera is moving very fast. Now it's fine. Yeah.
Okay, that camera is still not
Yeah.
so that is still moving, I am not sure. Because I am looking at the image which is from the...
Little bit more focus can be done. A little bit more.
Because incidentally I am not able to see what you are seeing. Okay. So I cannot comment about that. Okay. Because that camera has only output down there to the hall. And in between, let me tell you, we have got our very well tailored team. Anesthetist is also our anesthetist for last 3 years back. So she was with us, Dr. Harleen here, with me in Fortis Hospital. Rest of the team, my people, Dr. Gaurav, Dr. Himanshu and Sandeep and Devendra, they are all with me here. So I am relatively more comfortable than the people who operated upon them in the morning. So can I start the surgery?
Sure, sir. Please do, sir.
Please do, sir.
Time out. So here is the greater trochanter, we are able to see, we have marked it out. So I am giving little bigger incision than the routine because of, so that I could be little clear in my demonstration. Can you give me a forceps?
There is no need of picture in picture, so can we remove that? Only single view is good enough, I guess.
Can we remove that is for the intermediate people to listen?
Sir, that image is actually for the other camera. So whichever you can see better, you can zoom in. So that's on one camera is mounted on the light, one is in the hand of the cameraman.
So are you using modified Gibsons or posterior Cochrane? Are you using an approach?
Standard posterior approach, a very classical kind of approach. Here you can see this is the greater trochanter, this is the lateralis, and here we have got the gluteus, here you can see it out. The medius, the maximus is already out, and here the fascia is taken out. You can see the interval between the medius and down there you are able to see the piriformis here. So I am picking up the piriformis. Can you just make it up? So if you can see it out, I don't know whether the light can show, but I am with the piriformis tendon here. This is a relatively escape, so because we are compromising on the light, so we can you rotate it? Does it rotate? No, just try to rotate it if it's possible to rotate. So I am cutting the piriformis along with the capsule over here. I am sorry there is an aberration in the camera if it is there, because I do not know what you are being shown. And the posterior side is not really, we don't have much of the osteophytosis on the posterior side. But here anteriorly there is a reasonable amount which I will wish first to take it out. There is one left out which I am trying to take it out. Once this is done, then one part of it will be over.
Sir, there is a question from Dr. Rajiv Sharma. Why don't we remove the osteophyte after the trial cup?
The question is, even for a proper centering of the femur also, you need to have a good spectrum of the basic thing. If it is a routine kind of a hip, you can always do that.
Right,
but
sir.
in this kind of a hip, where there is a lot of osteophytosis, let's clear out the extra part. Then we will do the reaming, then it is likely to be the proper reaming.
Right, sir.
Otherwise, the soft tissue will not permit the proper reamer position also. So now I have been able to take out everything from the anterior side. So I reposition these things again and see if there is still more tissue or not. Now I reposition this. So now I just want to show if it's visible to have a proper.
Sir.
Now is that visible?
Yes, sir, it is.
I'm trying to show it up so that we are able to see the whole kind of a distinct from as such. Still there is osteophytosis. As Dr. Rajiv said it, I have to again go, but this is the cross release anteriorly. There is still something pumping out the fragment.
Sir, any steps you have taken intraoperatively for checking limb length, sir? Any mark by the...
If you see, I had put this one and I had given this thing on this side also, a mark on that side also.
Okay, sir.
The osteoporosis which I had put at the ischial neck.
Right, sir.
So, what I wanted to show that right now I am clear of the major fragments around this area. Now I have to go to the center of it. So I am going into the center. So now I am trying to reach to the floor of this, over here and here. You can see how much medialization that we have to go in for. Yes, there is a small operator beater. So now I think it should be visible the inside floor also, the osteophytes here down there also. Is that visible? This medial osteophytes.
Yeah, they are visible now.
So I have to take them out and use the reaming for that. I think this thing also. But this is the medial osteophytes which I am now removing. So for the central osteophytes, right now I am going that lateral to go down to the floor. I have reached the floor now. Thereafter I will use angled reamers. Is the abdomen visible?
Yes, sir.
Okay, thank you. So here I am using this angle reamer which gives me the proper direction also. For the sternum face also. I have done the medial reaming, now I will be gradually increasing the size.
Sir, the first reamer that you used, the smaller size reamer, you went exactly vertically down into the floor, sir.
Yes, I have already gone down.
Yes, sir. And the second reamer was angulated as per your inclination.
Yes, that's right.
Sir, can you please, the first reamer, why was it vertically down? And it is supposed to be done vertically down, but what is the end point of that?
We need to reach the fovea of surface. And at the surface, we do not want to ream further. Now we go to the angle of inclination.
Thank you, sir.
And now I don't have to go midly. I have to go gradually increasing the size. Because the osteophytes is still there, it will be done once our initial work is done. कितना साइज है? 48? मेरे को लगता था आ गया। हाँ? 49 करके because it is not. 49 करके 50 करता है। Now I have reached there, and I think I am at 49, so I will be trialing with a 50 cup trial.
Sir, can you demonstrate the position of your trial? If you,
Can you see? Yes, I'll just show you. Now, can you see it?
Your finger, yeah.
I'm not sure whether you are able to see the version, but here you can find it out. This is the line. Is that visible?
Yeah.
This is the line of version, and this is the inclination here. And this trial has fitted very well. And now, as Dr. Rajiv has said it, we will define the this extra osteophytes like this now. And here you can see the tail also. I am inferiorly medial to tail. Is that okay?
Okay.
If you can see it out. That is the right inclination. It is parallel to tail and it is medial to tail as a standard case. Now I will be, so now I will be taking out osteophytes. Both anterior and posterior. Now, once this soft tissue has given us, so again, now starting from the superior side, because these all will be useful in a soft tissue balancing. So I have to take them out. The initial removal was to have a good access. Now coming to posterior side, give me move that.
Sir, can you please mention any tips or tricks to get concentric reaming rather than reaming on a particular place where we want the cup to be seated? Any tips that we ream in a particular version or inclination so that the entire asteroid gets concentrically reamed?
Tail remains still the best indicator except for the situations when there is a pelvic version in an open pelvic injury and these things are altered. Tail remains our standard. Remaining that we need to be medial to it and we need to be parallel to it as far as space is concerned. Is the question a little more? I mean, I don't know, I did not make it out.
Sir, fine, sir. Thank you, sir.
Thank you. I'm sorry if I'm not able to, because...
So basically what I wanted to know, sir, was that when we are reaming, sir, we are supposed to ream the whole of acetabulum and not only ream the posterior part or whatever part of the acetabulum where we want our desired cup position. shell position.
Basically, why I did not dream it beforehand, because initially the osteophytes may alter your entry, may alter your perception. So it's always safer to get into doing. Most of the hits we are doing do not have a lot of osteophytosis, so we are comfortable going straight forward to the limbing and then to find out what is osteophytosis. But when you are involved in such, as I showed you in the CT also, we need to now trim down all the osteophytosis so that we see a total face of the sternum. And now once we have got a face, we now are able to dream in the direction as we want, to be parallel and to be medial to the death.
Sir.
That is the reason it is, we are doing it again.
Sir, thank you, sir.
So now I have removed posterior one, now I am removing the anterior one which I had put osteotome on. पीछे So I'm just feeling for the amount of osteoporosis all around. So I feel I have not been able to take out most of the osteophytosis from surrounding areas. So I will now go for the cup placement, as I have got a reasonable amount of strength also, as well as I have got a reasonable amount of the good quality bone also, which is likely to get this. Just touching. So I am taking the trial out. Now give me focus. I thought I have already made it to come out. So now So now you can see it out the inside. I don't know whether I am able to show you inside or not. The kind of a bone we have, reasonably distinct, and the periphery is still quite reasonably okay. So we have got a strong periphery and relatively a very bleeding bone in the base of it, all around. So now I will get the cup which is 50 in size and its due mobility as is being proposed. Now this is from the Smith-Nephew system. As they teach, I do. Okay? I don't know. You give me one, I put it on whatever it is. I didn't listen, Dr. Rajput. Have you gone back to Chandigarh or is he still here?
Hi, Dr. Sen. Yes, Rakesh had to leave because of his flight.
Okay, that's what I'm worried about.
Yeah.
Because I wish he can lose it and stay with me for tonight, but then he has to make a plan.
Right.
no issues with the instrumentation yet. So we are making adjustments in the jugaad within our system. Because we use the rimming with the angle retractor and apply the cup also with the angle retractor, then we don't have, so we will be using the straight one. A little issue here, but let's do it out here and it not here.
Sir, your cup is same size as the last reamer or it's bigger than that?
Yes, this is one up.
For this system? For this system?
Yes, for this system. It can vary actually depending on the bone also. Yes, yes. So this is the positioning section. So if I can show you, you can see the positioning, the ligament, the version. I am directly at it, and here this one. So this is the pad, if it is visible, and this is the positioning. Good. Screw it up. Spike ಇದೆ ನಾ बीस के दो 20 के आने वाले
Which size cup has been used? 50?
50.
Okay.
Because it is a soft bone, so we could easily go with the 49 rimming and a 50 size cup.
Okay.
And because the peripheral strength is quite good, so we could have good stability, and as for screw fixation is concerned, I am putting classically the 3 screws.
3 screws. You usually put 3 screws or use 2 screws? Or do you recommend only 3 screws?
This is a relatively a soft bone, as I said earlier.
Okay.
So probably it may be wiser to have at least 3. If it is a very good quality bone, you can do with 2, and sometimes you can do without any.
Okay.
But this is inside it is very soft, and as you might remember the X-ray picture also, the bone is not of a very good quality over there. So I do not want that we should take a chance in this kind of a scenario. So I feel more comfortable using a proper stability in the 3 screw holes which are there in this cup.
Right, sir.
These people have got an excellent cup in the size of a multi-hole artery cup that is excellent otherwise. So we believe in that cup we are able to put screw in all directions, so that makes us very comfortable in a poor quality bone also.
Okay, sir.
So get the liner, dual mobility ready, and if possible take a photograph, first time being done. Right? So, once this is done, I am looking for a liner and photo area. First dual mobility of roller with nephew, first dual mobility. Getting implanted, हो गया इसका सेंटर के साथ है So it looks to be centered well. So now we take So now we'll be shifting toward femur. There is an issue about femur. I don't know whether you remember, but he had got a very wide canal of the femur. Not MC, you can say, though he's a young man, but his cortices are also very thinned out. So I don't know whether we'll be able to get uncemented or we'll have to shift to a cemented kind of a step. So we just look at the quality of the bone inside, whether we are getting the deception or it is really altered dimension. So here we are with forceps. So here I am going to the neck, whatever the neck was left, I am taking it out, and as we perceive, the entry will be somewhere posterolaterally, maybe by somewhere here. So I am just clearing out the tissue from this area. And now I am putting the rectangular. What I am seeing in this approach which makes me comfortable is the positioning of the leg on which I can decide the version, which is very typically, I am good in this position, so I am very clear about the version which I am able to create. So at this version, I can make the rectangular mark, and as it is expected to be in the posterior lateral part, so I am already there. And starting from that part in that rectangle, I am going in. I am looking at the quality of the bone. If it gives me stability, I will be happy putting uncemented. Right now it looks to be okay. So I am going with it. Yes.
Sir, is this a small stem or is it?
I'm just going stepwise. These are relatively smaller stems as compared to accurate. And their number goes up to 11 or 12. Now I am getting a reasonable purchase here. So my rotational scale is giving me reasonable amount of strength also. So I'll see how much I can gain. So I am measuring. Let me उसका फायदा नहीं होगा करने का इसकी रिडक्शन करेंगे हाँ ये देना so I try to get standard. So I am putting a trial with the neutral. So let us see that. So if you see the mark which we had made was this one here. This was the mark which we had made. Right now we are here. So we have already got about 1.5 centimeter, which I had made 10 otherwise. As far as this thing is concerned, this looks to be okay, this looks to be stable. So, and this is combined version also, we can show it up. So here it can be seen as a, this thing also as a combined version also, it can be seen about 40 degree of this thing also. So now we are dislocating it out. So now give me the scale. Now we can take it out also because right now it has become loose. So just take it out. Because we have already measured it. So we have got the length what we wanted. Scale now. So we have the length which we had over here was this is the length of the neck cut. I am looking at the neck cut because we need that calculation 4.6 or 4.7. So let's see how we fare with this stem now. If we got empty by now, no feedback.
And all are here looking for your architectural, wonderful surgical demonstration.
Now, because there is no two-way response, you always feel like that you are left alone.
Half of the hall is having the audience.
So my count, this is my, I think, 48 live surgical demonstration.
Great, sir.
Great.
But it's not always hit. Mostly either it is hip or it is acetabulum or it is pelvis. But this time it is hip, so I am happy with it. So right now, again going with the same setup, it is same, 4.6 you can see it out. So I am stopping at that point. Neutral, we will be putting a neutral one.
So when do you allow the weight bearing of the patient?
Can you repeat it please?
When do you allow the weight bearing in this patient?
Achha, weight bearing.
Yeah.
Yes. Actually, when you are okay with your cuff stability, you are okay with your stem stability, and your patient is also reasonably okay with understanding what is his weight bearing pattern, we start it from the post-op day. If the bone quality is relatively poor, if we are also uncertain about the stability, we may delay it as long as the partial weight bearing is concerned.
And what about this patient, sir? How do you feel that?
This patient, I am worried about the bone quality per se on the acetabulum side.
Okay.
Because the peripheral bit is okay, partial weight bearing will be starting maybe tomorrow.
Okay, sir.
Many times you get a very hard bone, and your stability, that hard bone is line to line cup, and then thereafter very good stability, and sometimes you don't feel that you should even put a screw also. Those are the situations. If you put weight bearing on the full weight bearing also, it doesn't matter. But this weight bearing pattern will definitely vary upon all these things. So it cannot be a one single thing.
Right, sir.
Again, our patient is our patient. It is not an English patient or an American patient. So many times we change our perceptions according to our patient profile. And this is that kind of a situation when you have to look at how our patient is likely to behave. So there is always a time taken at the trolley for preparation. After all, it is the first case of pure mobility. So just cleaning it out. Gauze is clean, gauze is.
Sir, what is the diameter of the femoral head?
It is 32. No, but it is a different. Sorry, the combined is 38. 38. So it is 38 combined, as we say.
The inner one is
Because otherwise, inside is 22.
22.
Yeah. So I have just checked it out. It looks to be okay. This thing also okay. The collection okay. This thing also okay. So I feel we are okay with it. Can you give me this thing, Nilen? Small osteophyte in the inferior part and middle. So this is what you are talking about.
Sir, any special precaution being taken while reducing the hip?
No, I don't think we will have to worry about it. The same thing is about weight bearing. That is to be taken, otherwise nothing special. Obviously the standard precautions will stay. Okay. So I am finishing my job. I don't do at my place also. So here also I am not going to apply this thing. I have got a very good team with me. So that will take care of it. Is it okay that if I leave?
Thank you, sir.
Thank you so much, sir.
Thanks a lot.
And congratulations for doing the congratulations for doing the first dual hip of the Smith and Nephew.
Real clapping needs.
Thanks a lot, Dr. Ramesh Sen, for such a nice presentation and the live demonstration of his very important skill. So we are now back to the same again, like hip talk. So can we have the chairperson of the or we can continue with this like this? I think we can continue. Yeah, that's right. That seems better. So next we have Dr. Rajesh Kapila. Can I request the people outside, can they come inside please? Piyush, can you please go out and just get the people in? Yeah. Can I request the people outside to, delegates outside to please come in? We have the next talk by Dr. Rajesh Kapila. Or can we have Dr. Rajiv Sharma, if he is available? Yes, left? Okay, fine. Then next we ought to have for then sir. Dr. Rajiv Sharma? Rajesh, please. No, sir, आपको ही बुला रहा था since I was trying to find you. So can we have a applaud for Dr. Rajesh Kapila is there with us? So please, sir.
Good afternoon, everyone. My sincere thanks to Dr. Shubhang for giving me this opportunity at last in the evening, late in the afternoon. So my talk will be on cementing techniques in THR. So why do a cemented THR? So what's the indication? There is enough evidence in the literature that cemented hips have an excellent implant longevity. They have a lower revision rate, they have a low periprosthetic fracture rate, and in fact no age group has found to benefited from uncemented hip vis-a-vis a cemented hip. And cemented cup is still the gold standard against which other cups they are compared. So without going into this debate of cemented versus uncemented, because it's a big topic, there are certain situations where definitely cemented cup has its advantages. So if there is a femoral deformity, you can simply change the version, you can change the length, you can change this version and offset without taking into consideration the bone. Simply the implant that thing can be altered, and thereby you can correct the limb and you can get a stable hip. Similarly, in very severely osteoporotic bones, and then those DOR type C type of bones where a wide metaphyseal region may not be suitable for an uncemented hip. And then wherever required, this antibiotic delivery system, you all know, cement is mainly used. So longevity of this cemented hips is basically dependent upon the technique you use for cementation. Bone cement per se is not an adhesive, it's not a glue that it will just attach this component to the bone. Basically it acts as a tight space filler, and fixation is achieved through a closed interlocking between irregular bone surfaces and the prosthesis. So various types of bone cements, you can use any of these bone cements. The only point is that surgeon should be aware of the qualities of the bone, of the cement he is using. Low viscosity, the time, the mixing time, the working time with the cement will give. So he should be clearly aware of the properties of the cement he is using. So this is the point in this bone cements. So coming on to the techniques of cement. So the first generation techniques with which we started our journey of replacement through this technique, where it was basically hand mixing of the cement, and in the doughy state it was put into the femoral canal and the canal was unplugged. Then the second generation, where a bone plug, a piece of bone we started putting a piece of bone in the canal to act as a canal restrictor, and then, but the mixing was still with the hand, though a cement gun we started using cement gun, and there was a good irrigation of the canal. Then came the third generation, where the vacuum mixing was added, and along with that, centralizer was also a part of preparation. So the first generation simply with the digital, coming on to second generation, use of canal restrictors and centralizers. So now we have started fourth generation cementing technique. So basic principles of fourth generation technique, cementing technique are pulsatile lavage of the femoral canal to remove all the debris, the blood or any fatty tissue that is present in the canal. So make the canal dry using an epinephrine soaked swabs, vacuum mixing of the cement so as to reduce the porosity, then retrograde cement introduction. Very important point is cement pressurization and use of stems, these centralizers, so as to have an even cement mantle. So this is the composition. It has a powder part and it has a liquid part. Powdered part is already a preformed polymer, polymethyl methacrylate, an initiator and accelerator. This opacifier is basically either a barium sulfate or zirconium dioxide, and antibiotics wherever required can be added to it, or they come with pre-mixed antibiotics. And the liquid phase is basically monomer methyl methacrylate and an activator which is attached to it, which is added to it. And this is once we do a mixing of the liquid with the powder form, so it has got, these are the phases. So these are the phases, the mixing and the sticky phase. During these phases we wait till the working phase starts. Working phase starts when it stops sticking to the gloved hand, the color, the luster becomes a little dull. So this is where the difference comes between various types of cements. So these low viscosity cements have a long mixing and waiting phase. On the other hand, these high viscosity, they have a very short mixing phase, this first mixing and the sticky phase, and the working phase starts pretty early. So you should be aware of these properties when you are using the type of cement, because different company people, they will bring different type of cement. So you should be pretty aware of that, when to start applying the cement. So technical aspects of good cementation: on the femoral sides, it's important to remove cancellous bone from the medial side of the neck, to have an adequate cement mantle of adequate thickness, adequate quantity and pressurization of cement, prevent stem motion while cement is hardening, and avoid blood or bone fragment mixing into the cement. So this is the radiological assessment of a well-cemented femoral stem, the Barrack classification, depending whether the radiolucent line is visible, less than 50%, 50 to 100 or more than 100%. So on the acetabulum side, the technical aspects are there should be an adequate coverage of the cup. You should remove all the cartilage and fibrous tissue. Again, cement pressurization and even distribution. Avoid movement of cup while cement is hardening. And this is the radiological assessment of a cemented cup, this Hodgkin's classification, when you have divided from lateral to medial side into 3 zones, and you see lucency in each zone, and that is how they are graded. So pressurization, so it basically makes the cement go into the trabecular bone. So this is very, very important aspect of any cementation technique. You can have digital pressurization or pressurized half-own. These pressurizers, they are available, which can be, both can be used. So acetabular pressurization. So in this, this is a pictorial showing how flange cup, they are a little better as far as pressurization is concerned, because if non-flange cup, you are pressurizing, the cement will immediately come out from the sides. While if you are using a flange cup, it will not allow cement to come out in large amount from the sides. So a flange cup is better. So starting with acetabular preparation. So the first step is your thorough removal of the labrum. So all the soft tissue and this should be removed. After that, proper curate and reaming of the acetabulum till you get a good bleeding bone. It's a normal preparation of the acetabulum. And you have to wash it. So Then you pack it with an epinephrine soaked rolled gauze so as to get a clean dry bone before cementation. So cement pressurization. So what we do is when the cement is in the doughy state, we make a bolus of cement and the cement is put, and pressurization, what I do is I do this digital pressurization. A sponge is put in the, this is how we do it. In a glove we pack a sponge and then we pressurize with our, so this is the method by how we pressurize the cement. So coming on to femurs, on the femoral side, again the first step is removal of soft tissue and broaching of the canal. So different, so during the tip here is that during each step of broaching, when a smaller broach, you take it out and put another one. Before that, you should irrigate and you should do a suction, which will not only clean the canal, but will also minimize chances of embolization. So once you have done with the broaching, then thorough lavage of the femoral canal with the pulse lavage system so as to remove any blood, debris of the bone or any other fatty tissue. So this is just a pictorial demonstration how an irrigation leads on to cleaning of the canal. After that, they put in a restrictor or a canal restrictor, which is put at a distance of about 1.5 to 2 centimeter distal to the tip of the femoral stem. Again, same thing, once your canal, you have already irrigated it, then it has to be made dry, and for that an epinephrine soaked rolled gauze is tightly packed in the canal. Along with that, we also put in a suction. We put in an infant feeding tube or some kind of tubing which is then attached to suction. This is with the help of Romodrape we have attached so that any blood or any other thing that can come out of it. Then pressurization of the cement. So this is, it is done in a retrograde manner, and we do pressurization with a finger. An important point here is that whatever cement you remove, you should not put it back in the canal. If at all you require, you can put the cement that is already present in the gun. And then you have to give a digital pressure. And then we start with the sister centralizer attached to the stem. The stem is put in proper alignment along the lateral margin with your thumb on the calcar. So it will give two things. One, it is giving pressurization, and it is also keeping your along this stem along the lateral wall. So this is how your X-ray will show if you have a good technique. So a well cemented pictures you will get on the X-rays. So this is one thing with which we are worried about the cement, that is the bone cement implantation syndrome, which is characterized by hypoxia, hypotension, some arrhythmias, increased peripheral vascular resistance or cardiac arrest. So basically there are various theories associated with it. It may be due to the methyl methacrylate release causing vasodilatation, microembolization of the fat, histamine release, complement activation. So these are some of the causes, and it can occur at various stages. It can occur during reaming of the femur, during acetabular cement implantation, femoral cement implantation, insertion of the prosthesis during joint reduction. However, if you go through various studies, the mortality due to cement, this BCIS, is not more than 0.01%. A very good preoperative optimization of any comorbidity to the patient, and during surgery, proper care normally takes care of the patient, and you do not see much of the mortality. So coming on to our conclusion, excellent survival of cemented hip is due to good cementing technique. So for femur, a viscous cement is inserted into dry, clean bone and pressurized. Pressurization is done before, during and after implant insertion. Cement restrictor and cement guns are essential for pressurized cementing. And for the acetabulum side, again, drill holes, large drill holes are made to maximize macro interlock. Cancellous graft is placed under the transverse ligament to prevent leak of cement. Flanged cup, as I had earlier shown you, for better pressurization, and spacer beads for uniform cement bundle and to avoid bottoming out. So thank you so much for your patient hearing. And I'm also thankful for my dear friend, Dr. Dilbans Pandey, for his valuable contribution in this talk, for making this talk. Thank you, sir. So that cement doesn't leak out from below while you are pressurizing, just to avoid cement getting out of it.
Wonderful talk.
Thank you, sir.
Thanks a lot, Dr. Rajesh Kapla, for a very detailed talk. Can we have next Dr. Rajiv Sharma with the coxofemoral bypass? Can you put our hands together to welcome Dr. Rajiv Sharma? Has come all the way from Delhi to our place. So let's give him a warm welcome. Class, please.
Thank you so much. Dr. Shubhang has given it a very interesting turn of the words. It is not like a cardiac bypass or something similar, but it's a nice word to this special surgery. Is it there? No. Yes. It's a well-known term now. Okay, we'll just wait for a few seconds. Right. So it's a coxofemoral bypass that I've been asked to speak on, and it'll be a brief talk. And coxofemoral bypass is basically talked about for the trochanteric fractures, especially the comminuted trochanteric fractures, unstable fractures. And because these fractures, they usually have a failure modality. What we see here, the fixation, and then many a times these osteoporotic bones are not able to hold the implant. And if the patient starts walking, that's how it happens, that the osteoporotic bone, the implant, the dynamic hip screw usually cuts out. Or even if you do a very good fixation, medialization, the implant breakage may happen, because that's also major issue. If you want to keep these patients on the bed and you do not mobilize them soon enough, then also they have lots of skin issues like the bed sores, which starts within 48 hours itself. So these patients, they need to move, and that is very, very important. Why the fixations fail? Usually because the screw, it moves in the weak cancellous bone, proximal femur. It can have the implant can break because the fracture is unstable and the bone is weak. So coxofemoral bypass is an indication for patients above 75 years, severe osteoporotic patients, because it provides an immediate mobilization. That's what you see, a patient, 84-year-old male patient, having a comminuted trochanteric fracture. It's a cementing of the implant. And what is very important is fixing the greater and lesser trochanters in a proper way, and that is what it is. That if you bring them back to normal, then they work very well, and these patients can be mobilized the next day itself. And this is a very easy technique, even in the hands of the less experienced surgeons. But they need to understand how to how to have the right orientation of the femoral component, how to have the correct soft tissue tensioning, and also the mobilization and fixation of the tuberosity, the greater and lesser trochanters. That's what you see, the final X-ray of this patient, and patients can be mobilized the next day itself. Another 80-year-old patient, fixation, and you can you can allow the patient to bear weight the next day itself, and that itself is a major thing if this patient can walk the next day. Another patient, 72-year, operated, and patient is able to walk with the help of walker. And how much the patient can walk, we leave it to the patient. Like these patients are old patients, they have to keep walking with the support, and sometimes they need support for a very long time. Failed intertrochanteric fractures in a younger patient, younger than 75, like this patient who had a reverse oblique fracture, fixation done, and then this patient was operated for the total hip because he is 65. That's what you see. The same technique of fixation of the trochanter lesser and great trochanter, closer, and you see that's the X-ray 1 month post-operative. That's the patient 1 year post-operative, and that's the patient 2.5 years, and at 12 years. So it is not so that these are the patients who can, as long as their life is, probably he will not need another surgery for this problem, and that is probably what is the main reason. Another patient, 68-year-old male, cemented stem and cementless cup. Another patient, severely osteoporotic patient. The complications are protrusio, because we should not forget that every surgery may have issues, and you need to understand what are the issues. Protrusio is a major issue, dislocation of the cup. We'll discuss a few in brief. Failure of the trochanteric fixation, aseptic loosening, and infection, of course, that is the worst thing for all orthopedic surgeries. 64-year-old patient, severe osteoporosis, right intertrochanteric fracture, and very interesting follow-up of this patient, fixed very well. They started walking and kept walking, but at 6 years you see that the implant has broken the medial wall. So what it is important is that these patients should be followed. They should not be lost to follow-up at all. Another very interesting follow-up patient, 80-year-old male, had a fall on the floor, had a fracture of the left trochanter. Of course, this patient was operated by bipolar hip arthroplasty, fixed, and he was allowed to walk. And this patient also had a significant osteoarthritis of the knees. Now this patient had a fall again, month after the surgery. It was relocated, trochanter fixed again, but this patient had 2 more falls. And that's how the big problem that what is to be done. A simple approach. After the 3rd dislocation, we use the cemented constrained liner, and this made things all right, but this patient had a fall again, and probably the support at home was not enough, or because of the age, he had a fracture on the right side. So this time we did not wait, and other side we did the cemented constrained liner and the cemented bipolar, so that the patient does not come back for another surgery. And then this patient was able to go on in his life very easily, very well. Of course, he is not able to walk because of the knee arthritis. So conclusion is, coxofemoral bypass is an excellent method to treat elderly osteoporotic patients with intertrochanteric fractures. Care must be taken for the right choice of the implant, bipolar hip arthroplasty for patients above 75, and total hip for patients between 65 to 75. And all the patients less than 65, of course, the fixation, the osteosynthesis is the right approach. Technique of fracture fixation is very important. Thank you so much. Yes.
Because I saw you using a small stem, small cemented stem, uncemented stem, uncemented stem. So considering that most of these cases are between, yes, we saw small stems and uncemented stem in patient less than 70 years. And above than 70, they were mostly cemented ones. But our perception at one time used to be that if you are putting a cemented in a trochanteric fracture, it must be a long stem one.
Not necessarily, because if you have the trochanter is, the fracture is not subtrochanteric, then probably it is enough. The normal strength is enough.
Okay.
Because these patients, most of these patients are very severely osteoporotic. They have multiple other issues also. At 78, 80 years, you do not expect more than 10 to 15 years life survival. So with that, this functions very well.
Because their functional abilities are limited. So
and as long as the cementless is concerned, now we have a significant number of patients, elderly patients, cementless femoral stem functions very well, especially the coral type of a stem.
No, you have used solution. What about Wagner type? Solution is a cylindrical, Wagner is a conical. So solution, Wagner or readapt?
This solution stem was put some 20 years back.
They were old.
So that time it was very popular. It was the in thing, right? And it only became known to us later that solution is not a solution. It breaks. We have removed many broken solution stems. It's a major issue. But I agree, in today's time, most of it is the Indian bipolar implants. You need not go for a long stem, unless the fracture is subtrochanteric. If you put this bipolar, it should be perfectly fine. If the patient is younger, then I'll prefer a total hip rather than a bipolar, because as we know, this patient, the one that I showed, now this patient is almost 20-year follow-up now, and he's still okay. He's close to 80, but I think that's very, very important that the longevity of the patient should be kept in mind.
So how do you decide that this patient will go for arthroplasty as an option, or it can still be fixed?
If it is osteoporotic, I can see that this is a badly comminuted fracture, and especially the comminution is so much that you are not able to fix well. I give the option to the patient. If we fix it with the dynamic hip screw or condylar blade plate or a proximal femoral locking nail, now you have a chance of non-union. Second, you will not be able to be walking the next day, which is the bigger thing. You will be on the bed for at least a period of a month or 3 weeks. Then if the patient chooses that no, he wants one surgery or the family wants one surgery, then I'll go for a bipolar. If not, then I'll go for a fixation. Right, because one has to be very judicious in advising the patient, because in today's time I don't want that patient should say that you didn't tell me earlier, otherwise I would have got the surgery done at that time. Yeah.
Thank you.
Thank you, Natesan. Thank you. Thank you so much. Yeah.
So good evening again. And with your permission, I think we have only faculty left now. So we should skip the master panel. Dr. Sen, sir. We can skip the master panel because...
maybe wapis pahunch rahe.
Right. So I would just like to invite Dr. Sandeep Goyal, my partner and head of neurology at NHS, to say a word of thanks.
Good evening, everybody. A big day, long day, and a busy day, especially Sunday. I really want to thank all the faculty who came from far-flung places, who had been here for more than a day with us. I really thank them. I especially thank Dr. Ramesh Sen, Dr. Naresh Vaidya, Dr. Rajiv Sharma, Dr. Nilen Shah, Dr. Rakesh Rajput, Dr. Manuj Wadhwa, Dr. Avtar Singh, Dr. Sudhir Garg, Rajneesh, Dr. Abdul Ghani, Dr. Pankaj Mahindra, Colonel Satish, Dr. Hariom Aggarwal, Dr. Bobby John, Dr. Rajesh Kapila, Dr. Sanjeev, and Dr. Colonel Zafar. Thank you, sir, for taking your precious time to be here and enlightening us. Thank you. And with this, I especially thank my whole orthopedic team, especially the main organizer, Dr. Shubhang, Dr. Pratik, and Dr. Nitish, especially, who had been really working since last 1 or 2 months to make it happen. It's very difficult to select the patients, to keep them, make them go for live surgery. It's really great. I thank my all ground staff, especially Mr. J. Sharma, my all OPD attendants, all my IT team, and my HR team, who have really made the things happen. Thank you. Here again, I really thank my marketing team, who has really worked day and night, especially Mr. Jaswinder, Arthi, the reception team, who have made the things happen. Thank you.
So I thank all the delegates and my entire team. I think they can be on the dais, my entire organizing team. And let's have a round of applause for all these people. And I thank Mr. Soni, who has done very well in this camera setup and audio and visual setup. And Bandna, Mehak, Aarti, Jennifer, Baljit, Rajni. If I'm missing somebody, kindly excuse me. Manpreet, Manuj, everybody, I think they have done so well. So everything, as they say, that every good thing comes to an end. So we are also at the closing of the ceremony. So thanks a lot, sir. I thank Smith and Nephew team also. Jaswinder, I think you did a really great job. So your entire team, I am not able to recollect the name of everybody, but kindly give my word of thanks for them also. Mr. Jalandhar, and especially our Rakesh Verma, I think who is on the last day with us. He is flying after that. And our lighting person, Suraj. Dr. Nitish is always very, very dear to us, and he has done so well, I think. And Dr. Pratik also, the entire ortho team of NHS. We had our hospitality team also of Priya, Sonia and Sandeep, and plus the maintenance team of maintenance team of Praveen and his entire team, plus the housekeeping team. They kept everything clean and shining. So thanks a lot to each and everyone for contributing. And our caterer Shiva also. Can I call all the lovely ladies with black dresses, black sarees to be on the dais? Pardon? Yeah, we'll like to have a good photo session. We'll wait for you, sir. We'll wait for you, sir. We'll wait for you. Yeah. Can I ask somebody to call Aarti also? Aarti and her team.